Good morning and welcome to the second day of the 5th International Conference of Mass Gathering Medicine. We are thrilled to have you here for another day of insightful discussions, learning, and collaboration. As we commence our first session on infection prevention and control, we are privileged to have two distinguished moderators leading the way. Please join me in welcoming Dr. Salah Al-Awaidi and Dr. Majid Al-Thaqafi. Dr. Salah, he is a communicable disease advisor in Health Affairs Ministry of Health, Muscat, Oman. Dr. Majid Al-Thaqafi, he is a consultant and assistant professor of preventive medicine, public health, and epidemiology. He is also the chairman of the Saudi Society of Public Health. Welcome, and over to you, doctors.
May I start? Okay. Bismillah ar-Rahman ar-Rahim. And good morning, everybody. Wow. I think on behalf of myself and dear colleague Dr. Majid, we would like to welcome you all on the second day of this event, and hope you're going to have a very fruitful and a very enjoyable with a very eminent speaker that we are having today in our this session. Indeed, true pleasure to be here in our second home. Particularly myself, I have a lot of memories that when I used to study in this beautiful city for years and years. And I would like also to pass my heartfelt to Dr. Anas for inviting us in this very eminent Congress. Well, I would like to start saying that yesterday we have heard a few words from Professor Hanan, and I would like to echo what she said it very clearly and very obviously with respect to antimicrobial resistance. And what she said that this is a problem of antimicrobial resistance is a hidden and unrecognizable by everybody and most of the global country. I think the notion that she alluded yesterday was very right. I really I like when she says so. So I totally agree with what she said it yesterday. And if we are thinking with respect to antimicrobial resistance, there are many areas and many directions that countries already embark into in order to minimize the impact on our healthcare institution as a whole. And today we have very strong and very eminent speakers, as you could see them in front of you, where they are going to elaborate a lot of issues with respect to antimicrobial resistance and beyond that. And we are going to have a colleague from CDC, Dr. Douglas Hatch, a colleague from Saudi Arabia, Dr. Ali Barak, and from UAE, Dr. Hanan Al-Suwaidi, and Dr. Jafar Tawfiq, very well known to all of us. And finally, a friend and colleague, Dr. Majid Al-Shamrani. Thank you very much for being here, and we are really looking forward to hear from you, your experiences, and a lot of, to go beyond and beyond what you have in your mind with respect to antimicrobial resistance. So if I may start with our first speaker is Dr. Douglas Hatch. You're going to be the first one. And if I may introduce yourself in a few words, and as you could see, your bio is a very extensive and have a lot of experience. Thank you so much for being here. Well, Dr. Hatch is a physician with postdoctoral training in infectious diseases, preventive medicine, public health, epidemiology. I think you have already exhausted all the field of medicine. And he worked as a medical officer at the US for the last 20 years, completing the Epidemic Intelligence Service and Preventive Medicine Residency Program. He served as a CDC long-term advisor, but he is very well in terms of experience in the antimicrobial resistance, and he focused particularly after the COVID-19. We would like to welcome you, and we're really happy to, the floor is yours now, and I really appreciate to keep the timing. We have 15 minutes, if you don't mind, please. Please, go ahead. Yes, please.
Okay, thanks so much. Assalamu alaikum. Thank you very much for that generous introduction. When you summarize that I have a lot of experience, it means I'm old. So all of us as we get older have more experience. But it's a pleasure to be here. As I was saying yesterday, I'm originally from the Boston area on the east coast of the US, and had worked in Samoa prior to the COVID pandemic in the Pacific, and was invited to work with Hawaii for the last couple of years on COVID-19 response. So like many of you in this room, we've been occupied in every way, shape, and form responding to COVID. And of course, we would also be called by hospitals or long-term care facilities with elderly people because they had a multi-drug resistant organism. So we're trying to deal with COVID and overwhelmed, understaffed, working hard, and then there would be questions about what about infection prevention and control, and how do we deal with this multi-drug resistant organism? So I hope everyone would agree that's here this morning that we would be, or at least we would agree that it's our families that go into hospitals when they're sick. So it's not just an anonymous person. These are our children, our parents, our colleagues, our friends, and they expect when they go into the hospital, they're going to have good infection prevention and control. So it's a topic that touches everyone, and I think it's really quite exciting area. So hopefully I'll be able to help you understand that, and we can agree on some of these issues this morning. So it's fairly clear that healthcare-associated infections remain a major cause of preventable illness and death. There's a lot of elements of infection prevention and control, but I think one of the more interesting elements is it's both patient safety and health worker safety. So it's kind of an interesting area, and there's two different aspects that are equally important. We don't want the patients to get ill unnecessarily, and we also don't want the health workers to get ill because we need them. It's also a reflection of patient care quality, and so therefore, even at the clinic level or the long-term care facility level, every interaction with a patient is an opportunity to prevent infection. So the other thing that I find quite exciting is there's a lot of training materials, really high-quality training materials, interactive, different modalities, different media that are available. So even in the most remote areas, healthcare workers can have access to injection safety and other issues that they really haven't received training on in a long time. So my slides are not advancing. Is there something I need to do here? Could I have the next slide? It's like magic. Yeah, if I have trouble with my informatics, I call over my son and say, hey, something wrong here. Can you help me with that? So what are the core components? I'll mention some of them here. First is hand washing as per the photo. What's the proper method for hand hygiene? Injection safety, personal protective equipment, cleaning and disinfection. And what are some examples of healthcare-associated infections that would be important to monitor? And I've listed some of them here: sepsis, catheter-associated urinary tract infection, or we say CAUTI, central line bloodstream infections, or CLABSI, surgical site infections, ventilator-associated pneumonia, and of course, antimicrobial resistance like multi-drug resistant staph. There's other issues involved as well for respiratory diseases. There's how is the air filtered? How many air exchanges do we have? What type of system is it? Is it HEPA filters, et cetera? The whole issue of diagnostic tests. And I think with COVID, we've certainly agreed that the advent of rapid testing has really helped a lot rather than waiting for several days for a PCR. So I don't know if we'll have time to talk about all of that, but there's certainly some very interesting modalities where you can look at bacteria and know within a couple hours at the latest what the bacteria are, what's the species, and what's the drug resistance pattern for that organism. Then there's policies like isolation, respiratory isolation, vaccination. What do we require of our healthcare workers? And then, of course, as we mentioned before, there's trainers. I'm going to need my colleague to join me here for every slide. I'm not having any luck. There we go. It's like a delay of 10 seconds or something. I'll try. I'll keep trying. Sorry. As we spoke yesterday about looking at global health security, how important is this and how has it changed over time? And I have here a list of, from the National Library of Medicine, what's the number of peer review publications from 1939, to almost 100 years, to today's date. And you can see there might be 1 or 2 articles up until the 1970s. And then in 2023, 2021, we're up to almost 200 articles a year on infection prevention and control. All right, and just to give WHO credit, because I know they're working in a very serious way in trying to improve this issue, and from their guidelines, which I'm quoting here, the burden of healthcare-associated infections that up to 7% of patients in developed countries and 10% in developing countries will acquire at least one healthcare-associated infection, and that death occurs in approximately 10% of affected patients. European estimates showed that greater than 4 million patients are affected, approximately 4.5 million episodes. HEI annually results in 16 million days of hospitalization in addition to what was expected otherwise, and 37,000 attributable deaths. In the United States, it occurs in approximately 1.7 million patients, representing a prevalence of 4.5% and perhaps as high as 100,000 deaths. And just to look at COVID alone, and we know infection prevention and control is important, this is just long-term care facilities in the United States, that those elderly residents of long-term care facilities, there were a total of 1.7 million cases and 168,000 deaths. In addition, there were a similar number, 1.7 million, of cases amongst the staff. And I don't know the numbers this week, but over 2,500 health worker deaths from COVID. So we understand it's a huge problem. And in addition to the COVID issue, you've got the regular multi-drug resistant organisms that those patients are getting exposed to. I just want to introduce the idea that in the States, CMS has data, and that data is available to the public. And I just give you a sort of a quick look at part of the database. And as you can see, starting from the left, that their vaccination data for every line being a long-term care facility, something like 35,000 or 40,000 facilities. So there's percentage of residents in those patients in those long-term care facilities. What's the vaccination rate? Health worker, what's the vaccination rate? How many confirmed cases have there been in the week? How many confirmed cases per year total? Basically, anyone can download that data and look at it carefully, but as most of you know, you really kind of have to be trained to download a database with millions of records and look carefully for the health facility. But the idea would be there's been a battle between facilities and government, and people want to know what is the rate of healthcare-associated infection in that hospital. How well are the people vaccinated? And although the data is available, it's a challenge to get the data if you're the public. So we also have the healthcare-associated infections tracking system. I'm not at CDC any longer. I was there for about 20 years. But I'll try and summarize as best I can. It's basically tracking healthcare-associated systems by facility, by health department, by state, by region, and by nation. So it's tracking, as I said before, about 38,000 facilities. It provides a benchmark. So in other words, if you're a hospital with 500 beds, your hospital is compared to other hospitals with 500 beds. And it will give you a standardized incidence ratio about how well you're doing. It's a way to monitor progress. So if we're looking for a 10% improvement in MRSA transmission, then you will have a standard to compare how well did you do that year, and was it significantly better than last year or significantly worse. And I'm showing here that healthcare-associated infections continued to increase during the second year of COVID. That would be 2021. And so you've got ventilator-associated events would be the top line, MRSA bacteremia, bloodstream infection, urinary tract infection, and the baseline is at 1, right? So it's a standardized incidence ratio. But as you can see, there was a 60% increase in ventilator-associated pneumonia and other events. So even though we were working hard on infection prevention and control, I think it's pretty good evidence that at least in some locations and certain hospitals, the system was overwhelmed and they saw increased rates both related to COVID and independent of COVID. So what kind of data is tracked? And I've listed them here. I don't need to read them all, but acute care hospital, ambulatory surgery centers, long-term care hospitals, long-term care facilities with elderly, et cetera. Okay, so the estimate, sorry. So in the United States, approximately 2.8 million antimicrobial resistance infections are occurring each year, and a death of a minimum of 35,000 people. And I've put here and in the references a couple of really excellent CDC summaries of what's going on with respect to the impact of COVID-19 on antimicrobial resistance and antimicrobial resistance in the US. So just a quick summary, bacteria and fungi do not have to be resistant to every antibiotic or antifungal to be dangerous. Resistance to even a single antibiotic may mean serious problems, and use of second or third line treatments or antibiotics, antimicrobials, can cause serious side effects, organ failure, prolonged care, sometimes for months. There's many medical advantages depending on the ability to fight of infection. So there's high-risk patients that need those antibiotics and need them to be effective against, and that includes people with joint replacements, organ transplants, cancer, and other issues, chronic diseases. And then, of course, the real issue below, some infections really have no treatment options. So in the US, there are what we call regional laboratories that serve as reference laboratories for antimicrobial resistance, and there's also a global laboratory network. And WHO sponsors some of these reference laboratories to specialize in specific bacteria and diseases, and the list is available online amongst your references. So the only thing I would like to bring up before closing was just that there's a lot of innovative resources available for infection prevention and control training, and I've got some of them here just randomly, insertion procedures for central lines, caring for intravenous lines, proper insertion of catheters, and then of course there's evidence for standards that are published and applicable to health facilities. So flyers are available on the CDC website. There's certainly, there's probably 50 issues under just standard precautions, and users can find some really useful information here. And so I've listed these for you, and the references are at the end of the talk. So it's some things just to sort of consider, that case investigations of multi-drug resistant organisms, you need a team. It's going to include laboratory, it will include epidemiologists, it will include people working in medical records, clinicians participating. There's the key elements that you want to look at when you do your investigation. We certainly did point prevalence surveys to look at, if we've got a multi-drug resistant organism, what's the evidence that it's either spreading to other patients or is actively spreading in the time of the investigation amongst healthcare workers. We've also conducted some anonymous online surveys to identify gaps in health worker knowledge, skills, and competencies. and use that information to try and tailor training to whatever that region or hospital's gaps are. And then the idea that there's certainly grants available that you can design online. I think in Hawaii we had online training in Chinese, Japanese, English, Spanish, Tagalog, probably a dozen different languages, so that, which is helpful if the regional language is different.
2 minutes, please.
And then just for the final statement, there is a Project First line that is available, and some really excellent, short, interactive videos that deal with injection safety and infection prevention and control. So I'd encourage you to have a look at that if you're interested in this field, and certainly useful for infection prevention and control training. I'll finish with those references, and thank you very much.
Thank you very much, Dr. Douglas, for your excellent presentation, comprehensive regarding some of the initiatives and some of ideas that used during COVID era, such as the training and tracking system. And please, if you have any questions, we'll keep this question at Q&A. So please prepare your questions at that time. So we're going to the second speaker, Dr. Ail Barrak. Dr. Ail Barrak is a consultant in internal medicine and infection disease at Prince Sultan Military Medical City, Directorate General Assistance for Health Affairs, Health Services Directorate, Ministry of Defense at the Kingdom of Saudi Arabia. Dr. Barrak obtained his diploma in internal medicine, American Board of Internal Medicine, fellow with the Royal College of Physicians of Canada Internal Medicine, awarded a special competence in infection disease from the Royal College of Physicians of Canada, and diploma in tropical medicine and preventive medicine. Dr. Barrak was appointed the General Directorate of the Saudi Center for Disease Control at Ministry of Health, and also a member of the GCC Advisory Board for Infection Control since 2019. Dr. Barrak also published over 40 articles in various peer-reviewed medical journals, and is currently associate editor of Saudi Medical Journal. So we would like to welcome in his talk regarding the infection control practice and during the mass gathering. Welcome, Dr. Ali.
Thank you, Dr. Majid, and thank you, Dr. Douglas, for giving me the stage for talking about infection control and prioritizing some of the elements of infection control that is important for mass gathering. And thank you for the organizing committee to ask me to talk today about the mass gathering infection control issues. I will be going over why mass gathering is a risk for communicable disease spread, and also the characteristic of mass gathering that represent public health risk, step in mass gathering risk assessment, and components of management and surveillance and response, which is the triad of the response to communicable disease. So why mass gathering is of importance? There is a political attention that is being given to populations that are already that is gathered either because of their religious or their importance, or like in refugees camps, or in sometimes in military movement, when there is a lot of people are gathered in areas where they are exposed to certain infections because of their location or because of their gathering and diversity of these population that they come to contact with the resident or contact with other population. At the same time, there are people who are importing or exporting the disease from these mass gathering, i.e. bringing certain infections that could be spread, or taking these infections from this gathering to other places around the world, like what we see sometimes from Hajj. Historically from cholera, and 20 years ago it was meningitis. Epidemic-borne disease is also common in this gathering, and there are different behavior of population that they are gathered because of their backgrounds, culture, or behavior with their health. Environment conditions also affect the mass gathering, either because of the heat or because of the cold, and certain infections that are common in cold, like the respiratory diseases. Vector also that are that are localized in these areas might also contribute to the mass gathering communicable disease spread. So mass gathering requiring excellent infection control because there is a large number of people that are coming into close contact. They are either body to body, or because of respiratory, or because of their spread with their hands of the certain infections. These populations have diverse immunological status, i.e. some of them elderly, some of them are very young, depending on the population. Also, some of the population are taking some medication that lower their status, or they come with chronic disease that lower their immunity, like diabetes, like cancer, like being on immunosuppression. Specific practice that are carried in certain populations, like utilizing some of the narcotics or drinks, or some issues that are with the religious, with shaving and exposing to blood-borne diseases, and potential limited access to high quality food and water supply, make some shortcuts of food that are being handled or produced in unhygienic way. The main risk is usually in these mass gathering is respiratory illnesses or respiratory pathogens that are spread between these population, and also gastrointestinal disease that are because of the water and food hygiene. The focus of infection control practice should be to prevent the measures before the event by assessing the need for the vaccination for those respiratory illnesses, or by improving the handling of water and food. At the same time, making sure that those who are attendees to the event have been vaccinated and educated about how to prevent infection transmission between them and between their clients. And also, we don't forget the country residents who are residing in these areas, like what happened in the holy sites or in the events of that is hosting the population. Mass gathering is usually either spontaneous or planned. We talk about spontaneous sometimes if it is unplanned, like in refugee camps or gatherings of troops because of a need in that areas. Or we talked about planned, like what happened in Hajj, where it is recurrent in the same place, or in like the Olympics, where they happen at different places around the world. So the core areas that should be considered in mass gathering preparedness is the risk assessment of these events and the risk of infection or communicable disease. At the same time, the surveillance that should be in place to detect and also to respond to these events. The risk should be assessed in what might happen during the event itself, because of the timing and because of the location and because of the type of population that are attending. And also the surveillance should be utilizing the existing medical infrastructure in that region, have a good laboratory capacity to detect and to diagnose, and develop electronic or paper-based surveillance activities to report these activities in a communication to reach to the right people in the front lines. And use information technology to show the heat map of these sites, and also intervene in controlling this disease. At the same time, responding when there is a disease outbreak at a timely manner. We'll talk first about the risk assessment. Risk assessment for the mass gathering, the type, is it sport or religious or politic? The duration, it is 1 day or take more than a month, or days or weeks. Activity level, the people are sitting or being exhausted because of walking and standing. Also, the occurrence of them is recurrent or single. At the same time, for the environmental season, the participant characteristic, if they are from local or they're coming from different parts of the world, and these parts of the world, are they at risk of transmitting disease from their sites? Density of participation, having high density in certain areas, open or closed, and the participant health status. They are a young population, elderly, pregnant, or immunocompromised. The venue characteristic, is it indoor or outdoor, the use of narcotics or alcohol, the presence of the first aid stations and their distributions around the area, and the catering, are they being professionally from sites that are health certified or not, or the self-catering which carry high risk for transmission of the foodborne diseases. Hygienic and sanitation is also very important for the water and for the use of washing sites. So the chain of infection is usually that infection is coming from microbes, either the bacterial, fungal, or viruses, and then transmitted coming from a reservoir or portal of exit of that infection, either from respiratory or from the GI, and where the case could be getting from, either from coming very close to the population or being exposed to infection. At the same time, how they are likely to pass it to the other populations by having susceptible hosts, knowing their port of entry and mode of transmissions. So to prevent the spread of infection, we need to break this chain and the link between these circle. This is an assessment of influenza. Is it being transmitted to be reduced? Is the transmission reduced in mass gathering or not? This is a review of 24 paper in mass gathering, varying size, have 9 observational, 9 outbreaks, and 4 event report. Found some of the evidence that there is evidence to suggest that event duration and crowdness is associated with transmission of influenza, and possibly type of venue, either indoor or outdoor. When they looked into more of these data, they showed that these mass gathering could seed new strains in areas. And when they applied for 2009, they were looking into when there is the avian, so when there is the swine flu, H1N1, at that time they were looking into these kind of activity, and what they found is that the restricting of mass gathering and also social distancing has reduced the transmission. But when they restricting the mass gathering itself alone, it did not affect the transmission of the influenza transmission in these mass gathering. So the basic principle for infection control is usually 10 items. The most important in mass gathering is to pay attention to the hand hygiene, respiratory hygiene, and the cough etiquette, and use of personal protective equipment, and occupation safety for those who are working with this population. Hajj is an example for a recurrent mass gathering events. We had worked with our team in 2003 to look into the assessment of knowledge, attitude, and practice among healthcare workers that happen in Hajj season. We looked into 392 healthcare workers. Half of them are doctors and half of them are nurses. 80% who had worked in hospital continuously, and 19% of them had been coming from primary care centers. Of them, only 41% of them are coming from the region of Mecca itself. But 60% of them were coming from different regions of the kingdom, with their backgrounds, attitude, and knowledge, and practice, and infection control. When we did the questionnaire for them, we found that 81 of them correctly answered 5 out of 11 of their knowledge statement, and we found that 60% of them scored at least 4 out of 7 of attitude statement. The rest of the three areas that they were asked about their attitude, they were unacceptable response. Nurses, as usually, do better than doctors in their knowledge and attitude, and the variable compliance to hospital infection control is also, there was an issue with them with the strict and near strict adherence. The conclusion that training of healthcare workers is important for these mass gathering to be done early on and when they joining the event, and making sure that they are compliant, and also at the same time had improved their knowledge for infection control.
3 minutes.
Thank you.
Dr. Ali.
For the COVID pandemic, as an example, importance of trained and compliant staff. I will show you one study from a country where they looked into around 16 health facilities. 5 of them are nursing home. They found that in at the end of the 2020-21, there was an increase of Candida aureus, which is very nasty, resistant Candida infection that is happening in their units. And one of the major explanation of them is that the short staff that they have to utilize staff that are coming from primary care centers and also have worked inside the hospital, where they were not aware of how the transmission is to be prevented. With this, there was an increase of Candida aureus, and this has been shown in different models around the world. And one of them, Dr. Douglas, has shown that there was an increase of hospital infection during the late 2021 period after COVID. So what we did in Hajj, we had a questionnaire, an audit form that we had evaluated the impact of annual review of infection control practice in hospital in Mecca from 2003 to 2006, over 4 years. And we had this standardized checklist audit, and we went through the hospital for 10 days, moving from one hospital to another, and also checking on their elements of the infection control. There were deficiency of infection control committee in some of these hospitals. There was no infection control units. Some of them had issues with infection control education, and also the surveillance system in charge of staff. We had evaluated this hospital over 4 years, and we have shown that there is an increase of 43%. Some of the hospitals have went from 20 to 93% of improvement of the infection control by this audit tool, and feeding the information to this hospital to improve the compliance and also to improve the utilization of infection control. So to minimize the risk of disease transmission, we had to protect the health of the attendees and broader population. To do a pre-event planning include risk assessment, developing tailored comprehensive infection prevention control and plans, and establish a multidisciplinary team to work with the local area and also with other stakeholders in the provision of mass gathering health. When we go to the surveillance, there is an ongoing surveillance. The public health surveillance is an ongoing systemic collection, analysis, and interpretation of the outcome of specific data, and use this in planning and also implementing and evaluation of public health practice. It is usually a clinical survey that is data coming from the EMTs or the clinics or from the wards, or pharmaceutical utilization, laboratory data, and mortality. The most important is to have it in the right time, and the most being used is the syndromic surveillance. Syndromic surveillance is giving you a bypass to the lab to pick up on some issues of symptomatic or signs that are happening at different level of the healthcare, either at the emergency, at the EMTs, the clinics, or the hospitals, and looking into these data and collecting them and drive an information about the behavior of health. The most important thing is to make sure that there is communications between these stakeholders, and also the information is being transmitted to the right people. And pre-event preparation for this surveillance is very, very important to know the definitions and how to transmit these data. Enduring is making sure that right people at the right time, at the right place receive this information. And post-event, making sure that it is being transmitted to either those mass gathering population that they're going back, to make sure that this information is being followed up.
Time is over.
Okay, just one slide more. So the last one is about the response to the communicable disease, is to have a balance between the benefit and population of the population and the individual, making sure these measures stop the spread by early diagnosis, notification, isolation, but most important, to make sure that it does not disrupt the mass gathering, and also not to lead restriction of individual movement and to prevent transmissions. So this measure has to be balanced between the effective and the balance between population that are attending. Aim of the health professionals should be promptly and continue any threat. The post-event is to monitor and quickly intervene, and use the international collaboration and require close coordination with all the stakeholders. In summary, infection control measure based on mass gathering public health risk assessment should be considered to pre-event advise economic assessment of the intervention, hand respiratory hygiene, early detection and isolation, vaccination or post-exposure prophylaxis, use of social distancing, and use of quarantine for those who have already been exposed. Infection control measures and guidelines had to be implemented based on existing infection control guidance and mass gathering risk assessment. Postponement or cancellation of event sometimes being requested, but it depends on the nature of that infection risk. Thank you very much.
Thank you. Thank you very much, Dr. Barak, for a very, very interesting and very fruitful presentation. I'm sure that the audience would have a lot of queries and questions as we're going along. Well, the next speaker is Dr. Hanan Al-Aswedi from UAE. And she is an assistant professor of family medicine at Mohammed bin Rashid University of Medicine and Health Science. She has been appointed as the Chief Business Officer of Dubai Academic Health Corporation. She is also a business function as a communication strategy audit, legal affairs, and products management. She has an extensive experience in clinical practice, healthcare administration, and healthcare policy regulation. She is also played an instrumental in healthcare funding initiative, including design and implementation of the first national governmental-based health insurance in Dubai. Like this one, she has also served as Emirati space flight surgeon. So this is something quite interesting. Flight surgeon and led COVID testing stream at the Command and Control Center. And she is going to tackle something beyond what we have been discussed with respect to mass gathering. We're all focusing on Al-Hajj al-Umrah, but she's going to give us a lot of insightful experience on Expo, because we had Expo 2020, and that is something that of importance in terms of experience. So she's going to talk about Expo in Dubai, major amid the pandemic. Doctora, tfadali.
Assalamu alaikum. Good morning, everyone. And first of all, I would like to extend the thank you to the organizing committee and team for extending this invite. And I would like to share my admiration, gratitude, and pride to the services being provided in the kingdom for the major events that they are hosting every year through Hajj and Umrah. And it's really a privilege to be also the approach that the kingdom is following in inviting other colleagues to join and learn from these participation. So thank you very much. I will zoom out. The first two talks were focused on mainly very informations regarding specific information about the infection protocols. And I will zoom out even beyond Earth. The last 4 or 5 years of my work has really looked at experience. I've served for 2 missions the first mission of the UAE and the second Long Arm mission. And thinking about mass gathering in space would be 11 astronauts or more, and compare it to mass gatherings on Earth would be millions. And what's a common thread between both would be prevention and preparedness, which is similar. Going back to 2020, when we just heard about the new emerging cases of SARS-CoV-2 in the world, in Dubai, we were working very hard to host the first expo in the Arab world, and its premise was to connect minds and create the future. It was time of uncertainty, and major challenges and decisions needed to be taken. There was a decision that needs to be done. We were hosting Expo during 2020, the time where there was really little information known about this pandemic, and data was emerging as we go. So the decision was made not by the host, Dubai, but the International Bureau to postpone this world event, and it was the first time it was ever postponed in its 170 years through a remote member vote. At that time, it was the decision of the international participants. Every country during 2020 had actually really minimal understanding on what needs to be done. So the decision of postponement was taken. The name remained as Expo 2020, but the dates were shifted. It started in 1st of October 2021, ended end of March 2022. Dubai's challenge was similar to every city, every government in the world. It was our first health emergency. We had experiences in other emergencies, but a pandemic, it was the first. We have always been inspired by our leaders, and a quote I would like to share, a quote from His Highness Sheikh Mohammed, was 2020 was a year that showed us that unity is strength, happiness lies within our families, excellence is given, and health comes before politics and economy, and placing confidence within our youth really leads us to the stars. And the inspiration and the closeness that we've seen with our leadership and the trust that was been instilled within the community really helped us to have a very positive response to this pandemic. Just to shed light on the governance that worked, we had a Supreme Committee for Crisis and Disaster Management within the city of Dubai, and that also used to communicate with the federal committees. This committee was led by His Highness Sheikh Mansour bin Mohammed, and it had an integrated governance and a whole government approach. Membership of this committee involved not only health, it was led by the health sector. It had the police, it had the security, municipality, road traffic agencies, the data platforms and media and other more. The focus of the committee was to create efficiency and effectiveness in decision making. And you see the pictures that I'm showing are all taken within the premises of Mohammed bin Rashid University for Medical and Health Sciences, and the Command and Control Center for Dubai was led in that academic institution. There was a phased approach. We had a certain set of guidelines, principal guidelines that we took. The major principle was to balance lives and livelihood. The second principle was any decision needs to be made was made by or driven by data. And the third principle was if we couldn't find any of the above, we used common sense, where at that time common sense was not so common. The approach was, as you see, was the focus was to slow the spread at the early stages of the pandemic, reopen gradually as we go, protect and lift restrictions, and rebuild the readiness. And that approach really helped us to come to a point where Expo 2020 was ready to host and welcome its visitors. The framework that the Command and Control Center for Dubai followed is similar to the frameworks that other entities and governments used. We looked at suppression, built the testing capacity, looked at the best ways to contain the spread of the infection, look at the surge bed capacity and support capacity building. In Dubai, there is a large private sector, and there was a strong public-private collaboration for us in order to support the needs of the city. Supply chain was a critical matter in this experience with building the science and data platform. Research was very, very propelled during this time. A lot of research that supported decision-making and also policy changes was created. And communication was an extremely important element. I don't think we have done enough and proper communication during that time. And you can imagine, if you remember, there was so much misinformation that was shared across social media platforms that influenced decisions of individuals at a later stage. This was the methodology taken for us during our reopening. We identify which activities needs to be resumed, stakeholder engagement meetings occurred, protocols were co-created, then disseminated with a follow-up of compliance. During 2020, with the minimal restrictions that occurred during the April in Dubai, there was a gradual reopening since then. In June 2020, people went back to work with obviously the hybrid option still available. In July, aviation was opened, tourism was initiated. August, schools were opened. We had also at least 50% of children were getting their education in the school premises, and the vaccination program rolled out during December 2020. All these initiatives and all this work has ranked the UAE to be the first in the resilience index of the Bloomberg's institution. The Expo 2020 followed the same and were aligned with the same principles that the government of Dubai taken. The aim was obviously to protect the workers, protect the constructions, to support the opening of the event. There was testing and vaccination facilities available, and the guiding principles was obviously grounded in science and best practices. And what is unique with Expo was its communications with the international participants. We had more than 190 countries participating, and you can imagine every country at that point of time had their own protocols, had their own guidelines, and their people were, in doubt or sometimes confused what is the best protocols to take. And we were working with them closely to make sure that these open communications and channels are available. The protocols are similar to what's been discussed: precaution measures, testings, vaccination, containment was all available for the teams on ground. The timeline that Expo led, the task force was created in 2020, March 2020, and followed the same protocols of the wide city protocols. Testing was available, but really what really made it that shift was the vaccination program that was rolled out, not only for the city of Dubai, but also the international participants that was involved in Expo. The protocols and guidelines that the Expo event took in consideration were mainly obviously the precautionary measures, the masking, the social distancing, adopting the infrastructure for minimizing contact. There was testing and vaccinations available to the workers and the visitors of the city, and there was a lot of partnerships across different stakeholders. We have built major testing facilities, whether they were drive-thrus or large pavilions. Testing was not the only available service. Vaccination was available, communications, awareness campaigns were all provided within the premises of the city. You can see probably here the numbers of the testing increased after the Omicron wave during December 2021, and there was a ongoing genome surveillance by the city to make sure that we are aware of these changes in variants and how they are affecting or changing the disease burden. There was a lot of live events that also had their special protocols to make sure that these events are done in a safe manner. The impact in numbers for Expo, we had more than 24 million visitors during the 6 months from 195 nationalities. There were key pavilions in the Expo that captured the sentiment of the visitors. And during that pandemic time, people still shared positivity, the opportunity to move forward and understand how Dubai has came and developed during the past years of its creation. I just wanted to conclude with some reflections around this experience. And at that time, Dubai took a brave decision to go ahead and commit to Expo in the amid of the uncertainty and the fluidity of the time. There was courage taken and risk, but that was embedded in a science-based preventive approach. So things were done with clarity. And finally, when people did come and join this event, there was a spirit of solidarity and optimism, which I really think is extremely relevant even to our times today, where we need to come together to bring positivity in the amidst of the challenges we're facing across the globe. It is important to reflect, but we haven't able to achieve to this level without the humility to learn from each other, from other systems, and it was an amazing event, and I wish you all the best. Thank you very much.
Thank you very much, Dr. Hanan, for your excellent presentation, sharing with us your experience for Expo Dubai and the challenge that you have faced during that time, especially with starting of the COVID era, and you try your best to conduct such international events at that difficult time. So the next presentation will be about the Riding the Waves by Dr. Ja'far Tawfiq. Prof. Ja'far Tawfiq is a professor of internal medicine and infection disease at Johns Hopkins, Aramco Healthcare, and Indiana University School of Medicine. During his academic career, Dr. Tawfiq has extensive publication in mass gathering, emerging infection disease, hospital epidemiology, and infection control. He had participated in numerous international and regional conferences, and Professor Tawfiq is associate editor of many peer-reviewed journals. He sits on multiple national and international committees and medical organizations. So please welcome Prof. Ja'far Tawfiq.
Assalamu alaikum. Thank you to the organizing committee and for the chairman and the co-chairman for giving me the opportunity to speak today. So what I'm going to talk in the next 15 minutes or so, I think just like dogs, I wish that the slides could move forward. So when I initially got the title of the presentation, which is Riding the Waves, and I thought maybe the organizer thinks because I'm in the eastern part of the country, there's a lot of waves there and we are serving. So I'm not a server, but when I tried to put this presentation together, I think there are different ways of looking at riding the waves. We have the waves of preparing for mass gathering, which involve multiple waves in the preparation. And also, I was thinking of the COVID waves that we had recently that struck the global and affected the whole world. And also the wave of the population that they move during any of the mass gathering. And of course, it's very difficult to dissect each one of those waves from a different perspective in the next 15 minutes. But I will try to combine some of the waves that I thought will be interesting. So, as we know, the waves may refer to the cyclical nature of the infectious disease. We should have a proactive, and I think what Dr. Barak had presented in the initial presentation is a clear demonstration of the first wave of preparation for mass gathering. We looked at the proactive measures and the risk assessment and so forth. And from there, I'll just highlight a few points of the preventing strategies and went through from a risk assessment that usually occur in the pre-event, as well as had been just mentioned in the just previous presentation by Dr. Hanan about the Expo Dubai. Vaccination, hygienic practices, crowd management, and surveillance and responses. And this is a similar slide that Dr. Barak had shared, looking at the different types of mass gathering. And I think each mass gathering has its unique characteristics as well as associated characteristics and demographics and possible potential associated infectious diseases from respiratory illnesses, gastrointestinal, and so on and so forth. And in the Lancet, there was a paper looking at the risk assessment of the mass gathering during the COVID, but I think it's a framework that can be utilized to shed the lights on the risk assessment pre-events, from looking at the consideration in the planning phase, the specifics related to each diseases, it be in the COVID or others. In addition to that, in putting some of the communication strategies as well as risk mitigation. So all these are in the first probably wave of dealing with mass gathering. With the COVID, I think there have been, I have seen in the yesterday and today and probably throughout this conference is some of the mass gathering that had been reconsidered, canceled, delayed because of the Olympics, because of the COVID-19, including the Olympics and the Para-Olympics Games. I think the second is maybe adapting. So when the mass gathering had been established and being conducted, there are a lot of also challenges may arise during that time. And I think one of the aim is preventing measures. And I'll just show some in the waves of the COVID, how the kingdom had dealt with the Hajj from the establishment of the risk assessment, dealing with the different risk from the Hajj. And those who had performed the Hajj, you could see the number of the individuals, millions of people in the same place. And with this one study that had been published in the Tropical Disease Tropical Medicine, which looked at the number of pilgrims in the Tawaf area and average time. And you see that as there is more individuals, of course, there will be more of those contacts, which then increase the risk of respiratory illnesses. And some of the authors of this paper are here, Dr. Khan and Dr. Hani Jukhdar, who looked at the implementing an early warning system based on syndromic surveillance and event-based during the 2019 Hajj. And I think because of that electronic surveillance, you could identify which syndromic are starting to manifest during any mass gathering, and then you could direct the activities in the prevention to these syndromic that had arrived. With the COVID-19 starting in late 2019, beginning of 2020, there's a lot I said about the Hajj for in that year, and would it be canceled? And the risk is not only from the hosting countries, but also from the individuals coming from different parts of the globe. And this table shows the different number of cases per million from the highest 10 countries that performed Hajj in 2018. And thus the country took drastic measures to prevent based on the risk assessment. And some of this that we had put together is a combined model for the COVID-19 pandemic, which showed the amalgamation of different strategies from the HADOX and the community risk reduction tools to give an assessment of each of those mass gatherings to understand the risk of infection or the spread of infection in those mass gatherings. So for the 2020 Hajj, which is the first, the risk seemed to be very high. And the risk, especially if exceeded the Hajj population of 10 to 15% of the previous year. And that's why this decision had been made to really limit the number of the Hajj in 2020. There's a lot of activities took place, from having safe bubbles, 20 pilgrims, has a dedicated group of healthcare workers and health officers would accompany each of those groups with social distancing, face masking. And just to remember, at that time, the COVID vaccine had not been yet started. After the introduction of the vaccines and the first wave of the pandemic had passed, multiple steps had been taken to further enhance the number of the pilgrimage and during the Umrah and the Hajj. So the 2021 Hajj season, there have been around 60,000 pilgrimages, all from within the kingdom. At that time, the COVID vaccine was available and vaccination was required. And of course, there have been a priority group. And if we look at the incidence rate of the COVID in the country, was about 19 to 24 cases from July to August. But the number of the COVID-19 during the Hajj was only 3 to 7 cases, indicating the adequacy of those preventive measures that had been taken place. Subsequently, the 2022 Hajj season, which took place in July of 2022, included 1 million pilgrims. And that shows the risk assessment, the intervention, as well as building in the experience that had been gained from previous Hajj seasons. And they had been coinciding with some complete lifting of all public health measures for combating COVID-19. If you look at the etiology of severe acute respiratory illness among patients in the 2022 peri-Hajj period, so it's not particularly during the days of the Hajj, but this is peri-Hajj and included all individuals who had been admitted, see that a large number of them had negative PCR tests for commonly known viruses, but then the second was SARS-CoV-2. The 2023 Hajj, as we know, had been conducted with full capacity. The vaccination, once again, was available, and it had been completed in a timely manner with no reportable diseases. I think the third wave we look at from a mass gathering is addressing some of those uncertainties and challenges that may take place during such a mass gathering. So one of those is addressing or making decisions at the time based on scientific evidence. I hope that I could in the quick time that we had, showed some of the risk assessment, some of the thoughts that take place. I mean, this is an oversimplification, of course, in only 10 to 15 minutes, being flexible and adaptable to the emergence of new variants, new viruses, or unexpected disease outbreak. Variable strategies, including a multidisciplinary team, contingency plans, and open communication, and regularly updating protocols had to be also addressed during the events of mass gathering. So in conclusion, I think riding the waves, I tried to put the philosophy of using server perspective that we have to have prevention strategies. Those who do serving will understand the waves, the speed of the waves, the direction of those waves, as well as the human being waves. And then during this serving, so during the mass gathering itself, we have to have an adaptive and refining preventive measures as we go through the mass gathering, and of course, a reflection to understand the uncertainties and challenges and how these could be addressed in future mass gatherings should be also be considered. As well as refined, and hopefully new strategies will be addressed to overcome some of those challenges. And with that, thank you very much.
Thank you very much, Professor Tawfiq, for a very, very interesting presentation. And I personally like addressing the uncertainties and challenges. I think these are quite interesting and really need to look after them up to some time, whatever it is, but these are quite interesting indeed. Well, last but not least, I would like to introduce a colleague, a friend, and a brother, Dr. Maged Shamrani, and he is an Executive Director of Infection Prevention and Control Program in Ministry of National Guard, of course, here in Saudi Arabia. And he is absolutely a director, and there are a lot of things that you're doing it, Dr. Maged. And he's also director at the World Health Organization and Gulf Cooperation Council for IPC and MR. Thank you so much. And ختامه مسك زي بيقولوا. And his presentation is going to be limitation and recommendation in dealing with the unknown. It's going to be quite interesting.
Assalamu alaikum wa rahmatullahi wa barakatuh. Sabah al-khair ajma'in. First of all, I would like to thank you all for being here with us today, and also moderators for the nice, introducing. And I think this is very important, meeting where we're talking about mass gathering. We have a lot of risks here around us, and thank God, Prof. Tawfiq, he paved the way for me. He spoke already about, the issue of risk assessment and also the direct interventions, and which is very, very important when we talk about specific things. Let's say COVID-19 and Hajj, so you have a direct interventions for COVID-19 during Hajj. And we call it all the time from infection prevention point of view, which is, vertical interventions. And we have something called horizontal interventions, which is usually covering different things. And when we're talking about hand hygiene will cover and will reduce the risk of hospital-acquired infection and other things. So horizontal interventions, they are very important interventions to control unknown things, which is our topic here. So thank you, Prof, for easing my presentation. Okay, so we'll start by some introduction, then we'll go over emergence of infectious diseases and preparedness, readiness, and response, then we'll end with conclusion. And from introduction point of view, we lived through, all of us, through COVID-19. We know that COVID-19 not anymore a public health emergency for international consensus March of 2023, but truly the disease is still around us. And the idea of are we prepared and how we can utilize the COVID-19 to prepare ourselves for the next pandemic. And there will be next, for sure there will be next. And when you look to the Kingdom of Saudi Arabia here, actually the MERS-CoV experience in 2012 helped us a lot to mitigate the risk of COVID-19. We know that since 2012, we improved a lot when it comes to infrastructure for hospitals, for diagnostic labs, for research labs, for public health and infection control, and also not only in the health sector, also in the other non-health sectors, especially when it comes to digital transformation and infrastructures. It helped a lot to control the pandemic, and we went there and we ended, hopefully, soon the pandemic with very, successful story. And this is how horizontal interventions will help all the time. I don't want to spend a lot of time with this definition, but generally speaking, endemic, which is something that our disease happen with a constant kind of numbers all the time in geographical area or population. Epidemic, when this, disease occurrence, it happens more frequent, more than the expected, numbers, and among populations or specific areas, and pandemic when epidemic exceeded to different countries and continents, and we have COVID-19 and influenza and cholera there. And if you go back, pandemics, it happens and it will keep happening every now and then, and you can see here the similarity between the influenza in 1918 and the COVID-19 in 2019, almost like 100 years apart, but you can see that field hospital, closing schools, closing mosques and churches, and all of these things, it happened and it will happen again, so we have to be prepared all the time. There is something called disease X, and maybe most of you heard about it, and it's not a disease actually, it's a placeholder for what will happen next, what is the pathogen that will cause the next pandemic, and this actually been announced since February 2018. And at that time, WHO, with a group of people, they sat together and they said, okay, we want something a platform where it's plug and play. And whenever we have any pandemic, this platform, it can cover everything, cover the bases, how to prepare ourselves for the next pandemic. And actually at that time, they proposed the RNA prototype, RNA printing, which is later on used during COVID-19 for vaccine. And this is how we can build something and make it ready for the next pandemic. And I think the RNA platform will help a lot for any coming pandemic. To have a pandemic, you need a specific characteristic of that virus, and most of these or disease. And most of these, characteristics, most of the time they are available with the respiratory pathogens. Like if it could be new, like emerging pathogen or human pathogen, and it should easily and sustainable causing transmission from human to human. And if you look to MERS-CoV, the MERS-CoV has an issue with causing this sustainability, and that's why MERS-CoV didn't reach to the level of pandemic. But generally speaking, all of the three characteristics are very important to cause a pandemic. Emerging diseases is something that we'll face, and every now and then, and there's something called emerging and re-emerging. Emerging means something new causing a disease, a pathogen causing a disease, and re-emerging that it came again with more public health concern. And almost 12% of all diseases that we have currently, they are actually emerging in their characteristic. And this is something also was seen since long time and been described in the literature that, with syphilis 450 years ago, there will come yet other new and unusual elements when in the course of time, and this disease will pass away, but it later will be born again and be seen by our descendants. So this something happened and it will happen again, and the only way to prevent it or to mitigate the risk is by well preparedness. So this will cause a lot of challenges over time. This will need a lot of control and need a lot of coordinations, and of course it will have a lot of damage in case if we didn't prepare very well and respond in a good, speedy way. The economic impact is huge for all of these pandemics, and unless we are prepared, it will be a huge problem. So this is just looking back to some of the major, epidemics and pandemics years ago, and you can see that the economic impacts were huge. There are factors that contribute to emerging diseases, and there are a lot actually. I don't want to go over them and read them, all of them, but generally speaking, the most important thing is microbial adaptations and also change in susceptibility. We have a lot of mass of immunocompromised patients now due to medications and other things. Also climate change, as I said, and dam and irrigation system constructions and a lot of things around us. And most of the time, there are multiple factors together to cause, emerging and pandemic. The National Institution of Allergy and Infectious Diseases, they categorize diseases into three main ones. The most important one, they usually cause pandemic, which is the category A, and they put them as a priority A. And they are actually easily disseminated with high mortality rates, and also it causes usually public, panic, and also need a lot of preparedness. The group B in this category, they are actually easily disseminated, but not causing, huge impact to morbidity and mortality. But what we need to be ready for them, usually we need to enhance, our diagnostic capacities. And there are a list of diseases under each of these categories. I don't know why it's not, okay. Group C, they are the ones that use most of the time for bioterrorism, and they are actually easy to be engineered and to be massively disseminated. So now we're going to preparedness, and this is maybe the general horizontal, things that we need to do in our system to ensure that, any pandemic we are ready and we are responding to them in a timely manner. So pandemic, as I said, it has a lot of dimensions. It's not only the economic, but also social and political, and we saw that during, H1N1 in 2009, and also during the SARS-CoV-2. And to do a good, preparedness, it needs a lot of effort. It's not only, a scattered kind of effort, but it needs all under certain leadership and organization coordinations. We need to look to international, pandemic preparedness, and also we need to be sure people at risk, they are getting, care, and also pharmaceutical and supplies regarding vaccine and other need to be prepared. And here's an example from National Influenza Pandemic Preparedness. Dr. Tawfiq already mentioned the risk assessment and also he put that, dimensional risk assessment tool, but we have an easy one, and maybe you have different risk assessment tool, but generally speaking, the likelihood of happening and also the damage that can cause, they are the most important two parts when it comes to risk assessment. And we need to study things in advance and put things in priorities, and you can go with either certain disease or you can go by syndromic kind of surveillance and let's say all respiratory pathogens, all pathogens that can cause fulminant hepatic failure and other things, and then put them into this matrix and see if they are priority one, like high risk or moderate risk or low risk. And if you look to literatures and from WHO, although this is an old kind of slide, but generally speaking, you will have a lot of documentation that will help you for preparedness. And also there are a lot of tools there. It can help you to check yourself, do some self-assessment to ensure that at the national level you are prepared well for any kind of pandemic. Whole society approach is very important. So we're not talking about health sector only. Non-health sector also need to be involved in preparedness, and also individuals, families and communities also need to be part of this kind of preparedness to general or in specific, diseases. We have to do some risk assessment for job and occupations. It's not only for system, it's not only for readiness of the system, but also for human factors and manpower, health sectors or non-health, healthcare workers or non-healthcare workers. And usually categorize them into very high and medium and low risk based on their risk of exposures and if it's high or low. Like very high, those who's working in the ICU and they do a lot of aerosolized kind of procedures, they consider very high. Why we need to do that? Because during pandemic, we'll lose almost 50% of our manpower in general, either in health sector or non-health sectors. And you can see that during the peak, 20% of them that maybe they are not around, and also will lose people due to closure of schools and other direct factors. So absenteeism, it's an issue. It will affect commerce, it will affect supplies and delivery, and we saw this during COVID-19, and we have to cover this part too. Organizations, they have also their own responsibilities when it comes to manpower, especially in non-healthcare, non-health, sectors. They need to look to the impact of their, manpower in case if they are not around during the pandemic, and they have to put alternative to ensure everything, especially services that's, important to community that are available and also accessible. So what are the strategies to reduce stress in general? And this is, as I said again, is this horizontal interventions, not vertical intervention. This will work for all pandemic. And I will go over them quickly because I have only 1.5 minutes. So we have to develop political and will and funding, political will and funding. We have to be early response from capacity point of view, training programs, surveillance systems, syndromic surveillance system, improve diagnostic capacity in general, improve communication system, and also rapid data analysis and do action for them. Not only data analysis and collection, but we have to do action, and it has to be timely, in a timely manner. Use of vaccine, we are talking here about coverage and accessibility, we are talking about supplies, we are talking about developing vaccine and capability of the government to develop new vaccines is very important. New drug development is also very, very important, and we have to decrease inappropriate drug use, especially when it comes to the AMR issue and the epidemic and pandemic of AMR now. We have to decrease utilization of antimicrobial in general, in food, in agriculture, and other things. We have to improve vector and zoonotic, control, and this it will help a lot in a lot of diseases as a general interventions. We have also to do good health educations to different, transmission methodologies. Let's say cough etiquette, wearing mask when you are in crowd. So general terms when it comes to education, they are very important. And the most important thing, we have to utilize national, international alerting system. So we have the Global Outbreak Alert and Response Network. This is under WHO, and we have the Global Public Health Intelligence Network. And this is also, again, under Canadian, government. And these kind of, international alerting system, they are very important. We have to develop our own, surveillance and alerting system to different diseases and also the impact of these diseases all the time, either syndromic or specific kind of diseases. With that, I say thank you very much, and please be proactive. Thank you.
Thank you very much for Dr. Majid Shomrani for an excellent presentation and sharing with us how can we deal with any X disease in case of F having a new disease, and how can we initiate and hypothesize any recommendations to deal with. So thank you very much, Dr. Majid, and thank you for all the speakers. Now we're going to for the Q&A session, so please, for anyone have a questions, you can have a mic and ask colleagues for any related to the infection prevention, control, and public health issues with mass gathering, please. Mike, please.
Thank you very much for the very rich presentations that we have seen in the past hour from the five distinguished speakers. Actually, the mass gathering and the infectious disease is something that is causing headache to every mass gathering. Before COVID-19, it wasn't there in the implementation phase. All the mass gathering, they looked into the service delivery if needed, and emergency preparedness if something goes wrong, but not in infectious diseases. The first time we get struck with, and the whole world gets struck with infectious disease and mass gathering for 100 years is COVID. Yes, we had some infectious diseases pops up and there and here and there for the past 2 decades, like Ebola or influenza, H1N1, H5N1, sorry, and SARS. We remember 2003, but they did not strike the whole world like what we have seen in COVID with de novo virus. I think that has put the decision making to postpone or delay or cancel a mass gathering in the agenda, and we still, as the risk map that Dr. Majid has displayed is very important, but we still see difference in the decision making and taking. When UAE had the Expo and they were in the decision taking, do we postpone it or do we keep it on track? In the first year of the pandemic, that was a very tough call. Similarly, when we look at the Olympic Games in Tokyo, again, in the very first year of the pandemic, the decision was do it with no attendees, no crowds. And Expo, it has to be a crowd. Without a crowd, Expo will not be there. In Tokyo, the decision was you make it available for the athletes only and the teams, but no crowds. And that was a tough call to take, building on the economy of the country like Japan, that they're having this with, they have to factor the losses. For us in the Hajj, we were asked if UAE took the decision to go for the Expo 2020 to 2021, I think March, right? Like it was 6 months. And it was before the Hajj of 2021. Why you are not taking the risk and go for the Hajj in an open space like what UAE did? The decision was the population actually. You need to count the population diversity in the decision. The diversity of the population that are going to Dubai in 2020 to 2021 is different from the population that goes to Hajj in 2021 after the Expo. The population that is traveling to UAE, majority of them are people who are healthier, wealthier, and it is part of their entertainment life. Whereas people who are coming to Hajj, the population, the majority are people who are from the unhealthy, because they are older population. Many of them are not capable to fund their health appropriately. They collect money for 40 years to do Hajj. So the diversity of the population is different. To take a decision on opening the Hajj was much more difficult to take a decision for Expo, where you have a certain population group. So I don't know how to factor that into the risk assessment I'm sure that the mass gathering, they do have that, but it is still, again, a bit tough call to take the decision when you understand the population diversity. And we know that it's a sentimental decision to take, to tell the people, no, we are not having Hajj from outside the country for the second year in a row. In 2020, we did not. 2021, we did not as well. That was a tough call, and it had a sentimental impact on the population from all over the world that were waiting for the Hajj season to come to perform their Hajj and to attend. And they are not sure if their permission will be canceled the year after, or if they survived another year or so. So it's sometimes tough calls has to be there, but we need to understand how we're gonna put the decision of public health inside the economical, or I'm calling it economical because every single mass gathering, the highest impact is the economy, and then the others will come. So we need to put public health calls at the same level of the economical impact, and the how part is the responsibility of the scientists around this table or around this session. And sorry to take a long time, but thank you very much for
thank you, Dr. Hani Jukhtar, for your sharing your difficult time to take decisions for to do Hajj at that time. So I'm not sure if our colleagues respected, they want to add any commented regarding the comments addressed by the Deputy of the Minister of Health for Public Health, Dr. Hani Jukhtar.
Thank you very much, Dr. Hani Jukhtar. I think what you said is, you had put it eloquently. I think, and that's why I tried to allude by the wave, so it's also the wave of the people, so the individuals are, and that certainly carries its own risk. And looking back, probably sitting after years, you think maybe those decisions had been very easy, but I know these are very difficult, very challenging, and with a lot of unknowns also happening at the same time. And all those risk factors and tools that being used are useful tools, but might not tell every aspect of the mass gathering that had. And I think it's a collective understanding of the risk from the population who are attending, and that's why I maybe briefly put the types of the mass gathering, because each one of them, as you mentioned, have its own risk. And so one mass gathering does not equate to the other mass gathering from the activities, from the individuals, as well as the impact afterwards. And that's like and these are dynamics. I think there's a lot of things to be able to understand and learn from the past and improve for the future at the global levels. I think each country had struggled with the different mass gathering events from, as you mentioned, the either sports events, other, for example, just because of the time I had to delete some of the slides when the Black Lives Movement in the US had took place with marching. There was a significant increase in the number of the COVID, and so people had looked at it. So I think you put it really eloquently of some of those challenges. Thank you.
Okay, because of time, Dr. Majid, do you want to comment anything? Yeah.
Just a small comment regarding your maybe comment, Dr. Hani. It's all about public health, and when it comes to risks, the risk is there, or are there. There are a lot of risks when it comes to mass gathering. So mass gathering, it's an area where people coming from different, generally different, countries or places, and they are coming to maybe confined area, and then they go back. And it by itself, it's a risk because they will share a lot of things. They will share, during the exposure, they may share viruses, they may share, or they may have a risk from the environment itself, let's say food, water, the area that they will visit, and they go back and they may disseminate it there. So the impact can be huge. It's not only to them, but also to their countries and their area. And the idea how to control the parameters, how to control, the environment itself, so the area that they will gather in, the water, the food, the sanitations in general, how to control, tracing for them, and how to control surveillance all the time. How to prepare also the individual himself. They need vaccines before they're coming. Can we select certain group of people, certain age, certain, people with low profile or low risk? So all of these need to be prepared a little bit ahead. So it's a public health, huge public health, and the risks are there, either from the environment or from the individual themselves. Thank you very much.
Thank you all for your comments. Just we conclude the Sport take home message, as we know that, as discussed by our colleagues, the respiratory infections, the gastrointestinal infections considered as predominated and dominated at the mass gatherings, developing of the strategic plans, infrastructures to deal with improve the sanitations, keeping the public health prevention measures, masking, it's cough etiquette, or the difficulties to have the keeping distance with the mass gathering. All this would be decrease the risk of getting the infections. We have to think all the time, we shouldn't lose any opportunity of vaccination for any vaccine preventable disease, measles, mumps, pneumococcal, meningococcal infections. So all these have to be targeted during the mass gathering. I would like to thank the respected colleagues, distinguished speakers, and the audience for attending this sessions. And we have to conclude by what we would like to say, always the prevention is better than cure. Thank you.
Thank you. Thank you, our valued guest speakers and esteemed moderators, for the rich and wonderful session. Please, if you allow us for a group photo. Our second morning session is about risk communication and community engagement. I would like to welcome our esteemed moderators, Dr. Amjad Al-Khouli and Dr. Haytham Bashir. Dr. Haytham Bashir, he is the Executive Director of the International Academy of Public Health. Dr. Amjad Al-Khouli, he is the team lead for IHR assessment, monitoring and evaluation, country health emergency preparedness and international health regulation, CPI, at WHO Eastern Mediterranean Regional Office in Cairo, Egypt. Please welcome, and the stage is yours.
Assalamu alaikum. And good morning, colleagues. Let us start our session today. Our session will focus on risk communication and community engagement. Effective risk communication and community engagement can build trust, encourage preventive measures, and foster collective response to health threats. Clear, accurate, and timely information about potential health risks is crucial. Addressing misinformation and involving health experts is essential. Collaborating with media outlets and ensuring health information accessibility is also crucial. Mobilizing community members and fostering partnership with local organizations can further enhance these efforts. To elaborate more into these topics, we are glad to hear from our distinguished speakers, Dr. Imad Al-Muhammadi, Dr. Abdurrahman Al-Qahtani, Dr. Manaf Al-Qahtani, Dr. Fadi Makki, and Prof. Duncan Selby. We'll start with our first speaker, Dr. Imad Al-Muhammadi. Dr. Imad Al-Muhammadi is a consultant of preventive medicine and public health. He is Chief Officer of Communicable Disease, Public Health Authority in Saudi Arabia. Dr. Imad is a member of a National Committee of Communicable Disease and the National Committee Team of Immunization. Dr. Imad also is the head of WHO MERS Collaborating Center. Today, Dr. Imad will present the infodemic management. The floor is yours, Dr. Imad.
Assalamu alaikum, sabah al-khair. Good morning. Thank you, Dr. Amjad, for your kind introduction. Thank you for organization committee for the invitation. Today I will talk about infodemic as a part of risk communication, and through the presentation we will focus more, highlight some definition and background, and discuss more about why misinformation occur and the consequences of this misinformation and the infodemic management. Dr. Tedros, during the COVID pandemic, said we are not just fighting an epidemic, we are fighting an infodemic. Fake news spread faster and more easily than the virus, and it's just dangerous. And during the pandemic, the phenomena of infodemic has escalated to a level that required more coordination. We are living in the connected world. Now the website, the phone application designed to be more addictive. And as the world becomes more digitized, the environment of digital information increases influence. This affects ability or taking or behavior of the public and health decision. The infodemic is not only linked to the false information. It's also about the overload of information, outdated information and information void. The vulnerability not linked only to the public. Even the public health or the healthcare worker working in the front line during the emergency have fears and concern regarding to the emerging disease. And this may be the vulnerable for the misinformation. As we see, the misinformation and disinformation start as concerns and questions. This unaddressed concerns and questions, if it's not filled by trusted sources from a trusted healthcare worker or organization, it will be filled by misinformation. So for the authorities, it's easy to tackling this concern in early phases because it will be easy, and it will be the changes will be difficult in the, when the misinformation and disinformation will be appear. As a definition, the difference between misinformation and disinformation, it's both, it's false information. The misinformation, there is no intention. The people think it's a right information. But in disinformation, the people who spread this information know it's not not true. A global survey conducted during the COVID pandemic over 40 countries to address misinformation and believability and vaccine acceptance. In this study, Saudi Arabia was amongst the country with the highest misinformation believability during COVID, is more than 31%. As I said, people question if it's not addressed, people will turn to any attention to other information source, so will be more vulnerable to mis and disinformation. Why misinformation occur? It's two sides of the story, the source and the recipients. The source is maybe because they lack of experience or have a political agenda driving this, or conflict of interest, or just to gain some personal gains, like more retweet, more followers in social media. And the receiver, if there is missing accurate and true information, the receiver, it's leading to accept this misinformation. Understand these two way of information lead to need to construct a tailored framework to counter this spread of any falsity. This is the example of how the concern turned to misinformation and disinformation. For example, a community expressed confusion about why foreign-made vaccine is recommended to them, expressing preference for local-made vaccine. And the misinformation and link it to choosing due to hidden financial motivation by leadership. And then this misinformation about the vaccine origin is amplified with disinformation narrative, undermining trust in government and become talking point by the political candidate. The WHO tried to classify the impact of infodemics in this 5 domain. For example, in the physical, it's limited to accurate knowledge about availability of treatment lead to misplaced action. But also regarding to social impact like stigma or economic, it's usually linked to trade market and the panic buying for the medical countermeasure. Also, political impact, limited trust in official, rejection of official guideline, and also physiological impact like mental health epidemic and long-term depression. This is example of consequences of misinformation regarding to vaccine hesitancy. In 1977, in the UK, the claim were made that pertussis vaccine may lead to neurological development. These claims decrease the immunization rate from 80 to 30 and lead to epidemic of pertussis with more than 100,000 cases and 36 deaths. And also in Nigeria, regarding to polio vaccine and allegation that the vaccine could cause sterility. And this lead to a resurging of the wild-type polio virus transmission and spreading to 19 polio-free countries in 2005 and 2006. How do we prevent, prepare, and respond to future infodemic? Chasing the individual pieces of health misinformation is not effective for infodemic management. It needs to whole of society, whole of governmental approach to tackle this problem at multiple intervention and multiple levels to prevent health misinformation from sticking when it's circulated. Also, the WHO work hard to mapping the gap in the management of infodemic management intervention. And this classified it in 5 categories. First one, regarding to monitoring and detection of narrative, questions, and concern and misinformation through public health, social listening, and integrated analysis. Second one is regarding to science and health communication, rapid content development to address emerging information voids, also quality health information, materials and resource, debunking and misinformation correction. Third one, regarding to build capacity through education and training, to be more resilient to misinformation, improving self-efficiency to the staff to adhere our recommendation health behavior, or also capacity building to identify and address health misinformation. Fourth one, regarding to engagement in all levels, individual and community levels, and also healthcare worker level engagement, psychological support to individual and community, and use the social media-based strategy. Finally, regarding to law and regulation and ethics, cybersecurity law and public health advisor and guideline with legal mandate, also regulation of information and related platforms and ethics, consumer protection laws. These 5 categories summarize the area to work to intervene with infodemic. UNICEF also have the misinformation management frameworks. Start with preparation phase, preparation by building the team, identify the platform are the most popular for what audience, which account have the most reach. Then start to listening, build this listening system, social listening, detect the misinformation, and have develop a rumor log. After that, analyze this log and identify the rumors that require to response. Finally, engage the strategic engagement and content development campaign and monitoring and evaluation, and then end by lesson learned and the cycle continue. There is a different way to address infodemic harm and health misinformation. Who is the best position to do what? For example, healthcare worker address the patient question and concern directly through in the clinic or online, contribute to fact checking and addressing the misinformation. Risk communicator develop message and content that address most common questions and concern and address health misinformation. And they regularly update the online health information as a new guideline is released. Third group is it's media and journalists by fact-checking and help amplify the right information. Also, community leaders is important because they provide the feedback to health authority on community question and concern, and also promote the credibility and accuracy source of health information. Emergency responder conduct a social listening and infodemic management early on the emergency, adjust health guidance and communication service delivery to meet population need. Also, health program staff build a trust in health services and health worker by providing accessibility to information for vulnerable groups, and also create multiple tools like FAQs and other to address common misinformation and concern. Adjusted health guidance, communication, and service delivery to meet population need. Science translators provide plain language to explanation of news, scientific development. So also explain rule of preprint, changing or uncertain science journals, etc. The final message is that operationally put the risk communication and addressing the rumors and the misinformation as a routine work to be agile enough to rapidly surge in emergency. Thank you.
Thanks, Dr. Ahmed. Thanks for such comprehensive and informative presentation about such a very important topic, infodemic, and its impact on all dimensions of global health security, either detection, prevention, detection, or control. I will move to our second speaker, Dr. Abdurrahman Al-Qahtani. Dr. Abdurrahman Al-Qahtani is a health promotion and communication advisor at the Deputy Ministry of Communication, Ministry of Health in Saudi Arabia. With over 20 years of experience, he has worked in health promotion, health communication, school health, consultation, community empowerment, and health journalism. He has held challenging positions such as Director of Health Communication, Department at Ministry of Health, General Secretary of Consumer Protection Association, and advisor to National Committee for Narcotic Control. Dr. Qahtani has directed and participated in training over 10,000 trainees in health promotion, health education and communication, program planning, school health and media and information literacy. He has published over 40 publication and has extensive community work in various societies. Today, Dr. Qahtani will present multidimensional approach to risk communication and community engagement. The floor is yours, Doctor.
Thank you, Dr. Amjad. Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be with my colleagues and our distinguished guest. Actually, I would like to thank also the organizing committee to invite me to participate in this conference and providing and introducing this presentation titled Multi-Dimensional Approach to Risk Communication and Community Engagement. And I will highlight the experience of Kingdom of Saudi Arabia in risk communication and community engagement in response to COVID-19 pandemic. This is the outlines. I will start by the outlines of our strategic plan in Saudi Arabia, and will proceed to expose you about some example of field communication and campaigns, also some figures about our process evaluation, and finally the recommendations. Risk communication definition, as WHO say, it's a multi-level and multifaceted process that aims to help stakeholders define risk, identify hazard, assess vulnerability, and promote community resilience. Risk communication enables people at risk to make informed decisions to mitigate the effect of threat, such as disease outbreak or pandemic, and take productive and preventive measures. This is the 4 strategic objectives that we used for risk communication and community engagement in Saudi Arabia. It's also depends on one of the WHO publications. First, to be community-led, you have to put the community engagement as a top priority in facing the pandemic. Be data-driven, reinforce the capacity and local solutions, and be collaborative. And this is very important to have partnership with the private sectors, the governmental sector, and NGOs. According to these 4 major strategic objectives, we have specific, let's say, smaller objectives. One of them is to have effective leadership and governance, applying social and behavioral sciences. I think Dr. Amjad, he has a paper about how to use nudge theory in risk communication. Community empowerment is very, very essential component in designing any risk communication and community engagement and for pandemic management, and Dr. Imad mentioned that. Also, we have to use agile management. We have to be fast with balance in taking our decision. And finally, we have to be digital-friendly solution. This is our guiding principles. We got it from our experience in several pandemic cases and in Hajj and Umrah. We have to be first and proactive, fostering the public trust, also engaging with two-way communication, demonstrating respect and empathy, also be accurate and right even if uncertainty. You have to address the uncertainty in several cases. We have to also adapt our risk communication and community engagement programs according to our culture, according to our religious teachings, including the sensitive risk groups, selecting the right spokesperson, integrated. You have to be integrated with the other parties, with the other strategies, promote action and easy to access information. This is what we call it the epidemic curve, and any risk communication and community engagement in any pandemic should follow this stages: the preparation stage before the pandemic, and the containment phase, and then the recovery phase. Also, during designing the message in risk communication and community engagement, it's not one-way direction or only one-line direction. I think it should be a 6-way of direction, and in this direction we go forward and sometimes backward. This is including the risk message, warning message, preparation, uncertainty reduction, efficacy, and reassurance. This is adapted from a CDC publication regarding the emergency and crisis risk communication. Also in Saudi Arabia, we invest a lot in the digital solutions. For example, we have a very comprehensive website. We have investing in more than 5 applications and then merged to only 2 what do you call it, applications, Sahhati application, that's Me My Health, and Tawakkalna application. And in Sahhati application, you can have appointment for vaccination, appointment for COVID clinics. In Tawakkalna, if you want a permission for movement permission during the curfew was applied, or it can be done by this application. Social media account, also a web-based interactive map, as you can see it in the slide. Let me show you or highlight some of the health communication campaigns. The first one was regarding the risk communication, how the disease transmitted, what is the mechanism of the COVID, and then we start the campaigns regarding how to protect yourself, how to use the mask. Also here, this is one of the campaigns regarding social distancing, how to prevent yourself from infection through the distance, social distancing through in the mosque, in the malls, and in other places. Also, we do not forget our elderly people, our parents. We have dedicated campaign for elderly people, for parents, so that we can take care of them, we can give them the information regarding how to prevent themselves from the COVID. Also, we have a campaign dedicated for the vaccination, and also campaigns in the stage of recovery. The recovery stage, we have also another campaign. We do not forget the non-Arabic speakers and other nationalities. We have more than 11 languages. Our materials produced with 11, I think more than 11 languages. This is also the كلنا مسؤول, the right lower side. This is one of the campaigns investing in the responsibility of the community in preventing the disease. Also, we use the sign language for people with speech and hearing disabilities. During that period, we have daily joint press conference, participation in the media outlets. We have also outdoors banners in different schools, in different main streets around the kingdom. Community engagement, we use, as I said before, facilitate two-way communications through 937 hotline, and using also a interactive chatbot and WhatsApp. Also our application, Sahhati and Tawakkalna, there is a chance to, if you have any inquiries or question, and there is prompt answer to this question. As I mentioned daily, one of the community engagement is joint daily press conference to the public, coordination and cooperation with the NGOs, with the mosques, with the schools, universities, and the malls. Also, we have specific line to make our opinion leader in Kingdom of Saudi Arabia and the social media influencer to participate with us. And also we have several initiatives for community volunteers. Let me return back. This is a very important point. We have also what we call it social media listening. We listen to the social media, monitor the social media, and see what is the opinion and the inquiries coming from the social media through the community. Hajj and Umrah, I think most of our speakers talk about it. It's a very critical situation. We use the same RCC strategies, tools, and message, but with more focus. We use what we call it bottleneck strategy. The bottleneck strategy, that means where is the the most gathering of the pilgrims, usually in the airports, in the land ports, and the seaboards. So we focus our communication on this side. This is our partners, plus 45 government entities, NGOs, and community initiatives, and also the private sector. This is some example about the process evaluation. For example, we have more than 400 million impressions, plus 13 million interactions, and 6.6 billion awareness SMS message with more than 11 languages. Ministry of Health website also we have enough. I think it's a good interaction. We have more than 1,450 television and media appearance, plus 99 million people benefit from field awareness campaigns in the primary health cares and malls, and 32,000 volunteers participate with our campaigns. Regarding the Ministry of Health application, Sahati application, more than 6 million, they have COVID test requests through the application, more than 700,000 vaccination requested through that application, and also plus 1 million medical consultation, and more than 150,000 electronic medical prescriptions through the application. The 937 during that period received more than 24.5 million call, most of them related to the COVID pandemic. And also in the primary health care, we have every month around 400,000 activity around the kingdom. This is this is one of the cross-sectional surveys done on more than around 5,400 individuals in Saudi Arabia regarding the knowledge and awareness about the COVID. We found that 76% they have enough knowledge about the symptoms. 89% they know how to respond if they have a symptom. Also, 51% of the population know who's the higher risk group in the COVID. And also, lastly, 58% of the overall knowledge of the COVID in this sample was 58%. That is above the average. This is also the satisfaction. We can find that 81.5 from the sample, they are very satisfied. 15, they are satisfied. And they think that Ministry of Health response against any rumors related to the COVID.
2 minutes left.
Okay, the last 3 slides. It was 82% they said that Ministry of Health was fast. When the survey asked them what is the most trusted site or sector in Saudi Arabia regarding COVID, 92% they said the Ministry of Health. This is the last 2 slides. First, the experience of Saudi Arabia and RCCE response to COVID could serve as a model for other countries, particularly regarding digital solutions. Multidimensional and multidisciplinary and multi-sectoral strategy is a major approach to successful RCCE. Infodemic management should be an intrinsic and vital component of any RCC strategy. It also requires robust built-in mechanism to monitor and evaluate its initiative. And I think this is one of the gaps in our experience in Saudi Arabia. We have to more emphasis on the evaluation, monitoring and evaluation. The importance of investing in developing leaders and champions in RCCE at the central and peripheral levels. We should focus more on the sensitive group, vulnerable group, especially non-Arabic speakers, and the urgent need to develop Arabic educational resources for healthcare workers and others. Thank you.
Thanks, Dr. Abdulrahman, to present such successful story about applying multi-dimensional approach, and especially the area of using and investing in digitalization and using such community engagement, ensuring community engagement and partnership.
Thank you. Assalamu alaikum. بسم الله الرحمن الرحيم. حتى إذا أتوا على وادي النمل قالت نملة يا أيها النمل ادخلوا مساكنكم لا يحطمنكم سليمان وجنوده وهم لا يشعرون. صدق الله العظيم. With these 20 words, an ant communicated accurately to its colony in a caring tone the potential threat, which is the destruction of their bodies by the marching army of Prophet and King Sulaiman alayhi salam. It timely and precisely described the risk, its source, and its impact. In addition, it offered them a risk mitigation and prevention measure. So, and yet it was fair enough, and mentioning that the threat by the army is unintentional. Maybe the ancient fear for humans is the fear of the unknown. Whether like natural disasters or ambiguous phenomena. And today we have Professor Manaf with us to tell us about how to face the unknown. Professor Manaf Al-Qahtani is an infectious disease and clinical microbiologist physician. Currently, he is the chief of medical staff and senior infectious disease consultant and clinical microbiologist at the Royal Medical Services in Bahrain Defense Force. He obtained his Royal College of Surgeons Fellowship and LRCP, Ireland, trained as internal medicine at the University of Toronto, Canada, with both diploma of both American and Canadian board certification in internal medicine. He also awarded the fellowship of the Royal College of Physicians and Surgeons in Canada. In addition, Professor Qahtani received the American board certification in infectious diseases, as well as a master's degree in medical management from Tulane. I can keep going on with the introduction, but Professor Qahtani has been honored by His Majesty King Hamad bin Isa Al Khalif with the Prince Salman bin Hamad Medal for Medical Merit, and he is affiliated with several professional, national, and international organizations. So, Professor Manaf, please.
السلام عليكم ورحمة الله. صباح الخير. تحية من أهل البحرين لإخواننا وحبايبنا في المملكة. I'm very privileged to be back in Riyadh, a city that I have a passion. I was born in Riyadh. My family originally from Riyadh, but they have moved to Bahrain. And again, I'm happy to be a Bahraini as well. So in the next 15 minutes, I'm going to really share, it's a storytelling more than lecturing about risk, about the effective of risk communication. When Dr. Al-Qahtani had explained to you what you mean by effective risk communication, it's basically the exchange of information about the risk, about the disease, and its impact on the society, on a population. And the whole point from communicating those information is basically you want to promote a healthy behavior that's carried out by the individual or by the society, and that basically need the trust. And quite honestly, things I have learned when I was leading the COVID-19 in Bahrain, there are two learning lessons. So the number one is actually you need to understand the stakeholder. You need to understand the stakeholder belief, concerns, their knowledge, their practices, and at the same time, you need to establish a trust between those who have the knowledge, it's us, the expert, and those who have the authority, the in charge, the leaders, and of course, those who are going to be impacted by this risk, which is in fact the population. So if you, in the next just few minutes, I'm going to really talk about the Bahrain strategy or the framework that we have adopted in combating COVID-19. And hopefully in the next few slides, you're going to see a few examples. So basically, we based on 4 key principles or the frameworks of any risk communication. And the number one is the trust. Without the trust, you cannot build up on conveying the messages to the society. So a good example, in Bahrain, 52% of our population does not speak Arabic, and they're from the expat. And we had to engage them in our policy. So as Saudi and most of the GCC, most of our policy has been translated in their own language. Not only that, you had to understand their belief, their concerns, because most of the expats felt if they have the disease, they will be kicked out of the country. Not only that, even the government of Bahrain, the first 6 months, have invested what we call it the economic stimulus package that costs around 11.4 billion US dollars to kick on the economy for the first 6 months. So the trust is basically, it's acknowledge the unknown. We have to be humble. During the first few months of the pandemic, no one knows about SARS-CoV-2. And you have to address this to the community, that there are so many uncertainty, and your policy might change based on the new information that might evolve. They always say the trust is easy to lose and difficult to keep on. And you need to listen and to be aware of the public concerns. The next strategy of the framework is actually to announce early. In Bahrain, we launched what we're going to show to you, the command control room for the first time in the Kingdom of Bahrain, 3 weeks before the first case of COVID-19. And that was a multi-sectorial from different sectors in Bahrain. And the whole idea from announcing early is to be prepared, is you need to engage your community about your plan. You need to provide them the roadmap, and I'll show you the traffic light system that we use in Bahrain. When you're going to shut down the services, when you're going to reopen, you need to engage the business sector, you need to engage the educational sector. This is very important, even in the early of the pandemic. And of course, understand the public. Again, in Bahrain, we have, like in Saudi, we have religious event. We had to make a good communication with the religious leaders, with the tribes in the villages. We had to go down to their level, explain to them what would be the risk of not adhering to the public health and the threat of this virus. And the key message is the behavior of the virus was linked to the behavior of the individual. And the virus was never linked to a religious or to a sectarian, neither to a belief. And that was a very important message so that the public can understand. In our community, like in most of Muslim countries, it was very difficult to shut down some religious event. So you need to protect, you need to provide them with the tools and explain to them how they can run those events safely. And of course, being transparent, and that's the most important thing. We had the dashboard for the first time in the kingdom that tells you exactly the number of the cases, that tell you exactly the number of the ICU and even the death. You can find it in your mobile. And the whole message was not to transmit the fear, but rather than to engage to the public to their behavior. As I say, the behavior of the virus has been always linked to the behavior of the individual. So to make it short, His Majesty King has issued a directive to have all the testing and the treatment, including vaccination, to be free for the whole Bahraini and non-Bahraini. And I think that was a very important message to be heard so that people can come and to be tested without the fear. We have also incorporated some local guidelines. As I said, you have to be innovative. Do not wait for other countries to kind of issue guidelines. You need to work on the data. I'm going to share some data that we have worked in Bahrain to kind of, what we call it is a data-driven policy. Most of the policy in Bahrain has been based on our local data. So basically, we had what we call it, since I come from a military, a war room. A war room is basically, it's a command control room that has multidisciplinary team. We work 24/7, engaging with every active COVID cases. And to be honest, We wish that we have that system implemented even in the non-COVID care. So we know exactly when the patient turned to be positive, when the ambulance is going to be transferred and take him from his location, let's say to the hospital, how long does he stay in the hospital, how many beds has been occupied, what's the outcome, and then until the patient gets discharged. This is a daily dashboard that we have it, didactic and every day. We have dedicated 24 COVID facility completely separate than the normal hospital, so we have never compromised our patient care. We had around 850 COVID beds. Out of those, 350 ICU. And we know, even before the first case that has launched, we know that the threat going to come from the outside, so we had a rigorous testing at the airport. We have never shut down the border. We have never shut down the airport. So our strategy was based on what we know as is the 3 T's: testing, tracing, and treating. So Bahrain is 1.5 million population, so it's a small country, and we had reached to 30,000 tests per day. And that just gives you the amount of capacity. So every single individual in Bahrain has been tested at least twice. We had 400 employees working in contact tracing. We have done over 1.2 million individual in contact tracing. And we had the COVID facility that provide most treatment, including the monoclonal and antiviral therapy. What is the most important thing about Bahrain is we had the first time the integrated health system. So we speak with the same language. So all hospitals in Bahrain, private government, has been linked, what we call it, to iSaha, so we know the history and the details. Just for the sake of the time, we had the multinational task force meeting every day. When we launched the mandate of the mask, again, there was a confusion at the beginning whether the virus has been an airborne versus droplet. But again, masking has been shown to be effective in reducing the spread of the disease. We have launched the home isolation in Bahrain, and again, you have to understand how difficult it is to tell the people to stay home. So 70% of the effective cases back then has been in home isolation. So we had almost 4 months to kind of launch the program, to educate the people about what to do and what not to do when they are home isolated. Again, we have done also the 70% working from home, and that's an important that the economy was running in parallel with all the risk mitigation. One of the key things we have done is to protect our community and our population is we introduced the ICRP program, which is the International COVID Repatriation Program. Almost 4,000 people has been brought from 25 countries safely. 6% of those has been infected with COVID-19. This is very important when I talk about the command room. So we went into the vertical approach. So the command room basically has a didactic team, and we have a link with each sector. So from transportation, so we secure the transportation that is dedicated only for COVID-19. We had a direct link to the ICU for the COVID-19, so we know exactly how many beds being occupied. With the vaccine, how many vaccines are available, what type of the vaccine, testing, lab, medical equipment, even human resources. We had to recruit people. We had to train our personnel in ICU care, because when certain time when you need more ICU people and most of the border has been closed internationally, we had to invent and train our local people to practice in ICU. As I said, outreach program and protecting the border. So this is basically our command room, and we have a representative from each sector. Traffic light system in 1 minute. I feel very positive about it. This is the roadmap. So again, we engage the community with our action, and we clearly tell them that it's up to you whether you want to shut down, have a lockdown, even though we never had lockdown in Bahrain, or you want to have this green, happy life that you can resume a life actively. So it's basically on the rolling average of certain cases, and then we went into the percentage of bed occupancy in the ICU. So each individual in the kingdom, whether you are a businessman, whether you are a professional, you know exactly which road we are heading. And actually that has been a very powerful tool to engage our community. So basically, green light means everything is happy, red means everything shut down, and in between means that it's restricted if you are vaccinated. And again, we have this colorful vaccination program. We try to maintain the freedom and the will of, for those who are not willing to take the vaccine, but at the same time, when you have a pandemic, you need to respect that you need to protect the overall society. So even though if you are taking the decision not to be vaccinated, you still can resume your life normally, but in certain occasions, like indoor activity, that will be very limited for vaccinated only. The stigma of being positive, we have addressed this very carefully in the Kingdom of Bahrain. We have a psychological assessment for those who has been stigmatized. Again, if you want to empower your testing, you need to remove the stigma of being COVID. And this is actually truly for any contagious infectious disease. And we have a dedicated team that can help individual who suffers from the stigma of being labeled as COVID positive. And this is my last slide. And sorry if I have rushed in the 50 minutes. We have almost had 43 data-driven policies, as I said, in Bahrain. Those has been gathered from the local data, and they are coming from the Epidemiology and Public Health Project, some diagnostic tool. We have done amazing work on vaccine trials. We had also done on the long COVID complication and monoclonal antibody clinical and treatment guidelines. And of course, we had the privileges to work with WHO and publishing 2 major articles or recommendations about aviation. And just sticking with the time, that was my last slide. Thank you.
Thank you, Professor Manaf. I think this is very interesting and informative, sharing the experience of Bahrain with the special focus on the how you manage uncommunicated risks. I liked really the innovative approach of the traffic light. Maybe we can discuss it later. So now moving to our next speaker, Dr. Fadi Makki, is a partner and director at Boston Consulting Group and is global co-lead of BCG Behavioral Science Lab. He established the first behavioral insight unit in the Middle East, P4 development, at the organizing committee of the FIFA World Cup 2022, and is a founder of Nudge Lebanon. He conducted more than 150 Nudge experiments to date in a variety of policy areas. He is currently co-chair of WHO Technical Advisory Group on Behavioral Insights for Health. He held previous senior positions in several private sectors and served as Director General both at the Office of the Prime Minister and the Minister of Economy and Trade in Lebanon. He holds his PhD from Cambridge University, master degree from LSE and Hull University, and bachelor degree from AUB and the Lebanese University. So, Professor Dr. Fadi will talk mainly on the science of nudge, a topic that I'm really looking forward to know what is it. Yes.
Thank you very much. It's a great pleasure to be with you today. Before I start, would like to tell you that coming to the field of behavioral science helped fuel my passion for behavioral change, but did something else, which is taught me humility, because oftentimes we could be wrong for what we plan to have, particularly on health policies. With this, let me start with okay. So I'll cover 4 things. I'll start with a brief introduction of behavioral science and recent trends in nudge. I'll focus on why use behavioral science in mega sports events as an example of mass gatherings. I'll share insights from experiments that I've conducted in mega sports events in the run-up to the FIFA World Cup, as well as during the event itself. And finally, I'll conclude with some lessons learned for scaling up use of behavioral science in mega sports events and mass gatherings. So traditional policy-making tools effectively think of behavioral change using either command and control. If you don't do this, you'll be punished, so a lot of penalties, sanctions, and reminders of that. Or, on the other hand, use financial rewards, or simply provide information. The assumptions being that people are rational, they're going to process that, and life is going to be beautiful. However, experiments show that we are not as rational as we think we are or as we thought we are. People have biases at stake that could lead them astray from effective decision-making that is in their own interest and that of their communities. So behavioral science and nudging provides a complementary approach to behavioral change. In particular, we use the term nudge, waqs, isja, hath, and so on. So we have about 28 words for the word nudge. Effectively, what that means, it means any aspect of choice architecture, handasat khayar, that gently pushes people in the right direction without forcing them, so maintaining freedom of choice, and without creating heavy financial incentives. So the use of insights from behavioral science, such as nudge, has become very fashionable, and became very fashionable especially with Richard Thaler winning the Nobel Prize in 2017 for his work. Examples of nudges: updating people's perceptions of the status quo, so giving them what we call social norms, telling them other people are doing this, or simply changing the default. People are lazy. We use insight from behavioral science to understand that people procrastinate and go with the default. I'll give you a very powerful example of a nudge. When you order food on delivery platform, before the changes that happened recently, you get automatically plastic cutlery. You could opt out of it, but often people don't. They go with the default. So simply changing the opt out of plastic cutlery to opt in could really make a big change to plastic use. And this is one such example. We used it some 6 years ago, before it became online, using it with call centers to get people to simply actively choose not to take plastic cutlery. Since 2010, there's been many behavioral science units set up around the world, and recently coming in the region, you've heard about the nudge unit of David Cameron, 2010, of President Obama, the White House, and there are so many here, especially in Saudi Arabia, in the MEP, in the Riyadh Center, the Ministry of Public Health as well. And it's been used in a variety of areas: in community compliance, getting people to reduce speed, stop at traffic signs. In health, particular innovation has been used during the COVID vaccine, not only at the initial stages to increase social distancing, but also in mitigating the impact of the pandemic, such as facilitating access to mental health because of the stigma that was around that during the social distancing and the isolation. But finally, it was a lot of innovation using behavioral science and nudge to increase the vaccine uptake. But it's been used to facilitate female participation in labor force. You've done great experiments in Saudi Arabia on this, on sustainability, on tax and organization transformation. Essentially, we use 3 steps in behavioral science and nudge approaches. The first one, we dissect the challenge to look at what gets people to tick or not. So we look at biases at stake. We do a behavioral map. We do a mapping of the journey to see what are the entry points for introducing nudges. And then, because of that superior understanding of the situation, we are in a better position to introduce nudges that change people's behavior. We use a model called shape difference to basically introduce nudges. And finally, what makes behavioral science science-driven and as evidence-based as possible is that we test, because what works is not what we think works, but what has been tested to work, ideally in a randomized controlled trial setting. So nudge and mass gathering can be unique opportunities for showcasing the power of behavioral science for a variety of reasons. First, many of the human biases that we know of, present bias, overconfidence, herding, and so on, could be accentuated with a multiplier effect in mega sports events. Second, nudges could be very powerful and cost-effective, and could be, especially in recurring sports events, like leagues and so on, could be amazing in harnessing habit formation, which is extremely important. And finally, experimentation is the way to go. Examples of many of the biases that are accentuated during mega sports events, such as overconfidence, that we might not be caught smoking in prohibited places, or basically herding unsocially desirable behaviors because others are doing it, or simply kind of being hassled to take our litter and use it properly in the disposable bins, or simply being presently biased, eating unhealthy food, because, of course, a lot of the NCDs are not immediately displayable. So using nudges in mega sports events is becoming a must. Many of the challenges that we face in the whole journey of a fan has a behavioral component, and therefore addressing it with only conventional weapons will not work. It is good value for money, and finally, it's as evidence-based as can be. What I'm going to go over now is take you through a typical journey of a fan before the event, on the way to the event, during the event, and after the event. And I'm going to focus on some experiments that I've led in the run-up to the FIFA World Cup that could be very illustrative to explain this. So the first one I'm going to talk about is one example in the run-up to the FIFA World Cup where we were trying to encourage volunteers to come and support. But what we saw is that many of the volunteers were overemphasizing and overstating their language skills. So the experiment was how to get them to be honest about their language skills. And the experiment, which was done with about 10,000 people, led to increasing the number of people being more honest about their language skills. The nudge was to put for the treatment group a simple box where they click and say, I agree to tell the truth during the application form. So that was the one experiment in the run-up to the FIFA World Cup. Another one that was done in the Arab Cup was to get people to use public transport, be more willing to use public transport, using social norm, by first of all telling people that more people have been using public transport and seeing the effect of this on a treatment group. A similar experiment was done a few days after, just by checking how social norm could have an effect on perception level. We asked people to see how much perception they have of others using social norm. It turned out that the higher the perception level, the more are willing to take public transport. Another example of using social norms and using nudges for the ticket holders was either targeting those that already have a ticket in the country or those coming out of the country. So supporting carpooling in the case of locals and supporting visitors to use public transport. On the way to the event, I'm going to stress one very powerful example that we did in the run-up to one of the events, a marathon, whereby we checked people's blood pressure. But what's very important about this is in the NCDs, there are three main stages. Addressing the risk factors, there's a lot of behavioral science at this, eating healthy, physical activity, but there is the second part, which is the most important one, which is the early detection. And mass gatherings are an amazing opportunity to facilitate that early detection. So in that event, what we did is people who were coming to gather their badges for the marathon, we asked them to play a game of dart. And the interesting thing was that 76% of those that had high blood pressure were unaware of their situation, which is pretty high. But then we did it as a randomized trial to check which ones are likely to go and do a double check and reading. And it turned out a simple reminder increased by 17.5 percentage point those who would come and check again their blood pressure. During the event, there was so much that we did in the run-up to the FIFA World Cup, one of them on littering. So we divided some stages into sections that had simple reminders of asking people to take the litter, leading to about 18% compared to control group in stadium sections. Another one where we simply placed QR codes also to get people to sort properly. And you've seen the effect was slightly higher in post-match as opposed to during the match. And it even had an impact in basically when you told people to help them achieve our sustainable target in the littering. That's also another example we did in the disposable behavior, where we asked people in the Club World Cup to a simple reminder when they use the dustbins to do good and recycle right. So reduce the number of incorrect uses and increase the number of correct uses of disposable bins. But for those of you who have been in the World Cup, this is probably one of the most interesting experiments on healthy eating in the World Cup. I don't know how many of you have visited the World Cup during the event.
You have 2 minutes.
Yeah. So this is an experiment where we basically randomized stadium into control and treatment. So those that had the treatment, the nudges was to promote healthy eating. So first of all, 30% of the food was guaranteed healthy, which was already a big achievement from previous FIFA World Cup. The second thing, we reordered the food by healthy kind of components. But thirdly, we use salience and priming to highlight those that are healthy. So the fatair with spinach and meat were healthy, veggie sticks and veggie rolls. And then we used wobblers in the kiosk, and the results were fascinating. In some cases, more than 100% difference in the effect of nudges on healthy eating in stadia. So 154% on using veggie sticks, healthy fatair about 24%, and veggie sticks 41%. Scaling up the use of behavioral science is very important. Through orders, President Obama did that 1 year after setting up his nudge unit, did an executive orders. The Secretary General did something similar, and recently the WHO did that through the behavioral science for better health resolution a few months ago. Lessons learned, there's so many potential areas for using behavioral science. Building capacity is extremely important for the organizing committee as they work to prepare for mega sports events. Starting early is very important. It's not an afterthought. There's so much we could have done more had we started even earlier working with the various units. Endorsing experimentation. But experimentation needs to happen innovatively, of course, but needs to happen ethically. So abiding by ethical standards when conducting experiments is extremely important. Finally, so many lessons learned have been done conducting experiments in the sports event. The importance of collaboration between behavioral science units is extremely important. Thank you.
Thank you. I can see the smart link between the behavioral and social sciences, what we are talking today about, which is the mass gathering events. I'm sure that this approach can be applied for others. So our last speaker, a very dear and friend, he is a real public health leader, international public health leader, Professor Duncan Selby. He is the president of the International Association of National Public Health Institute, IANFI, since December 2020. He is the founding chief executive of Public Health England, now known as UK Health Security Agency. He has been the executive board member of IANFI since 2016 and with many roles since then. Prior to that, he was chief executive for many hospitals in the UK, and other appointments include honorary professor at the Robert Gordon University, Aberdeen, professor at Chester University, companion of Institute of Healthcare Management, honorary fellow of the UK Faculty of Public Health, and now he's chief advisor to the Public Health Authority of Saudi Arabia, ITQAB. So, Professor Duncan, mic is yours.
Assalamu alaikum. Thank you. I think it's still the morning. Good morning, everyone. To Professor Fadi, I think the future of public health is behavioral science. We're talking here principally about infectious diseases, but we are talking about all of the non-communicable diseases as well, and about how does risk communication contribute, and behavioral science is at the heart of that. I only have 5 minutes. I'm going to be very fast. I'm going to summarize, I think, some key messages, not as a scientist, professional risk communicators that we've heard about today, but as a chief executive, 25 years of 4 different organizations and 8 years as the chief executive of Public Health England. And during that time, we experienced the Ebola outbreak in West Africa, and many other events of international importance, and of course COVID most recently. I did also want to say that as a resident of Riyadh and of Saudi Arabia, I'm very proud to be here and of the exemplary experience through COVID that Saudi can share with the world, and listening this morning as well about Bahrain's experience to convey my congratulations. So to summarize, I think there's so much to be proud of about what's being conveyed this morning over yesterday. Obviously so much to do and so many lessons to learn. And so I've got 4 or 5 that I just wish to quickly share. The first is the importance of science and evidence, and not deviating from the science and the evidence. Being honest and clear about what the risks are. We know that there are risks in just about everything. Nothing is 100% safe. And we need to hold the trust and confidence, the consent of our people. This really matters, and it works. We need to be clear about what we know and equally clear about what we do not know. And as we're talking epidemics and pandemics, but as we learn dynamically, we can say more, but it's just as important to say about what we don't know as that we do. Many have spoken about the importance of clear and simple language to describe the actions that people should take, because we're not talking to scientists and other public health professionals. Well, we are in a way, but we're talking to the public and we're talking to politicians, we're talking to the media. We need to use language that they understand and make sense, not because they're not intellectually capable, but because this is not their world. We need to be honest about the trade-offs that exist between what might be good for your health and what might be good for the economy. These are not always the same things. They have to be balanced, and they're not always decisions that will be made by public health professionals who advise, but politicians will decide. There will be trade-offs, and we need to be honest about those. So who do the public trust? Who do they trust the most? Well, in the West, they don't trust the politicians. They will trust doctors, they will trust scientists, most of the time, but not always. So the use of influencers, others have spoken of this, but celebrities, leaders, community leaders, religious leaders, people who they relate to convey the messages. And vitally and finally, as spoken just again by Professor Fadi, we need to use peacetime to build understanding and resilience. If we wait until it's all already happened, it's too late. We need to be building this understanding and this learning for the next time, which will inevitably come. We've been in a cycle of panic and forget. about so many major outbreaks over the years. And this time, we have to learn so that the next time we're better ready. Thank you.
Thanks so much, Dr. Duncan, for such informative speech. Now the floor is open for any question. The mic.
Thank you very much for the nice presentations from the five eminent speakers. Just want to link the first two presentations together about the risk communication and the infodemic. And also, by the end of my speech, I will link the last two presentations. The first two presentations, interestingly, let me get back to MERS, Middle East Respiratory Syndrome Coronavirus, which emerged in 2012. And how did we deal at that time with risk communication? The only missing part from the risk communication and talking to people was the daily media press by Dr. Abdel Ali. Dr. Abdel Ali in the COVID-19 had the effect on communicating with people. In MERS, we used to have daily media press. We send a number of cases to journals and announce it. Yet there was debate among people about rumors about MERS-CoV and also infodemic from that time about MERS-CoV. And if we compare COVID-19 infodemics to MERS-CoV infodemic, we can notice that, as I told previously, the missing part was direct speak to people via television about number of cases, the hazard of the disease, the effect of the disease, and the impact of the disease itself, and the causes behind the disease. And the last two speakers, I just want to ask one question. What is the most effective tool for defeating the rumors about the disease from the experience of Dr. Fadi and Professor Duncan? Because we used all the tools, but we don't know which one is the most effective one from the your experience. Thank you very much.
Thanks, Dr. Mahdad. Thanks so much for raising such important question. Before moving to our panel, if there's any other question, okay, maybe it will be the last question we receive before ending our session.
Thank you. My name is Dr. Kieran Attridge. I've recently relocated to Riyadh from the UK and worked on the COVID response on behalf of the Royal Air Force in the UK. My question is for Professor Selby. I absolutely take your point about not deviating from the evidence and the science, but where do we go when our trusted professionals are deviating from that, when we have our trusted healthcare professionals particularly who wish to challenge the orthodoxy or don't believe in the evidence that's being presented by the central government?
Thanks so much. Let us move to our distinguished panel for very short comment about this question. So we can start with Dr. Ahmed.
I think the points which raised by Dr. Mu'taz about MERS and COVID, the difference between that, I think the building the capacity during this year from MERS to COVID help us to deal with the COVID more better. In the governance regarding to risk communication, there is a committee from all sectors dealing with these rumors, detect these rumors during COVID and try to design the message in the right way. And I think we need to more invest in this to be prepared for the next threats. Over.
Thanks so much, Dr. Ahmed, and I completely agree about the role of risk communication during responding to MERS, and you did a great job to control spreading of the MERS during that time. Moving to Dr. Abdurrahman, if you have any comment.
Regarding what is the most important tool for combating the infodemic, I think the answer is there is no one tool. It should be comprehensive tools. Two-way communication, this is very important, depending on the opinion leaders in the society, depending on the social media influencers, and we have a good experience in Saudi Arabia during COVID. This is another approach. You have to be first, you have to be proactive, do not wait until the rumors spread and distributed around the community. No, you have to be first. The second thing, you cannot completely shut the rumors or the infodemic, but at least reduce reduce the volume of this infodemic. So my answer, I think, is there is no one tool that can be done. It should be a comprehensive view. Thank you.
Thanks so much, Dr. Fadi.
Very quickly regarding misinformation during COVID, 3 things we found very useful. The first one is always acknowledge and then refute. And we use something called psychological vaccine. For some of you who might have seen my recent publication, that's very powerful. It uses, just like the biological vaccine, a weaker version of the kind of misinformation and then basically using it to refute, which we found very powerful, increasing resilience against misinformation. And finally, we've also used in COVID the triggering of what we call cognitive dissonance, just reminding people that they've done something similar, different vaccinations, so this is not in many ways very different. So these are 3 things that we used very powerfully in an experimental way during COVID, and they were very effective.
Thank you so much. Dr. Manaf, if you have any comments.
Well, I think my take-home message, to have an effective risk communication, you need to understand your stakeholders' belief, perception, and practices. And you need to establish a trust between 3 parties that I have mentioned. Number 1 would be with the expert, and number 2 with those who have the decision and the authority, and number 3 with the public, which is the population.
So on what matters, there'll be 4, 5, 6, or 7 things that you might do, but the one I would choose is transparency. So being as open as possible, sharing what you know, what you don't know. To my colleague about differing views about the science, I think it's very healthy. I can't think of a situation where there is an open argument, and through argument you tend to get better decisions. But we have to tolerate each other's view of the world, and nobody owns the whole truth, and somehow by openness and transparency and engagement you get to the best truth that you can, and often on imperfect information. So I would say it was a sign of a healthy scientific debate where there is disagreement and that people feel able to say what they think, but ultimately we need to make decisions and we need to get things done, and that's where politicians and public health professionals come together.
Thanks so much. I think during this session many topics have been covered related to risk communication and community engagement. I just want to highlight the major points which we'll work on it based on our discussions, the infodemic management, including social listening, and it's important, of course. We have to know, to study the knowledge gaps, and maybe we can design a research agenda related to risk communication, community engagement in the event of mass gathering and global health security. Also, we have to work to capacity building, as it was highlighted, including availability of different guidelines, and also sharing experiences. During this session, we had such an opportunity to listen for different opportunities, for different events, and I think this might be needed in the coming future. And by the end, we need to ensure there is a tool for monitoring and evaluation of such very important activity. By the end, I would like to thank all of you, our distinguished speakers, and of course, all our participants for such active participation. Thank you so much.
Thank you, everyone. On behalf of organizing committee, I would like to thank our esteemed moderator and our valued guest speakers. If you allow us for a group photo, please. Our valued guest, it's now the time for the lunch break, and we will be commencing our third session at 1 p.m. Thank you so much.
dünyadan göçüp giderse boşa gider mi de gözyaşlarım şu dünyadan göçüp giderse boşa gider mi de gözyaşlarım
Good afternoon. Ladies and gentlemen, welcome again as we continue with our third session for today about laboratories, capabilities, biosafety, and biosecurity. Please welcome with me our distinguished moderator, Dr. Samira Al-Juhani and Prof. Ali Al-Sumaili. Dr. Samira, she is the head of microbiology and virology, Department of Pathology and Laboratory Medicine, and a consultant microbiologist in King Abdulaziz Medical City. Dr. Al-Juhani is also an associate professor and associate dean in King Saud bin Abdulaziz University for Health Science. Prof. Ali Al-Sumaili, he is a highly qualified medical microbiologist who completed the Canadian Fellowship and the American Board of Microbiology and worked as a consultant and teaching faculty at King Saud University College of Medicine. He has more than 120 peer-reviewed publications and an editor-in-chief of the Journal of Nature and Science of Medicine. Welcome, and the floor is yours.
Assalamu alaikum jami'an. I'm Dr. Al-Juhani. I'm the director of the lab at National Guard Hospital. It's with a great pleasure to introduce Dr. Maram Al-Ataibi. Dr. Maram is the president and the CEO of the Health Support Services Center, and she's the leader of the Red Biotechnology program at Ministry of Health. She held several leadership positions at King Saud University and King Saud Medical City, including as associate professor in medicine, consultant molecular genetics, and the director of the genetic services at the Ministry of Health. Dr. Ataibi, she received her bachelor degree in genetics at the University of Arkansas, and before receiving her master's degree and the PhD in molecular genetic and oncology at George Washington University. It's with great pleasure to introduce Dr. Ataibi, who will be talking about transformation in lab medicine.
Thank you, Dr. Samira. It's my pleasure to be here with you. I believe I have a small presentation. If the team can have it on. Good afternoon, and thanks for having us this afternoon. It is a pleasure to be here and to share with you the lab transformation in the kingdom, as well as the Ministry of Health. Here's an overview, a brief overview of today's talk. I'll go and briefly say who we are and what we do, as well as our success story when it comes to COVID, our excellent operation and transformation that happened and occurred during the pandemic. The last is I'll talk about major lab transformation projects that will take place in the next few years. Who we are. In 2022, His Excellency, the Minister of Health, has actually mandated us to start what is called the Health Support Services. The Health Support Services contains the laboratory services, as well as the blood banks, the forensic, as well as the biotechnology. The way we operate is vertically and horizontally, where we have the operation, the digital, the supply chain, as well as the equipment counter with the healthcare services. Our vision is to ensure the delivery of our product, laboratory and blood services at its highest quality. Our mission is to be the global benchmark for laboratory services as well as for blood and forensic. We've done it. We've been the global reference when it comes to COVID. We were cited more than 1,000 publications when it comes to the Kingdom journey in COVID operation. Here is a small history of our journey. We started in 2020 with a mandate on COVID operation. In 2021, we started our governance, an advisory committee or supervision committee that acts as a board. 2022 was the establishment of the support health services within the Ministry of Health. We continue to provide excellence in providing the services that is contained within our scope. Allow me to share with you our story in COVID. Our story in COVID is special. Was one of the toughest operation anybody can go through. There's no manual anybody can give you to tell you how you deal with it. The story starts with dealing with the unknown. You don't know when a mutation will come and when the plan needs to be in place. So we started our command center to ensure that there is a one centralized command center for all laboratory operation across the kingdom. Pictures are shown here of the team behind COVID. COVID operation was not an easy operation, and it wasn't something that can be done in a daily basis, something that requires a special operation and a special way to deal with it, an ability to be agile, ability to switch testing from 1,000 to 100,000 in few days. تأكد Gen 1. We all got used and experienced تأكد Gen 1. If you actually been in the kingdom, you know what are تأكد locations, are the drive-thrus across the kingdom. 23 drive-through locations, 9 mega and 14 mini. It was the benchmark for global best practices when it comes to dealing with pandemic. These drive-thrus were able to provide the testing, PCR testing at the beginning, and later on, as we get vaccine approved, it was the site for vaccination. Today at Global Health, we announced the beginning of تأكد Gen 2. We're building on today's experience to provide more services rather than laboratory and rather than vaccine, and to ease and to give oxygen to the healthcare system. So the challenge at that time was how many tests we can do and how fast we can do it. Let me share with you some key achievement. More than 40 million tests was conducted in these sites and laboratory. We were able to do it in less than 18 hours from swapping till results. The second globally, right after Korea. We had the highest satisfaction during COVID with 94% of our customers. As I mentioned earlier, it requires a whole lot of back-end operation, the supply chain, the quality, the integration, the optimization. And we couldn't have done it alone. There was a whole ecosystem activated. Our colleague in Wiqaya was hosting our central laboratory sequencing facility. We were not able to test and sequence and send all of our positive samples to this laboratory in order for them to keep us all in great intact and secured when it comes to new mutations. You name it, Omicron, Delta, etc. These are one of my favorite slides. As I told you, the beginning of the pandemic was not easy. The left side illustrates how the situation was in June 2020. The TAT took longer than expected. The number of samples that needed to be done per 100,000 individual was a challenge. We looked at the root cause. We realized we need to have a centralized operation, a center command and control, as well as we need to ensure that this laboratory is operating with the highest quality, with the help as well of a team. In Wiqaya, we were ensuring that this laboratory, public, private, can operate within our quality premise. It was hard to have clear access on the kingdom, clear visibility and tracking. You're talking about 20 regions in the kingdom. In the middle, it shows our strategies. We immediately needed to centralize, to standardize, optimize, and of course have the digital enablement. The TAT was turned to be the global reference when it comes to COVID testing. We were able to get it in less than 18 hours for most of our tests. We had the lowest positivity rate, as well as we had the 12th globally to provide testing for its nation. You can tell that we went from 1 lab to 27 labs, the turnaround time, the test, the compliance as well. It's an ecosystem that was activated. The 937, the help and support of the digital, the ability to activate Sabahi, and as well CAB to ensure that this laboratory is working with the highest quality and standards. Quickly, I will touch on the current laboratory services and some of our next projects to get you all in the same page with us moving forward. Simply, we're gonna divide the laboratory testing to 3 levels. Routine, urgent, and non-urgent, that will be a cluster-based. A specialized testing that will be shared services, part of health holding company, and a kingdom reference lab that will deal with highly specialized test menu. This slide will summarize one of our key and mega projects when it comes to laboratory, the Kingdom Reference Lab, the Send Out Ayyinati, a digital platform where each citizen living here in Saudi Arabia will have his testing in his mobile in Sahati app. Ta'akkad Gen 2, a whole transformation when it comes to providing these health services. Digital pathology, where we're announcing at Global Health that our ambition is to have the kingdom 100% digital pathology by 2030. Definitely accompanying this, the biosafety as well as the point of care testing. Here's our scope, and due to time limitation, and I apologize, I'll run through these slides, but you guys are more than welcome to have a copy of it, and if you needed more further elaboration on it, I stand ready to provide it. And here are some key numbers that will tell you where are we right now and where are we heading for each project. And the efforts are taking place to minimize the send out outside of the kingdom. This is a brief on Ayyinati as well, and what does it do, and how is it going to enable us to have a visibility on all laboratory testing in the kingdom. Any lab done in the kingdom, in private or public, will be hosted at Ayyinati. Ta'akkad Gen 2 is providing more healthcare services to ease the access of healthcare services. This is the digital pathology. This is the biosafety as well program that we're working on with our friends in the CDC or Saudi CDC Wiqaya. Point of care testing as well will be a huge player in the next few years. I couldn't be doing this without a great team. So here's a picture of our amazing team in our annual gathering. Thank you again for your time. Thank you, Dr. Samira, and the panelists as well. And I'm sorry to take such a long time from you guys.
Good afternoon, ladies and gentlemen. It is my pleasure today to introduce the next speaker of the topic biosafety and environment. Our speaker is a graduate of Cardiff University in biological disaster. He is a deputy commander of corona pandemic at the Ministry of Defense. He had lots of collaboration and representing the country in many international agencies like WHO and United Nations. And he received many awards and participated scientifically in many scientific publications and conferences. Please join me welcoming Dr. Saud Al-Shahri.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. أسعد الله أوقاتكم بكل خير. بعد البدء I'd like to express my appreciation to Dr. Maz and Dr. Anas and his excellencies team for invitation. And hopefully, inshallah, within the next 15 minutes that you can gain some information about biosafety. I have no doubt that you have knowledge more than me in biosafety as you work in the hospitals. So this is my agenda for this presentation. As we heard of, some presentation in the last sessions, they were talking about COVID, which is pandemic, which is unique in our lives. So according to the lifestyle, the technology that we have in our life nowadays, the scope of biorisk is huge nowadays. So how to control this spectrum of biorisk? We have to control it by biorisk management, which is cover the public health and biosafety, biosecurity. This is the three subjects can be controlled, the biorisk. Biosafety and biosecurity are complementary to each other. Therefore, the concept of biorisk management raised nowadays, which cover all the spectrum of biorisk. This is the definitions that this slide I use it for my presentation, for the presentation that I've done. Each of them has own definitions. But let me to summarize the definition for each of them. Biosafety, it's how to protect yourself and your community from the pathogen. Whereas the biosecurity, that protect the pathogen from the human or from yourselves. Mainly, we'll talk about the biosafety and we'll let the biosecurity for the my colleague here in the panel. Biosafety has three main elements, which is lab practice, technique and safety equipment, and facilities design. If you have no strong biosafety, that means your public health system will not work effectively. Why biosafety is important is to protect our worker in the lab or in the hospital, therefore will protect our community outside. Therefore, many international organizations, they produced many guidelines for biosafety. As I said before, to control the spectrum of biorisk, the international organization, they have efforts. For example, WHO, they produce what you call the IHR, International Health Regulation, which entered into force in 2007. And the United Nations Security Council, they produce a resolution 1540, which entry into force in 2004, and to control the weapons or the what we called it terrorism or bio attack by using the organisms. That the United Nations produced Biological Weapons Convention, which is entry into force in 1975. Biosafety level distinction are based on design features, construction and equipment, practice and operational procedure required for working with agents from the various risk group. Biohazard agents may be classified by risk group that are required biosafety precautions. The risk group classification is used for lab work only. What I believe each country should has their own risk group to define the biosafety level or precaution. This table shows you the fourth group. WHO classified the risk group to 4 groups. The first one, which agents that are not associated with disease in healthy adult human, for example, Escherichia coli. This group can be use the minimum safety measure, whereas the risk group 2, that is agents that are associated with a human disease, which is rarely serious and has preventive and treatment for it. Such examples such as influenza A, measles, and dengue fever. The lab personnel can carry out the diagnostic test on the specimen, but need wear gloves and facial protection and gowns. This is mean to raise the precaution in this or to deal with this group. The third group that are associated with a serious or lethal human disease such as SARS and tuberculosis, Rift Valley, which has high individual risk and low community risk. The precaution here is more high than the risk group 2. The fourth group, which are likely to cause serious or lethal human disease, for example, Ebola viruses, and there is no bacteria in this group. It is high individual risk, high community risk. It requires team to wear positive pressure personal suit with the scalded air supply. Extreme isolation precautions are mandatory. Therefore, we divided the biosafety level to 4 levels. The biosafety level 1 and 2, 3, and 4. And this is the example for the biosafety level 1. which is important to concern about the access control and the sink for hand washing. It's basics. The biorisk or biosafety level 2 lab, it's easy to see that the autoclave is outside of the lab, but mainly we have the access control and bio waste beside the safety cabinets. The third level, which is biosafety level 3, it's more restricted. Should be all the windows must be sealed, and we have 2 doors. And also, you can see the autoclave inside the lab, not outside of the lab. It's also use the biological biosafety cabinets with HEPA filter, and you can see the directional airflow from outside to inside the lab. The fourth lab, actually, it's more restricted and more precaution than the others. This slide illustrates the relation of risk group to biosafety level and practice and equipment. This is the cabinets of biosafety, which are designed to provide both clean work environment and protection for the workers. Use airflow to create a barrier to airborne particles such as microorganisms, and use the HEPA filter to clean air going into the work area and outside the environment. Most important to put this label outside of the lab and for each equipment inside of the lab. This slide shows the table for the equipment and potential hazard and safety features for the lab coats and lab gowns, respiratory and gloves. I will stop here just to remind you that most of the lab workers, maybe you, most of you working in the hospital, you can see them, they can work in the lab, and when they go outside, they will not take off their the coat or change it. You can. This is mean they transfer the risk from inside the lab to outside the lab. Biosafety, sorry, has hazard identification to and risk assessment, risk management, and risk communication. But the backbone of biosafety is risk assessment. It should be considered a possibility of the material handled to generate infectious aerosol during the different procedures. We have to establish higher level of precaution and biosafety measures. Epidemiology is most important for disease and for patient population. Health immunity status of lab workers is more important as well. Experience for the lab staff using good, make sure they have good experience with the practice while handling infectious agents. The equipment biosafety features required to prevent and spill, breakage, aerosol generation with handling potentially infectious material. Maintenance of equipment and biomedical waste management. Most important for all of the assessment. This essential biosafety measure, the code of practice, most important to has lab access, responsibility for the lab manager, personal protective equipment, make sure that the personal protective equipment there, the procedure and the work area is useful for the people who work there. The equipment should be designed to prevent limit contact between operator and the infectious material, constructed of material that are resistant to liquid. This some of recommendation for design and facilities. And the training is the most important issue that makes sure that your staff have well training for with the policy and procedures. Transfer and shipping, it's most important to be planned. And the hazard material shipping, some material sent out, we have to follow or adhere with the safe packaging and documentation and transport. Packaging term, there are triple packaging, primary and secondary and outer container. We have to follow the packaging structure 602 and 650, and also with the UN approved. So the hazard materials has 9 hazard materials, but the important for us is class 6.2, which is divided to infectious and substances, category A, and biological substances, category B. This is the most important. As can be seen here, the category A should be has UN approved, whereas the category B, no need for UN certified box. Just I'd like to go through the Saudi Arabia efforts to establish the biosafety. Actually, we engage with the WHO for the joint external evaluation, and this is the excellencies team that work with in the 2017. As a leader of biosafety and biosecurity package, alhamdulillah, we have got the score 3 in both biosafety and biosecurity over 5. Saudi Arabia is one of the BWC states that signed earlier in 1972. And this is the articles of this convention. As Article 4, we have to establish our national measures. Therefore, we established the National Authority for the implementation of the chemical and biological weapons conventions. We work on these guidelines for biosafety and biosecurity at the national level. It is still a draft, and inshallah it will be appear soon, inshallah. Why still we said biosafety is important? As the head of the WHO, as we know him, he said that the world must be get ready for the next pandemic. So we have to be ready, inshallah, for any pandemic, la samhallah. This is some recommendation. Hopefully this conference will take in their count. We have to raise the awarenesses. We have to be restricted for the security control for the lab, monitoring and surveillance disease. We have to be cooperated with the other ministries and relative authorized preparedness and international cooperation for implementation BWC, enhancing transparency among stakeholders. This is the conclusion of my presentation. As Allah subhanahu wa ta'ala said, وَأَنفِقُوا فِي سَبِيلِ اللَّهِ وَلَا تُلْقُوا بِأَيْدِيكُمْ إِلَى التَّهْلُكَةِ وَأَحْسِنُوا إِنَّ اللَّهَ يُحِبُّ الْمُحْسِنِينَ. That means don't throw yourselves with your hands into destructions. That means you have to protect yourself. Therefore, we will protect our community. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Dr. Saud. It's my pleasure to introduce our third speaker, Dr. Abdulaziz Anjoun. I hope I said the name right. He's a medical virologist and certified health professions in infectious disease, a coordinator and principal investigator of the African Infectious Disease Multidisciplinary Research Group. He served as the head of the Department of Microbiology and the team leader for influenza and other respiratory tract viruses at the Laos State University in Nigeria. He received training in various international institutes, including Johns Hopkins, and he did his fellowship in Luxembourg School of Public Health for influenza viruses. He presented a lot of papers and research, mainly in viral pathogens, and he's part of the scientific committee for African Virology Network and the Middle East Influenza Group. Dr. Abdulaziz?
Thank you very much. Okay. Alhamdulillah wa salatu wa salam ala Rasulullah. So to start with, surveillance and laboratory services. What is much more important than biosecurity and biosafety has to do with surveillance. It is a very important phenomenon that all of us must be actively involved in. Lassa fever is endemic in Nigeria, Ebola in Africa, diphtheria has been talked about, starting from Nigeria, currently circulating in West Africa. Anta, Nipah viruses are all here in Asia. The SARS-CoV-2 also started from Asia. And that takes us to the outline. Classical etiologies for continuous surveillance. Why must every one of us be involved in surveillance? What are the roles of surveillance in laboratory services? To start with, surveillance is a French word that was adopted into English in 1802. It is the act of oversight or watching over. It is a dynamic and fundamental process, an ongoing systematic collection, analysis, and interpretation of data for public health dissemination and to develop local, national, regional, and international policies for three classes of people. Number one, to those who implement intervention and carry out public health action. Number two, to the public who need to have information in order to evaluate public health practice. And number three, to those who need information for personal action. Surveillance in laboratory services are more reliable data from the laboratory. And four major components are involved: data collection, analysis, dissemination, and response. We don't want this. Ebola. We don't want measles all over the world. We don't want the poliomyelitis anymore. Look at this. No one wants the Zika virus. And I'm sure no one here will raise up his or her hand to say, you want the diphtheria. The SARS-CoV-2, we do not want it. The MERS-CoV, we should be able to do surveillance and end it. Look at this. The Lassa fever from a village in my country, Lassa village. Look at the SARS-CoV-2. We don't even want the hunter, talk less of the monkeypox. So what do? All of us must support surveillance. Look at the classical etiologies that must be continuously surveyed. In this part of the world, the typhoid fever, the salmonella, the MERS-CoV, the diphtheria. In Africa, HIV. In South Africa, the Lassa that I mentioned earlier on, and several others, influenza, the SARS-CoV-2 that is still ravaging the world, the Rift Valley, the Nipah, the hepatitis E, and several others. This is the current classical etiologies, the 2023. The same set of viruses, bacteria, and fungi. And the work of Cassetti et al. At the NIH that was published just last week. The viral family that are ravaging the world, surveillance must be done for all of these. We are all, every country, every citizen here, all of your countries are involved in mass gathering, either for football, either for the Hajj, Nigeria, Saudi Arabia, India, Pakistan, mention the country. We are all involved in mass gathering. So why surveillance in laboratory services? We must do all year-round monitoring. We need the One Health surveillance in the animals, in the human population, in the environment. We need to monitor the classical etiologies. We must do genomic surveillance. We must monitor the mutation and the variants within the etiologies. Antimicrobial resistance must be monitored, and that was said yesterday. We must integrate to the level of point-of-care intervention. What about drug design and vaccine development? So all of that, we must do surveillance. The types. The active surveillance, the passive surveillance. Disease notification system, usually by legislation when you talk about the passive. And of course, on the other side, for active, targeted population are involved. The active include sentinel sites, while lab surveillance data when passive samples for diagnosis are involved for passive surveillance. We need to move. Roles of surveillance in laboratory services. For effective disease monitoring, to detect, to characterize, for signal alerts, and of course, to investigate epidemics. Either in relief camp, at the local level, at the national level, at the international level, all of these must be done. Microscopy, bacterial culture and sensitivity, typing, serological analysis, and of course, viral culture and monitoring of dangerous pathogens. It has been said at level 4, class 4, we must monitor the likes of Ebola, the likes of Nipah, the likes of Anta. The tools that we need for monitoring. We need to do whole genomic sequencing, next generation sequencing. We need to do hemagglutination inhibition. We need to be on ground to use the latest technology. We must be able to sequence from time to time. And we must be able to deposit the nucleotides being sequenced in the global gene bank. What are the best practices for laboratory surveillance? There must be clear guidelines on sample collection, sample size, transportation, all of that have just been highlighted, before now. We must look and maximize the representativeness, the quality, the timeline, and of course, continuity, of the surveillance. The use of variant-specific PCR for surveillance, We must do robust genomic surveillance. Standard protocols for analysis must be established. Sustainable laboratory for common pathogens must all be put in place in line with the WHO guidelines. The Lagos system. What did we do? We experienced the case of soya from Liberia into Nigeria. The entire government system was critically involved. From the presidency to the state governors, you can see the laboratory at the central role there. We can see even at the level of research and manuscript publication, advocacy and stakeholder management, strategy reporting, supply chain, operation, everyone coming together to ensure that active surveillance is achieved. And the same thing goes, for this. We can see in the middle, down research, we can see coordination, we can see the laboratory analysis. So at the Lagos State University, what do? We track all of those viruses, respiratory tract viruses. They are key in mass gathering. They must be monitored. Boca virus, RSV, influenza, human metapneumovirus, all of the respiratory viruses must be actively, surveyed at One Health. This is the European model. It's there. Once the slides are shared, we can all, follow up. Primary diagnostic testing, the NRL, and of course the surveillance and epidemic response. The same thing with these, so I go to the next because of time. What are the components of the WHO plan to strengthen laboratory infrastructure for surveillance? We need diagnostic and research reagents, modern equipment and facilities, continuous training of the scientists, the virologists, the laboratory personnel, rare expertise or capabilities, quality control and assurance practices, effective data analysis and management, and of course, regular communication. For laboratory-based communication in surveillance, all of these are very, very essentials. The ProMed has been giving us daily information, data on daily basis. The GISR is another critical example, supporting, giving us updates as far as influenza is concerned. The Salmonella, network, the Legionnaires network, and of course, publication and bulletins. Evaluation for surveillance system.
2 minutes
the following
left.
must be done. Oh, thank you. Expediency, accessibility, simplicity, flexibility, acceptability, and of course, results analysis. In conclusion, you all agree with me that surveillance is a fundamental and dynamic process, that there is need for integrated, targeted surveillance. That surveillance helps in epidemic intelligence, evolution monitoring, and signal alerts. We must all support Global One Health and mass gathering agenda. We must continuously be actively involved in robust genomic surveillance, strengthen laboratory surveillance networks at national level, at regional level, and even at international community. We must institutionalize multidisciplinary collaboration between all sectors. And of course, there must be trust and regular communication. And finally, we should all adhere to the quality control and best practices. I want to thank the GC, MGM, Dr. Anos Khan. I appreciate you. Thank you for the invitation. We met in Istanbul, and I was in the United States when I got the invitation. Thank you. Many thanks for that. I must thank my collaborators and my funders. Thank you all.
ladies and gentlemen, it is a great pleasure to introduce the speaker of the next topic, which is WHO Laboratory Biosafety Manual and Laboratory Biosecurity Guidance. It is our privilege to have someone who worked on this guideline, and she got extensive experience in research, diagnostic, and outbreak. She was trained in biology and specialization in genetic biochemistry and virology at the University of Greifswald in Germany. Please join me welcoming Dr. Rika Zinski.
Okay, thank you very much for the kind invitation. And I would like to thank the organizers for inviting us to present our project here at this conference. And I will talk about the revision of the Laboratory Biosecurity Guidance, which is the next big project after the LBM4 for the WHO Biosafety Biosecurity Program. Just a short introduction. So the first edition of the Laboratory Biosecurity Guidance was published in 2006. As mentioned, it's currently under the revision. So the second edition is planned with the publication for the first quarter of 24. Why do we need a revision? So in 2006, not only the times that passed since 2006 makes it necessary to revise that document, there has been also huge developments in the science and technology that need to be reflected in that document. Also, we have published in 2020, the LBM4, the Laboratory Biosafety Manual, with an evidence and risk-based approach, and this should also be applied to laboratory biosecurity. The document focuses on the prevention and the preparedness and less on the response. So also another aim of the document is to strengthen the institutional biosafety committees with their review and guidance function. The laboratory biosecurity aims at different levels. One is the lab level, the second is the institutional level, and the third is the regulatory level. Of course, as WHO, we are not able to do this on our own, so we have the support of an advisory group. The BEC, it was called BEC, provided expertise for biosafety since over 20 years. In 2022, this group was recharged and is now called TECB, Technical Advisory Group for Biosafety and Biosecurity. It consists of 16 leading international experts in the biosafety and biosecurity area. We are happy to have, for example, Professor Amar Ikram here, one of those brilliant heads in that group. And we also have some other members that contribute to that, and we have some external project matter experts. They help us here. We established 8 working groups to work on that document, and we are now in the final phase of the development. As mentioned already in the presentation before, biosecurity and biosafety overlap in most of the areas in the lab. For example, risk assessment, program management, inventory control, access restriction. There are some areas that are specific to biosafety and biosecurity. Biosafety, it's PPE, personal protective equipment, the primary containment devices, and SOPs. What more in the biosecurity area is cybersecurity, personal reliability, and code of conduct, for example. It was said in the last presentation that the risk assessment is the backbone of biosafety. Here's some similar slides. So we have developed a risk assessment framework, which I would call the heart piece of the LBM4, and also of the laboratory biosecurity guidance. So it consists of 5-step PDAC cycle, with gathering information, evaluating the risk, develop a risk control strategy, select and implement risk control measures, and then there's a review cycle that reviews the risk and risk control measures, and if necessary, or usually after a certain period of time, the cycle is repeated. For the biosecurity guidance, we have thought about the terminology. Usually the term dual-use research of concern is used to explain also misuse of biological science. We also think we think that misuse is one important aspect, but also the biosafety aspect. So the unintentional exposure and release of high-threat pathogens are important. And so we established or used the term high-consequence research instead of dual-use research of concern or dual-use research or just simply dual-use to address biosecurity and biosafety. As you have seen in the risk assessment framework, we also have this, we have this for biosafety and also for biosecurity. And the use of biological agents that have a biosecurity relevance in the lab should also trigger a biosafety risk assessment, which should also analyze those risks in the lab. What are the types of biosecurity incidents that we are trying to prevent or be prepared for? There are usually those classics that are involved with the biological agents, for example, the deliberate or accidental loss of those biological agents, or the unauthorized release or misuse of biological agents. Then there are also the classic disciplines of biosecurity, physical security incidents, such as the unauthorized access to labs, the theft of biological agents, or the sabotage of laboratory activities. Then we have personal-related biosecurity incidents. In the presentation before, there was mentioned that biosecurity is to protect pathogens from humans. So also those personal-related biosecurity incidents are quite important, and such as an insider-caused biosecurity incident, but also external threats to personnel and facilities are considered there. The next part is information security. Unfortunately, or very sadly, we experience more and more cyber attacks, not only to labs, not only to hospitals, but also to universities and other facilities, likely on a weekly basis. And the last but not least, deliberate events and wars. And there are also not clearly biosecurity incidents, but there could be situations that could facilitate biosecurity incidents. For example, labor issues or disputes, workplace violence, biosecurity breach, or natural calamities. Just have a little bit a look at the contents, what we are having in the laboratory biosecurity guidance. Of course, we have an introduction. I have also here in this table what kind of level is maybe most interesting for that section. Then we are starting with the reason why we were revising this document, emerging technologies and potential threats. So in the first edition in 2006, no one has heard about CRISPR-Cas9, but this is a common technique nowadays in the labs. And so also genetic engineering, gene drives, AI, or DIY labs are considered in that second section. Then in the third section, it's about the biosecurity program management. This is complementary to the LBM4 document about biosafety program management as a distinct monograph. And then also, of course, biosecurity risk assessment is one of the big sections in this document, and consists of, for example, of a biosecurity risk assessment template, which can be used in every lab, which can also be adjusted for the individual lab situation. Then, of course, we are talking about or mentioning biosecurity risk control measures, which are, for example, personal reliability. As mentioned, those are maybe the main issues for biosecurity. Then physical security, inventory control, and laboratory equipment. Then, of course, also the destruction, decontamination, and waste management, cybersecurity and information security, and also emergency incidents and response and prevention. Another one is also transfer and transport. Usually in the international legislation or regulations, only the biosafety side is considered, but also biosecurity is important in this issue. And of course, the last section is about the national and international regulation. We have there some kind of best practice developed. It's called the two-tier approach, which I will talk in the next slides. But there in this section are also examples of biosecurity legislation, and also the international frame is mentioned. This two-tier approach which was developed with the TechB members consists of two parts. So one part is the regulatory level, the other one is the institutional level. So on the regulatory level, an independent regulator is defining high consequence material, for example, pathogens, in a living document. This is also based on a risk assessment and can be revised as necessary. And then we have, then they should establish a national registry of biosecurity breaches, which is then fed by the institutional level. On the institutional level, so the players are the Institutional Biosafety Committee, the biosafety officer, and maybe scientists or other lab personnel who conduct and review local risk assessment. Also, their task is reviewing high consequence research projects concerning their feasibility and planned benefit. And also the IBC should review planned publications for biosecurity sensitive information. They both parts should have a knowledge exchange and should provide regular feedback to each other. And the regulatory level should update the national high consequence material list for the institutional level, and the institutional level should report back biosecurity breaches and feedback about high consequence research. Both parts inform in this way the laboratory activities. For the process of the biosecurity guidance development, we're working since mid-22 with the TechB on this document, and at the moment we are in the review phase. We have 2 rounds of review. The first round is completed and the comments are implemented in the document, and at the moment we are working on the external review. So we have about 40 reviewers and over 2,000 comments to be implemented in the document. And this will also change a little bit the scope of the document. And for example, we have some recurring recommendations to include in this document all laboratory work and not only high consequence, because also for maybe a simple diagnostic lab, biosecurity incidents such as a theft of a sample or so could also have huge consequences for them. Okay, thank you very much for your attention, and I would like to thank the TechB members for their work on the document and all the other contributors, then my WHO colleagues, my supervisor Dr. Kaz Kojima, and also Dr. Sabri Gemach from the EMRO office. And also, I would like to thank the participants of the Biosafety, Biosecurity and Deliberate Events workshop that we had last Friday as an side event of this conference. Thank you for your input and feedback and insights. And if you want to have more information, you can have a look at our website or contact Kaz or me. I'm happy to answer any questions now or later. Thank you.
Thank you, Ms. Rika. Last but not least, it's my great pleasure to introduce my colleague, Dr. Ahmed Al-Barrag. Dr. Ahmed, he is the Chief Officer of the Public Health Lab and the Public Health Authority with more than 20 years of clinical and academic experience in the field of microbiology and infectious disease. He's in charge of the genomic of infectious disease and the public health genome at the Saudi CDC, with a lot of administrative experience in the field. He's the chairman of the National Committee of Public Health Lab and the deputy chairman of the Scientific Council. And he is the Saudi Arabian representative for the International Association in Geneva, Switzerland. Dr. Ahmed will be talking about the National Referral Lab. Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh, and good afternoon, everybody. I'd like to thank the organizer for the invitation and the moderators for the nice introduction. Thank you so much. So we'll make it brief. So talk about the National Reference Labs and how this usually very important in terms of the acting during the mass gathering, pandemics, any disasters, and also to be a reference diagnostics facility within the country. So reference lab usually provide very high quality and efficient reference lab testing, but also provide good and very efficient surveillance, research, and also with the aim to advance testing, prevention, and control of diseases. So usually very high quality specialized services capacity, that's very important to be a reference, a national reference lab, and also the management of the laboratory-based data and reporting systems for the, which enable detection and also alerts of any pandemic or any emerging or re-emerging disease, and also keeping in mind the value of the rapid response to these events. And also provide referral testing services for agents that's considered to be highly pathogenic, that need high containment facilities, as mentioned before, as BSL-3, BSL-4 agents. And also develop a national quality management program, because this is also very important. You cannot deal with the lab testing without really focusing on quality programs and quality management within these labs. And also establish a very comprehensive lab information system where you can gather all data from other labs as a network across the country and make this data available for decision making and also for surveillance purposes. And then to develop guidelines, protocols, I think standardization of protocols, how the labs across the country should test and also report and investigate and use surveillance data in very standardized way, other than having data which is not really standardized, you cannot really report them together. And also the management of the waste, which is also part of the biosafety in the country. So usually we need an efficient and effective national lab system that's essential for achievement of the national requirements. And this is usually to control and prevent diseases and any communicable diseases or non-communicable diseases. And also, it plays a very synergetic role, not alone, but usually working with other labs in the ecosystem, including private labs, governmental labs, and also research labs in the academia. So usually, it's not one lab that can guide everything. So usually, you work in a very synergistic way with others. It can include communicable diseases or infectious diseases, and also non-communicable diseases, which today we know that it kills more people than infectious diseases. And also, beyond the human health, we also focus on environmental health, which is another factor that affects the human being, which is today we are speaking about one health approach, which includes the environment, animals, and human altogether, rather than just focusing on the human diseases. And also biosafety and biosecurity, biobanking, and the value of biobanking in response, and also in biotech development, and also emergency preparedness and response, together with our epidemiological and surveillance teams, and also data intelligence team, for better response to any event. And also policies and guidelines, training and education is very important to mainly for the workforce in the labs in specific areas, including the biosafety and biosecurity with 3 and 4. And also innovation and development in area of lab services, and also diagnostics and therapeutics, vaccine production, and others. Lastly is the partnership and communication with internal stakeholders within the country, but also with many other stakeholders outside the country, including WHO, as we heard from our colleagues working in the area of biosafety and biosecurity. So the scope is very, very broad, but it's also important to cover those aspects to have an effective and very efficient national lab services within the country. So usually it goes beyond the only sample testing. It includes different elements, and these elements should work together in a way to make the system running smoothly to achieve all the goals. So it's really including surveillance, good reporting system in very rapid, timely manner, and also the good communication of these lab results and surveillance data. Outbreak preparedness and response, and also fuel and enhance the research and development within the ecosystem. I will just mention the Hajj, which is one of the major mass gathering, I think the largest mass gathering in the country, but also one of the largest mass gathering globally. And in this event, usually having a good national reference lab that can support the efforts from other entities dealing with Hajj as one of the largest mass gatherings is very, very important. So usually it's involved risk assessment for what might happen, and that's usually done very early before the Hajj, and also rapid surveillance, plus rapid and efficient response in case something happened. So usually alert is very important, mainly for the infectious diseases. It's go through lots of planning, what is to be included for this season, what's the potential risk that might come with the Hajjis from our side, so you have to be ready. And also continuous monitoring and evaluation for these emerging diseases, and also focusing on the visitors from which countries and what epidemics running in those countries. So risk assessment is very important, surveillance, and also to be ready to respond. So you do alerts, preparedness, first response, very important during any instance that might happen, and also outbreak investigations that we cannot really prevent it sometime during these mass gathering. Genomic surveillance, one of the very strong elements today in terms of surveillance systems. So it is the era today where surveillance using genomics should be integrated in most of the pathogenic organisms, including respiratory viruses, but also in other pathogenic surveillance system. I think integration of genomic surveillance is very important. And this is what we are doing in Saudi Arabia. Since COVID, we really integrated the surveillance using genomic surveillance in most of our surveillance systems, including AMR, food poisoning, and food safety, plus the respiratory pathogens, and extended this to even more other diseases. So rapid detection is very important. Usually we estimate the risk, and we work together with other teams to say where is the risk with the priority pathogens, and work on these lists based on the mass gathering events. So usually that gets us to the same slide where we can go risk, respond, and also efficient actions. With the experience to really test this model, we participated during Hajj last time with a mobile infectious disease unit within not far distance from the sites of Hajj accumulate, usually in Mina and other sites. And it was very, very helpful and good experience where you can provide a very quick response and also report communication with authorities to take actions. Usually you focus on respiratory pathogens, meningitis, because those could cause an outbreak during the mass gathering, plus GI diseases and also the vector-borne diseases mainly during the some season where we can see an increase in such diseases. So usually for reference lab during pandemics, you have to respond firstly. So you have to be ready for day one response. So you cannot really say you cannot really respond because lack capacity, lack of people. So first response is very, very important. Plus continue to provide the capacity testing and enhance the services and capacity within the national level through coordination between the lab, different lab sectors, and also quality management system, specimen transportation and logistics. Usually this could be challenging during pandemics, but also very, very important also to take the consideration biosafety and biosecurity during all this process. Biological events could happen, not only to pandemics, but also could be disasters. So also you have to be ready for any biological events that might happen and to respond. And also history is there where we witnessed lots of pandemics and epidemics across the globe. We know that vaccines already introduced, so this did change some of the pathogens that we see, but still threat is there. So biosafety and biosecurity, I want to skip this slide because it has been covered nicely by our colleagues previously. So usually what we focus on is to have a program, and this program should have very important elements and essential elements in this program where we can really have an efficient biosecurity and biosafety program. With that, I conclude. National Reference Lab should provide quality specialized testing services and capacity in this regard, and also very early report and alert in case something has to be reported to the public authorities to take actions. Referral testing for advanced diagnostics and also for those highly pathogenic that need containment facility, plus synergistic role working with others to achieve this goal and very effectively contribute to the health ecosystem through training, innovation, and research. Thank you so much for your attention.
Thank you. Thank you, Dr. Ahmed. Thank you for all the speakers. We will open the floor for questions and start the panel discussion.
Thank you so much. I think very elaborative presentations. But I would, I'm Professor Amir Ikram. I've been the Chief Executive for National Institute of Health in Pakistan for the last 6 years. Fortunately, I am working with Technical Advisory Group for Biosafety and previously with Health Security Interface. And I've been also the chair of the board for International Federation of Biosafety Associations. With all that background, I think pandemic has opened up another avenue whereby, I mean, we have to move, as we just saw in some of the nice presentation, from red to green. So from biosafety to moving on to biosecurity. And the final thing that is something very, very important is the dual use. And dual use research, dual usage in the future. We are just sitting on the tip of an iceberg where CRISPR-Cas9 is sufficient for doing so many things. So I think the responsible conduct in science is the main thing that needs to be ingrained in all the minds, starting from the very beginning. And as we move on, we have just seen post-pandemic the changes within the WHO forming the BioHub, the different technical advisory groups that include this biosafety, the dual use, One Health, and SAGU, and so many others that are coming, especially the One Health. And I think One Health is the arena whereby we talk a lot about collaboration. We have to actually experience coming out of the COVID has to be made, converted into implementable strategies. And the key area is the dual use as well as the biosecurity, and that's what we are lacking. And not forgetting that we have a new standard for biorisk management internationally, which may be adopted by the countries, which is ISO 35001. So with all that, extremely grateful, highlighting to all the participants for this, this important gathering, and I'm sure the message will be taken on. Thank you so much.
Thank you so much, Prof. Thank you for the comments. Any comments from the speaker?
Thank you so much for the speaker. Very inspiring talk. Since most of the outbreaks and pandemics, it will start at the environment or the animal. So what do you think about One Health Lab? One Health Lab. So, I mean, we need to collaborate with the animal health, with the environmental health. At least we can do risk assessment. So, I mean, why to wait for the coming pandemics? MERS coronavirus, it is endemic, like among camels. So we can do a lot of risk assessment. So we don't need the lab to be the last, so for diagnostic only. So the lab, it can help us with risk assessment. It can help with surveillance. This number one. Number two, genomic surveillance. It will be the future of the surveillance. I'm public health physician. Most of our colleagues, they don't know the importance of the genomic surveillance, and in this case, it is high time for you to lead. This is my message for the panel. It is high time for the lab to be in the front. It is high time to have the One Health Lab in the country. This is your role to prepare, to respond, and be part of the pandemic preparedness era. Thank you so much.
Thank you, and maybe I'll ask Dr. Maram, Dr. Ahmed to comment about this.
Yeah, thank you for the comment. I think it's very important. One Health approach now is the way to go. We cannot really work alone and just focusing on the human health. Having them in one lab, that's different question, but what we need today is to link those labs in one network. And that's what we are doing now in Saudi Arabia. We have one health platform that connects data and surveillance programs from different environmental and also the human side. But agree with that, it's this where we should go really with the One Health approach. Most of the diseases, zoonotic disease coming, most of the human disease coming from the animals and also from the environment. For the genomic surveillance, as I mentioned, it's coming. Now it's part of many surveillance programs, and I think also very important to integrate genomic surveillance in our EBI surveillance. This will definitely enhance how we monitor and get early detection. One last point is what he really mentioned. I think integrating the lab within the EBI surveillance team is always very helpful. Talking in silo and labs separate from the epidemiological team and surveillance team, that's always compromise the strength of our surveillance. So putting all team together, talking to each other, part one team, that's also enhance our surveillance. Thank you.
Thank you, Dr. Aywa. Yes, yes.
Yes, I quite agree with the last speaker on the concept of One Health. You know, that was also mentioned during my speech that we need to, because studies have been published that most of the global pandemics and epidemic emanated from the animals. You know, what we usually have is the zoonotic transmission. So I cannot agree less with you that we must start the surveillance, you know, from the animals. We should be doing more at that level, working with the vets, you know, working with the environmental scientists, checking for the viruses, the bacterial, the microbial agent within the environment, and that will go a long way, you know, before getting to the level of pandemic. Not saying that we must wait until when we now have pandemic that the whole world will now start running up and down, but rather the laboratory should be at the forefront, you know, in active surveillance. Thank you.
I want to ask the panel just a follow-up question regarding the One Health. It is an approach, but it is to enhance and empower the collaboration and communication between different sectors. You don't have to have, do you have to have a physical setting in order to have all? But you can, instead of that, empower and enforce the collaboration, communication, and sharing the information on that time that you can take an action between the human, animal, and environment. This is my understanding.
And if you allow me, Prof, I think your question is excellent. And I will mimic it with current a book I read. It's called The Secret of Longevity. It says, if you diagnose a patient in the clinic with diabetes, it's too late. So similar case here. So if we diagnose something in our clinical laboratory, we're late. So 100%, and I agree with Prof and our colleague and the panelists here, it needs integration, animals, environment as well, public domains. If we all work together, then we can go toward that. So excellent point, and thank you.
Thank you very much. My name is Dr. Mash. I'm from WHO. And if Dr. Saud allow me, I think Dr. Saud is here, so I totally agree with the comment, so I'm not going to repeat what has been mentioned, but I would like to advocate about something mentioned partially by Dr. Amr, which is related to the DERG. I have, if you allow me to have two comments on your presentation. In addition to what you present the IHR, the Resolution 1540, and the Biological Weapons Convention, there is the new United Nations Biorisk Working Group, who are also working on this area, and they are focusing on deliberate events. And here, back again to what mentioned Dr. Ammar about the dual research of concern, that we really need to take it into consideration. Then I will add for the four, I will suggest to add for the four risks that you mentioned, which are mostly unintentional, is the deliberate misuse. It has been mentioned by my colleague Rika, but we usually don't think about this area, which is really progressing more and more in this. And that's why I'm sure you mentioned the Biological Weapon Convention. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Thank you for your comments. Basically, the three organizations that I mentioned, because they, for example, the WHO has about 192 states which already they signed for the IHR. The resolution of United Security Council also about 192 states also signed for this or try to implement it. Whereas the BWC, still there are some countries resistant to sign for this convention, and still we need to raise the mention about this convention to encourage the other countries to sign for this convention. As I said before, the spectrum of biorisk is huge, but still, when we have the regulations right now, do you think COVID, it's easy to be pandemic without biosafety and biosecurity? I mean the strong biosafety and biosecurity? No. If we had good biosafety, as I mentioned, we will have public health system will affect to deal with this subject. Transparency is important between all the states. This is the most important. We have to declare, I mean, we can comment for the prof, what he said before. The most important for biosafety and biosecurity, you have to make the declaration for the lab and the people who work in the lab. Also, my colleague, she talked about biosecurity. It's important because I said they two faces for one coin. You can't play with biosafety without biosecurity, and you can't play with biosecurity without biosafety. Thank you.
Thank you. I think we have a question here, Dr. Abdullah.
Thank you very much. Excellent discussion. Two quick questions. Maybe Ms. Zinsky can take the first one. Is how can the tag B help us address the laboratory leak theory when it comes to SARS-CoV-2, which is a very stubborn theory that's refusing to go away. The second question is more general, and it's in relation to the point of care testing. Where do they fit in the laboratory landscape? Who's validating them? Who's linking them to surveillance systems? Thank you.
May I ask you to repeat your first questions? You were asking about the tag B, so the tag B.
The tag B, yes. How can they help us address the laboratory leak theory that is hovering around SARS-CoV-2 being the origin of the pandemic?
That's not in the scope of the tag B. So that's I think that's SAGO, so another technical advisory group from WHO who's working on this. So tag B is for biosafety, biosecurity, and not for this investigations. Thank you.
And the second point is point of care. Anyone? It's my interest. So anyone wants to talk about the point of care test?
Thank you, Dr. Asiri. It's a very critical point. In my speak, you missed it, but we're establishing a whole operation for point-of-care testing. We see there's a gap, not only when it comes to infectious diseases, and maybe we can collaborate with the team in CDC or Wiqaya to do it. Right now, a clear guidelines, a clear checklist of which point-of-care testing to use and applied for the kingdom is still in establishment. There is Saudi FDA approved point-of-care testing, and this is golden standards, and everybody's follow it. However, there's an evolving market when it comes to point-of-care testing. I can tell you that the rate of point-of-care testing to be developed yearly has been increasing. Definitely we need to focus. It's a great point, but it's one of the projects that we're establishing in the near future, Bidnillah.
I just want to add something. We have a good example that point of care showed a great effect on patients' care, like in pregnancy test, urine analysis, and in glucocheck. It's still in infectious disease, microbiology, still start to be on board with the COVID testing recently, but I think there's so many in the market. And as with the US, they are validating it, and they call it CLIA waived. I think we have to do some similar examples. I think now all the efforts is based on institutional agreements. So it's within the institution, but I think all the institutions are willing to collaborate with the Saudi CDC, with the Saudi FDA, and the Ministry of Health, I think.
Thank you very much. Assalamu alaikum wa rahmatullah. Hamoud Al-Garni, General Supervisor of International Integration Program in the Ministry of Health, Saudi Arabia. Here I have a small comment and question, which is related to some extent to the IHR and the relation between lab capabilities, biosafety, biosecurity, and IHR. We believe that there is a lot of efforts in lab capability, also in biosafety and biosecurity. All these efforts regard to policy guidelines, and it is at international level and national level. However, I'm just asking here about, I believe it's an excellent area for researchers. Is there a strategy for research in such areas, especially biosafety and biosecurity? Thank you very much.
The question is the research in biosafety and biosecurity, right? Yeah.
Research strategy at international or national level, or any level, okay, in this area, and publication. Thank you.
As we're having this risk and evidence-based approach for biosafety and biosecurity, we need to rely on those evidence and research. I think WHO is involved in the biosafety research roadmap, which addresses priorities in this area. And of course, we are always interested in this kind of research and having an eye on this. Thank you.
I might think about for discovering of emerging diseases in the environment and looking for opportunity for new antimicrobial agent by screening the environment. I think these R&D are very significant in knowing what is coming from the environment, from the animal. And also the antibiotics, we are in need for new antibiotics, and majority of these antibiotics comes from environment, from bacteria, from fungus. So these are just at the top of my mind that I think that it might be helpful.
Excuse me. Can I add something, please? Actually, the research with the microorganisms, it needs to be identify the lab that you are going to work with and the organism that you work with as well. Therefore, you have to declare the scientists or who are the researchers with the, and you have to be stuck with the regulation with the PwC, the important issues with this convention, that you have to declare the organism that you used and what the purpose for using this organism. It could be as one of the biological weapons. And you have to be careful with the kind of research that you are going to do with it.
To comment on the question that was raised about the origin of the SARS-CoV-2. So I think initially when the pandemic broke out, with the support of genomic surveillance, a lot of analyses were done, and the virus was sequenced and found to be over 96.6 phylogenetic relatedness to the earlier members of the Coronaviridae. So that has established the fact that it is not a laboratory-made or something that somebody somewhere just cooked, but rather it is part of what has been in the animals before now. So studies have shown that it is the real coronavirus from the members of the Coronaviridae that we know. So it is not that somebody, it is part of infodemic, that people are trying to say, it is not real, some people manufactured it or something. It is not. It is a real actual virus. And studies have actually, established that. Over.
Thank you. I think we have to conclude because people have appointments. So thank you for all of you for the attendance. Thank you for the organizing committee and Dr. Anas Khan for this wonderful event. Thank you.
Thank you, everyone. On behalf of organizing committee, I would like to extend our appreciation and gratitude for our esteemed moderators and valued guest speakers. If you allow us to have a group photo, please. I would like kindly to invite Dr. Abdullah Asiri, his Assistant Deputy Minister for Preventive Health. The next session will be about point of entry and international travel. It's with my pleasure to introduce our esteemed moderator, Dr. Sami Al-Mudarra and Dr. Muhammad Al-Hajri. Dr. Sami, he is the Director of Health Information at Gulf CDC. He is an epidemiologist and public health consultant. Dr. Muhammad, he is a consultant, International Emergency Medicine, Strategic Planning and Performance Department. He is a senior consultant in community medicine at Ministry of Public Health in Qatar. Welcome, and the floor is yours.
Assalamu alaikum jami'an. Welcome to this, inshallah, interesting and exciting session, which is really was recognized during the pandemic, and before that was underestimated by some of our colleagues. It's the ports of entry. Ports of entry really played a vital role in terms of controlling the COVID-19 through the pandemic. And we all realized the importance of ports of entry in terms of controlling, facilitating, and enhancing the health of human beings. In any gathering, whether it's mass gathering or usual interest, ports of entry were recognized as valves to control the movement of people and also the movement of microbes. In our previous pandemic, COVID-19 was the enemy that we wanted to delay its entry to our countries until we become ready for that. But we faced the challenge, and the virus was really clever and has succeeded in terms of entering to all the countries. But some countries delayed it, and some countries couldn't. We will discuss the lessons learned from the COVID-19 measures taken by countries and even by WHO in terms of reducing the cases, number of cases, and the impact in countries, and get the experts to, inshallah, give us their feedback. We will start, inshallah, by Dr. Saif Al-Abri from Oman. He graduated from Qaboos University and also was appointed as the Director General for Disease Surveillance and Control in the Ministry of Health in Oman, and also was and superheaded the National Technical Team in response to COVID-19 pandemic. And in 2020, he was a member of the IHR Review Committee by WHO. Also, Dr. Saif has a keen interest in medical education, and at the moment he is an international advisor for the Royal College of Physicians of London, and was still served as a lead examiner in the region during the period of 2011 to 15. Also, he held the position of the chairman of the Governing Council of Oman Medical College from 2015-18, and currently sits on the Governing Council of the National University of Science and Technology. Also, he has contributed to many articles in many respected journals, and he has authored over more than 120 scientific articles in peer-reviewed publications. So we will start, inshallah, with Dr. Saif presentation Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank and appreciate the kind invitation for me to be here, especially Dr. Anas and the team. And it's a great pleasure to talk to you today about the evaluating measures at the points of entry. And in fact, nowadays we call them ports of entry and borders health. A lot has been discussed, so it was more of the background for my talk. Yesterday, Dr. Abdullah Asiri has talked a lot about the IHR, and also there was a talk about the IHR and also the ports of entry. So in the 10 minutes which I have, I'd like to talk about why do we need to assess the procedures at the points of entry, how do we do it, and then can we do better? Why? Because we want to prevent diseases, halting cross-border infectious disease spread. Also, we want to identify areas for public health and security enhancement. It's part of the health security and safe travel. We need to identify vulnerabilities. How can we improve what we do? And it's also, we should assess because it's part of international standards nowadays, especially adhering to the IHR. I deliberately put this slide here now, and I'll explain, because this is a study published in 2019. And this is all the joint external evaluations that has been conducted in the Africa region by WHO from 2016 until March 2019. So this is just before COVID. And if you look down, you will see points of entry. And these are the numbers of countries. Red means no capacity. So this is a score of 1 to 5. Okay, so 1 is the lowest and 5 is the highest. And almost 21 countries didn't have anything with regard to the capacities. 14 countries were developing, like when they say no, 1, which is less than 20%. The brown, which means 20 to 40%. So you can see that the majority of the countries don't meet the standards for the points of entry. And what is applicable to Africa is also applicable to many other countries all over the world. So when we look at the points of entry, we need to look at the IHR as a whole. We can't look at the points of entry in silos. So on IHR, we have the monitoring and evaluation framework for the IHR. And there are 4 core elements for evaluation. We have the state parties self-assessment annual reporting, we call SPAR. We have also the voluntary external evaluation, we call the joint external evaluation. We have the after-action review, and we have the simulation exercises. So there are 4 elements. And even during COVID, we have what's called the intra-action review as a 5th element, that during the crisis, we do assess. So both the SPAR and the JEE, it's only the mandatory, the SPAR. But like both the SPAR and the JEE are quantitative. The after-action review and the simulation exercises are more of qualitative. Like we are looking for, are these things available in SPAR and JEE? And in the simulation and the after-action review, do they function well if we test them? And as have been mentioned yesterday, that it was supposed to be that countries that has done JEE should do them every 4 to 5 years, but unfortunately, most of the countries that have conducted JEE didn't do them again. So this is, again, just more of reinforcement. But like when we look at the capacities using SPAR and the JEE, SPAR is more self-assessment. Joint external evaluation is more of facilitated in-depth discussion and structured site visits. When we look at the qualitative ones, which is the after-action review and simulation exercises. It's how should it work, does it work, and how can we improve? But the whole purpose of this exercise is that for countries to have national action plan for health security. So it's not just conducting these. And the most important thing from these national action plans is for them to be budgeted. And we'll see that most countries failed with the national action plans because they failed to budget them. And when they failed to budget them, it means that they couldn't improve. Nothing is free of charge. Whatever we want to do to improve really takes money. So this is more of now enforcing the monitoring and evaluation of the IHR on the points of entry. So when we assess the points of entry, we assess at two levels, one at the national level and one at the point of entry itself. So there are two levels. And we look at the average. I mean, we will go into the details of what we do, but then also the after-action review and the simulation exercises looks at how they work together, the national, the regional, and the local. So we need to know this, because many times you will find strong national program, but nothing in the ground, or strong regional or local capacities, but at the national level it's really weak. So it tests how do they talk to each other. In fact, since 2009, the IHR came into place since 2007. 2009, the WHO has published the International Health Regulations, the assessment tool. And so the objectives were, as we have mentioned, to determine the current status of existing core capacities, obtain baseline information for measuring progress, and then develop a plan for improvement. So it has two parts. One is assessing the establishment of communication and collaboration structure, and part B has two core elements: assessing routine capacities needed at all times, and also assessing capacities needed to respond to events. But now we have a third core element since 2021, where we have learned from the COVID-19, and we will come to it. So this is what it takes for the coordination, communication of the event information and adoption of measures. And this is the most difficult thing, really, because it's national communication link between competent authorities at points of entry, direct operational link with other senior health officers, communication links, legal procedures, assessment of all reports of urgent events within 24 hours, communication with the Ministry of Health and with other sectors. And also there are core capacities for health, like medical services and adequate staff, equipment, personnel and transport, trained personnel, safe environment, trained staff. I'm not going to go into the details, but again, we have the JE, the Joint External Evaluation, which is more expanded than the initial SPAR. So it has three core elements. Routine capacities are established at points of entry and effective public health response at points of entry. But then there's a third capacity that's now part of the SPAR. So SPAR is the state parties' annual self-reporting. So it's the same capacities, but also now we have a third indicator, which is the risk-based approach to international travel-related measures. And now, ports of entry are called ports of entry and border health, rather than just ports of entry. This is the report for Oman for 2012, measuring the three things, and it compares Oman to the global, to the regional, and to the the state indicators itself. So comparing us to Oman's reports from before, to the IMRO, and to the global performance. This is a nice paper published recently about the interaction reviews at points of entry in the Netherlands. I'm not going to go into the details, but this is how did they do it. They grouped in people from ports of entry. They did interaction review. they have points for improvement. They went back after 3 months to see what has been done. Some countries have done it in a systematic way. Some countries have done it, but not really in a systematic way. This is also a template for assessment and notification of a suspected case at the airport, so that countries can use these templates of assessing their capacities for simulation exercises. And so when it comes to the ports of entry, it's not only WHO, we have WHO, we have ICAO, we have IATA, we have other organizations, and we need to involve other national capacities and other stakeholders. So can we improve? Of course we can. And the most important thing is through engaging stakeholders. We need to involve all relevant parties and upskill public health professionals. We need to adopt diverse methods, use evidence-based innovative data collection and analysis. We have many gains during COVID, but unfortunately we have lost them. We should have kept those capacities. We should have kept those technologies which we have learned, but unfortunately we have lost them again. Many countries, almost every single country, developed apps, developed big data systems, but nowadays most of them have evaporated. We need continual monitoring. We need to regularly evaluate points of entry, focusing on public health outcomes. We need community and policy integration, engage communities, and let findings shape policies. Support for limited resource countries, and provide financial and technical aid and share findings broadly. So for example, during the JEE, or even during the Global Health Security Agenda, many countries have conducted the exercise, but they didn't have the money. They have been promised that they will be financed, but they have not been financed, so their exercises were useless. I'll end there, and thank you very much.
Thank you so much, Dr. Saif, and good afternoon, everyone. It's a pleasure being here in this esteemed conference. Our next speaker is going to be talking about another important topic related to point of entry, which is travel health. This is Dr. Al-Mubashir. He's a consultant public health physician from Qatar Public Health Ministry of Health. He's also an associate professor of One Health and Emerging Infectious Diseases at Qatar University. Dr. Mubashir have granted through his expertise in One Health and MERS-CoV, as well as travel health, several positions with WHO and FAO in different committees. One of them is the One Health High-Level Expert Panel. Also, he was being selected as one of the 10 international experts to investigate the origin of the COVID-19 in Wuhan, China, in 2021. Please welcome Dr. Al-Mubashir.
Thank you so much. Assalamu alaikum wa rahmatullah. Bismillah, salatu salam ala rasulillah. Thank you so much for the organizer and Dr. Anas. It is my pleasure to speak today about travel health. Since it is the last presentation, I will make easy, I will summarize my presentation. I will start with a funny story. I'm working in Qatar. I traveled, this has happened 3 years ago. I traveled back to Sudan. I took my vacation after a long time. Then, after 7 days, I got a very severe fever. And then I went to the doctor, and he mentioned, Mubashir, this is falciparum malaria. I spent the rest of my vacation lying on bed. And then after the last injection, I just came back to Qatar. My manager asked me, Mubashir, did you spend your vacation very well? I told, I spent my vacation on bed. So with fever and with the triple injection for falciparum malaria. So travel is so crucial, travel health. So here, this is the content of my presentation, but really my aim is to advocate for the travel health program at the Minister of Health. It is high time to have a travel health unit, a travel health focal point at the Minister of Health, as well as at the institutions. It is high time to have a travel health programs. It is high time to have travel health guidelines. I will present figures, numbers, justification, best practices, as well as steps, systematic steps to establish this unit or a program at the national level as well as at the institution level. So travel health, it is a specialty right now. So it is dealing with measures before, during, and after travel. The focus is destination, doing risk assessment concerning destinations, how to plan for safe travel. This is one of the cornerstone of travel health, as well as what are risks when it came to behaviors, how to behave during and after the travel, as well as there is a package of services, including health insurance, vaccine, prophylaxis, and other services I will reflect on. It is decision making based on risk assessment. The Minister of Health, they need to have, the WHO, they need a role. The CDC, they have a role. So it is really, it is a program, it has to be part of the public health intervention at all countries. So as I mentioned, risks, there are so many. So I mean, like in destinations, we have different disease agents as well as temperature and altitude, humidity. So those are the example of risk. So travel health, we're planning with travelers how to make it safe. And the travel health, like the travel health specialist or physician, they will discuss how to minimize the risk based on certain measures. This is a profile of traveling. 4 billion, this is what IATA expecting. So you can imagine the impact of 4 billion people that will move. And we are in a region, really it is one of the hubs for travel. Saudi Arabia, United Arab Emirates, Egypt. It is time for mobility and it's time for moving. There's a lot of countries in the region. Their major investment, it will be establishing airplanes. In Saudi Arabia, here you have also a plan to invest on making these airplanes as one of the major investment area. You can see United Arab Emirates as well as in Qatar. So there's a lot of different reasons for travel, for Hajj, tourism, and you can name it. And this is numbers showing number that are increasing. Yes, during COVID, the number they are decreasing, but still they are jumping. So, like in summary, numbers they are tripled. Those people that are traveling for different reasons. You can see globally more than 100%. So people, the numbers they're doubled. You can see in the MENA region, the inbound tourism, it is 163% increase. And let us focus on the GCC. You can see in the GCC, we have 65% of inbound travel tourism in the region. So outbound travel, 44% increase, also a big number in the GCC. This is just to justify, we need to deal with travel in a systematic way. It is high time for the ministers of health and the health institution to deal with travel. I will skip those slides. So, in summary, tourism, Hajj and Umrah, and also immigration. Like there's a lot of immigrants in the region, refugees, IDPs, and also families, immigrant workers in the region, sporting events. This is Hajj, I will skip this. But here you can focus You see, majority of Hajjis, they are coming from Bangladesh, they are coming from Nigeria, also India. So we can see the impact of, the travel in our local health. So here, this is reflecting on immigrant population in our region. 88% in United Arab Emirates, they are immigrants. 70% in Kuwait, 77% in Qatar. So you can imagine, this is one of the major determinants of communicable disease in our countries. So this is, paper reflecting on what kind of health problems among those that are coming. So we have acute diarrhea, fever, chronic diarrhea. I need you to focus in this slide. How many experts in our region, they have a certificate in travel health? You can see, this is the International Society of Travel Medicine. I just emailed them. How many from our region, they have this certificate? 2%. So from Qatar, we have 4, Kuwait, we have 1, and you can see in Saudi Arabia, only you have 2. This is the official record of the International Society of Travel Medicine Association. This is the Royal College. In the Royal College, they have the Faculty of Travel Medicine. So how many? They have 6 affiliates only from the region, 4 associate members and 2 members, 2 fellows. In the state here, we have 2 fellows, myself and Dr. Al-Hajri. And then you can have the rest of 5 from the whole region, 22 countries. So we have in this year, 4 candidates that are doing their training. I emailed the American Tropical Association how many they did the certificate in clinical tropical medicine to be specialized in travel medicine. I'm so surprised when they answer me, 0. No one from our region, they did the certificate. You can imagine how, people that are practicing the travel medicine. So when it came to how other countries are dealing with the travel health. In the United States, they have the CDC, and they have a specialized department and section dealing with travel and immigrant health and quarantine. They have the American Society of Tropical Medicine. They have the American Travel Health Nurses Association. They have the Department of Foreign Affairs. They have a specialized unit. They have a hotline dealing with travel and travel health. This is in UK. Also, at the part of the public health security, they have a travel health unit. They have the Royal College of Travel Health. They have the famous program which is giving guidelines for travel clinics. They have Travax, Fit for Travel, and you can see how other countries are dealing with travel health. Minister of Health, they are in the front. Clinics, they have guidance, they have systems, they have travel health surveillance. This is how they are dealing with travel health. And this is Europe. In the European CDC, they have a unit, they have a team dedicated with travel health. They have a network, they have a department as part of the Ministry of Foreign Affairs. They are dealing with travelers. Canada, the same. So this is how other people they are dealing with travel health. It's part of the security, it's part of the public health, it is science, and they have a system how to deal with travelers outside and inside their countries. When it came to the United Nations, IOM, UNHCR, UNICEF, all of them, they are dealing with part of the travel health with guidelines, but unfortunately, till now, we don't have like a working group or something unifying between those United Nations organizations to deal with travel health. WHO, as mentioned by Dr. Saif, they have a lot of components dealing with travel health. Part of it, the IHR, you mentioned the point of entry. They have a surveillance. WHO, they are investing a lot, doing risk assessment. They have a lot of guidance.
You have 3 minutes, Dr. Mubashir. 3 minutes.
3 minutes. So when it came to the region, in Oman, travel health is mainstream as part of the public health, the primary health care, as well as in Qatar, but we don't know about the region, how many travel clinics we have in this region, this is we don't have. So, in summary, travel health right now, it is a network, it is a department, it is an association. You can have a fellowship, you can be a member in travel health. It is a surveillance system. They have a travel clinic. Clinics is part of the infectious disease department, it's part of the incubation. So it is a well-established specialty, it is science, it is a department, it is a surveillance. They have a research agenda, they have international association. So when it came to our region, still we have a lot of strengths. We have the component, I can say it. We have the component of the travel health at part of different departments at the Ministry of Health. Surveillance, they are taking care part, occupational health, the IHR, but they are not well integrated, well connected as part of the Ministry of Health to formulate what we call a travel health program. In the discussion, we can reflect more on this, but it is quite obvious for WHO, we need to have at regional level a travel health program. WHO should lead this one, and at country level also, we need to do our investment by having policies, guidelines concerning travel health governance. It is high time to have a training and capacity building program dealing with travel health. It is high time to have education and awareness program, surveillance, building the capacity concerning travel health-related surveillance, and the health insurance. So a lot of facilitator factors. So we have the ingredients of having a travel health program at the regional level, as well as at the country level.
1 minute.
Those are the steps, and thank you so much.
Shukran, Dr. Bashir. Thanks for the detailed travel health as a specialty. And inshallah, now we'll go for our colleague, Dr. Ahmed Al-Qarni. He works in the Ministry of Health in Saudi Arabia. He is an expert in public health and serves as Supervisor General of the International Health Regulation Program at the Ministry, in addition to numerous positions within the Ministry related to the IHR capacity, including the supervision of surveillance centers at points of entry. He graduated from King Abdulaziz University, Jeddah, and also is a family physician, and also obtained a master's degree in global public health from Emory University, Atlanta, Georgia, USA, and published many articles related to the IHR, epidemiology, and also MERS-CoV, in addition to mass gathering preparedness for Hajj. Thank you.
Thank you very much. Thank you, Dr. Muhammad, for this introduction. Actually, I extend my thanks to Dr. Saif and Dr. Mubashir, as they actually give a background for my presentation. Dr. Saif talked about core capacities in the point of entry and the framework, how can we measure and follow up this, and the indicator set by WHO through IHR. And Dr. Bashir talked about travel health and the epidemiological situation all over the world that can we assess. And here I will present our story during Hajj at points of entry and beyond through assessment of countries and putting the requirements needed for these countries. Always we talk about IHR, which is a legal binding document that prevents the spread of infection through the borders. Also, now to contain the risk at its point and spread and reduce the spread of public health risk internationally through rapid detection, assessment, reporting, and response. When we talk about travel health, our experience in the Hajj, we do an assessment for epidemiological situation in all countries. We deal with Hajj and due to the overflow and short period as, let's say, a public health emergency, which we need to prepare before to such event. Actually, this preparedness starts by putting the recommendation and requirement for the countries coming, the countries that the Hajj is coming from, and this assessment based on the global epidemiological status. This requirement is published at Ministry of Health website with, I think, 6 or 7 languages. And these requirements include, let's say, 3 different types, and 3 different entities are responsible for implementation of such requirement. The required and recommended immunization, which is yellow fever, meningococcal meningitis, poliomyelitis, seasonal influenza, and COVID-19. Some of these immunizations are required for the mass gathering event, and some for preventing introduction of disease or infectious disease to the country as it's eliminated or cleared from this disease, like poliomyelitis or yellow fever. The targeted entity here is, Saudi mission in each countries before mission or approving the visa for the Hajj need to make sure about this requirement. Educational information, this for Hajj missions, which is include personal hygiene, education about respiratory disease, about heat-related illness, about physical ability and chronic diseases. The third one is that the transportation means, as we have a regulation and requirement for this means, include disinfection certificate for the countries coming with yellow fever, dengue fever, and Zika affected countries. We talk now about international level. Now we'll come to the points of entry. Our measurement at there. Actually, in Saudi Arabia, we have 36 health surveillance centers, 15 airport, 10 seaport, and 11 ground crossing. And actually, we believe that we reached demonstrated capacity at all of these points of entry during COVID-19. However, we have 13 designated points of entry for Hajj. This changed from year to year. This includes 4 airports, 1 seaport, and 9 ground crossing. And this is the public health measures at points of entry during Hajj. Actually, there is a lot of trained personnel during this event, and there's a lot of measures at point of entry at this duration. This include inspection and checking vaccination records for the Hajj coming from the countries which we require the vaccination, application of preventive measure needed based on risk assessment, and providing medical service for urgent cases, and inspection of transportation means, maintaining environmental health and control of factors, coordination with stakeholder within the points of entry, and assessment of events and reporting according to the risk assessment. We have future plan for improving the health security in such requirement, and to ease the journey of the Hajj during Hajj journey. This includes Makkah roads and accreditation of health centers at pilgrims' home countries to make sure and prove that they are taking the required vaccine. Makka Road initiative is owned by Ministry of Interior and a lot of stakeholders like Ministry of Health, Ministry of Hajj and Umrah. It's aimed to improve service by facilitating entry procedure through special lanes at their pilgrim departure airport. In this initiative, we guarantee the adherence to health requirements through inclusion of health requirement in initiative agreements with the country, and Hajj agency at participating countries will guarantee adherence of their pilgrims to health requirements. In some countries, we need more preventive measure, and we'll do this through application of preventive measure by health authorities, by local health authorities at participating countries under supervision of Saudi Ministry of Health. And this example for adding preventive measure an airport of country with the Makkah Road. During the last Hajj, more than 40,000 pilgrims arrived through Makkah Road through these different countries, and they plan to extend it to about 400 or 500 this year, inshallah. Additionally, Makkah Road also plan to make a digitalization and to make it easier instead of sending people and so on. They are working on digitalization now. We take a step forward in this regard by accreditation of health center at pilgrims home countries. This initiative aims to facilitate adherence to health requirements and minimize time spent at point of entry. Accreditation of health center at pilgrim home countries. This centers linked to an electronic system which report pilgrim health data, and in addition to putting or giving the required condition by Saudi Ministry of Health. This will help later on in pre-planning for Hajj by knowing some condition with Hajj, and will make the pre-planning is better. Also, this system access to relevant government agency to verify adherence to health requirement prior to arrival or prior to issuing visa. Thank you very much.
Thank you so much, Dr. Hamoud Al-Garni. It really was an entertaining speech. Our next speaker is Ms. Fatima Arifi. Ms. Fatima currently serves as the technical focal point for the point of entry and border health within the country health emergency preparedness and international health regulation, the CPI unit at WHO EMRO. With over 7 years of experience in the field of international health regulation, disease surveillance, point of entry, she brings a wealth of knowledge and expertise to her role. Also, as a distinguished Fulbright scholar, she earned her master in public health and epidemiology from Florida International University in the United States. Additionally, she holds dual bachelor degrees in public health, political sciences, and public administration. Also, that further demonstrates her commitments to public health and her multidisciplinary approach to addressing health emergencies. Please welcome with me Ms. Fatima Arifi.
Hello, good afternoon, everyone. Thank you so much. I would like to start with thank you so much, Dr. Anas, and also our colleagues in the Global Center for Mass-Carrier Medicine for giving us this great honor to present on points of entry capacity building in the Eastern Mediterranean region. Next. Sorry. This one? Okay, thank you. It's not moving. Yeah, it's not moving. Sorry. See, it's not moving. No. Yeah, sorry, yeah, just bringing the new one. Oh yeah, it worked. Okay. So I would like to start, I think you all have the knowledge about international health regulations, so I would like to start about the overview of international health regulations and where points of entry fits within IHR. As you know that the IHR, the main scope of IHR is to prevent international spread of disease in a way which is commensurated with the public health needs, as well as avoid any unnecessary interference with the international travel and trade. So here, points of entry play the main gateway for the international travel and trade, which includes goods, cargoes, baggage, containers, as well as even the parcels. But it also includes the agencies and areas which are providing services to the points of entry and exit. This definition is very important because later, I think our colleagues, Dr. Saif and also Dr. Mubashir, they provided an overview of the IHR core capacities. So mainly this definition is guiding us to outline the core capacities which needs to be in place at the points of entry. Next, please. So why points of entry is very important according to IHR core capacities. As we have learned all through the COVID-19 lessons learned, so points of entry is the first line of defense for the public health threats. From operational perspective, the points of entry, the public health personnel, they are the first ones who might be able to detect the public health threats and the initial responders to those public health threats. So these hazards, it may include the sick travelers as well as contaminated goods, containers, presence of vectors, or any disregardings for the requirements to be in place at the points of entry. So the points of entry staff, they might be the first one who receive these notifications, as well they might be the ones who will provide the initial response. Our colleagues also provided an overview why, because we have seen a lot of growth in international travel and tourism due to the advancements of technology in aviation sectors, as well as the efficient plane modes and airline modes. So as today, the world is connected more than ever. While it is a great milestone, but at the meantime, it provides the opportunity for the cross-border spread of disease and also presents the opportunity for the spread of infectious disease, which may include SARS, COVID-19, and also drug-resistant tuberculosis. I think Dr. Mubashir also provided an overview that mass gathering is one of the events in the region which attracts large international audience and large international travel in the region. So that's why we need to work and enhance on these points of entry capacities. So the key, as the international travel itself and the increase in the travel, it is a huge milestone, but at the meantime, it poses some inherent public health risks, which is different based on the health needs of travelers, as well as the type of travel that they are undertaking, whether it's for work, for leisure activities, or it is for attending conference or business. The travelers, they may face some sudden changes in humidity and temperature and may be exposed to a variety of infectious disease. Especially in the areas with poor accommodation and hygiene facilities, this risk might be more serious. So the factors which are determining the public health risks, it includes, it is different between, based on the mode of transport, whether one is flying or driving or they are voyaging through sea. The destination where they are going, each destination deposes, based on their epidemiological profile, deposes distinct risks, as well as the long travel and in some certain seasons, they might be exposed to a variety of public health risks. And the purpose of travel that they take and the behavior of individuals, which is so unpredicted, and it's exposing them to different public health risks. Dr. Abri also provided an overview of IHR core capacities, which needs to be in place. But here I will just touch upon some of the important core capacity requirements which needs to be in place. We discussed about the capacities which needs to be in place at all times, but also the capacities that needs to be in place during response to public health emergencies. So the capacities that needs to be in place during routine times, first it is to provide facilities for the assessment and care, and also staff and equipment for the international travels. This is the main area for this one is access, to provide access to these facilities. This might be sometimes located at the point of entry itself, but sometimes near to the points of entry. But also trained personnel to do the inspection of conveniences. I think Dr. Hamoud provided how these provisions are practiced during Hajj in KSA. And also equipment and personnel for transportation of those suspected travels to the dedicated health facility, and ensure safe environment, including safe potable water, food and hygiene facilities, public washrooms, and other risk areas which are present at the points of entry. And importantly, train the staff and program for vector surveillance as well as control at the points of entry and the adjacent facilities. So the core capacities, it needs to, which needs to be developed during public health emergencies. The first thing is I would like to touch on the public health emergency contingency plan. This is one of the areas that it's not only about the availability of the plan, but we need to know whether these plans are exercised, whether they are implemented. Do we have identified contact points for this focal point? Is it coordinated with other sectors? All other sectors are informed about these plans. Is it implemented during an actual public health emergency? Does it work or not? So that's why this is one of the areas that we are struggling in the region. We are working on to improve the capacities in the facility, as well as the other capacities that need to be in place during the public health emergencies. So this one shows how I think Dr. Saif also provided presentation that points of entry before COVID-19, it was one of the areas with weakest capacities in the region, and we were working on how to advocate for enhancing this core capacity. But after COVID-19, this is one of the areas that has received political attention and also commitment to improve these capacities. As you can see, at least in Eastern Mediterranean region, so the capacity was 53%, the total capacity in 2018, and it improved by 15% to 68% in 2022. We are, as you see, in regards to specific indicators for points of entry, we are doing fairly better in the routine capacities, but we need to further work on the emergency capacities. As the risk-based approach to international travel was recently introduced in 2021, I think countries, they have learned the lessons during COVID-19, so they want to take any approach, any risk-based approach to prevent the travel bans, but to adopt mitigative measure and risk-based approach to the travels. That's why the capacities have been improved, and this practice on risk-based approach have been improving. So this is the support that we're providing at the region. So for the strategic support, first of all, we conducted a need assessment and prioritization of the needs at the countries in the region, based on which we developed a points of entry regional strategy for 5 years, for 2023-2028. The strategic areas includes enabling environment, multi-sectoral coordination, cross-border collaboration, operations to improve preparedness and response, including surveillance, workforce and capacity development, M&E, and regional points of entry network. We have been also developed an operational framework for cross-border collaboration. I think we can take this COVID-19 opportunity, because we have been receiving a lot of requests to facilitate information sharing and collaboration across borders to detect and respond to public health threats in the region. So we have developed this operational framework to provide a step-by-step guidance how to make this collaboration operational. At the meantime, we were also conducting simulation exercises to test how this collaboration is working. For example, recently we conducted simulation exercise between Somalia, Kenya, and Ethiopia in context of One Health, which we are trying to replicate this in other countries in the region as well. We have also established an interagency workforce in the region, which includes IAMI, IATA, and also some collaboration with Africa CDC is in place for the public health emergencies. and guidelines and advocacy for the risk-based approach for international travel against different disease outbreaks which are ongoing in the region. And importantly, we have been, countries, as you know, the practice is so different in different countries based on their resources. So we have been documenting the case studies to know how each capacity is practiced in different countries. That's why we have developed at least more than 12 case studies in the region, which is reflected in the training package I will go over in the next slide. And we developed a roster of experts for the points of entry professionalism and conducting a stakeholder mapping for points of entry. As you know, that the different stakeholders are present at the POE, and it's important to keep all of them engaged. Some of the operational support, we have been supporting the cross-border collaboration by establishing technical working groups in each country and facilitating meetings and discussion to have the collaboration. We have one in context of mass gathering in Iraq, between Iraq and neighboring countries to do the cross-border collaboration in context of mass gathering. Developing contingency plan and supporting to conduct the points of entry assessment and developing public health action plan, as well as incorporating within national action plan for health security to develop the points of entry capacities. And risk assessment to designate points of entry as well as for the international travel measures. And developing some RCC package and some specific technical area support based on the requests and needs of each country. This is the best, I think we have been receiving, like countries were saying, we want to develop a points of entry task force, but we don't know what we should train them, what should be the tour like. So therefore, we worked on a points of entry training package, which will be accessible publicly by next week soon. So this one is divided into 3 intro, intermediate, and advanced package. So it includes a holistic training package, how the points of entry capacities are practiced in the region and how they should develop these capacities. So this one is coming soon in the Open WHO. And some of the challenges that we were facing is that it is very, the provisions, the practice is very different in different countries in the region. And the capacities are so different in a variety of countries. Some countries have very well-established facilities, very well-resourced staff, but some are receiving, especially the poorest borders. They have limited resources, and the capacities are very primitive. They are facing thousands of population movement on a daily basis. And we have also some challenges in management of public health events, and some insufficient coordination with other sectors, and unlimited HR, as well as availability of electronic systems to provide evidence for the points of entry capacities, as well as the ill passengers at the points of entry. So some of the way forward for the region includes the implementation of points of entry region, improving the points of entry capacity, as well as galvanizing these lessons learned of COVID-19 to enhance the cross-border collaboration in the region, and enhance the points of entry rule within IHR to synergize our efforts and enhance multi-sectoral collaboration within the countries. And also expand our regional roster for the points of entry to include other expertise in the roster as well, and ensure that all countries have contingency plans, they are tested and they are implemented in the region. Thank you so much.
Thank you. That was really informative and shows the efforts by WHO, especially IMRO. Now it's our time with Professor Maria Bordina, inshallah, please. Professor Bordina is a WHO Senior Technical Officer on Mass Gathering. During the 2019-23, she was involved in the WHO Border Health and Mass Gathering Unit, COVID-19 response, through providing technical support to member states and other stakeholders with the aim of strengthening the strategic and operational planning for mass gathering events. Also documenting implemented activities, liaising with WHO collaborating centers. In her capacity in the WHO, also the virtual interdisciplinary advisory group on mass gathering that has started since 2010, Dr. Bordina was involved in some international mass gathering projects, such as 2012 UEFA European Football Championship, the 11th African Games 2015, the 5th Asian Indoor and Martial Arts Game in 2017, and also she participated with the IMRO Sub-Regional Preparedness for Mass Gathering in 2019. She was also nominated in 2013 and also 2017 as a roster of experts membership for the Emergency and Review Committee experts in mass gathering. At her background, she was working for 24 years in Academy of Postgraduate Education under FSPU, FSCC of the Federal Medical Biological Agency of Russia, Moscow, the head of Emergency Medicine Educational Department, professor, as well holds a position of associate professor in People's Friendship University of Russia Disaster Medicine Unit. Also, she has a broad expertise in public health, emergency medical services management, medical education, and she is an author and co-author of more than 90 scientific publications. Please, thank you.
Thank you, dear colleagues, for this introduction. So let me express my appreciation for this opportunity to share with all the audience the experience of WHO, Border Health and Mass Gatherings team experience in support of some international events held during mass gatherings held during COVID pandemic, as well as some key findings from the literature on medical planning on mass gatherings. From the first sight, this topic is not directly connected to the title of the session, Points of Entry, but of course we all can understand that each participant of any kind of event, each pilgrim coming to another country has some expectations regarding the medical care coverage during the event. And of course, they consider that in case of emergency, they can have appropriate standards of medical care on site, and if there is any kind of need, could be transferred to the hospitals, could have any kind of best practices practiced in the country. So staging the very first steps of formation of mass gatherings medicine, this discipline went beyond the scope of public health provision due to global health threats. And WHO role in regard to mass gathering is to provide general guidance, norms, and risk assessment tools and advice how to use them and best practices to allow organizers to make decisions, to hold events, to postpone events, and cancel events. But during COVID-19, the scope of support instruments was significantly enforced with establishment of intergovernmental all partner task forces, technical working groups, and to address needs of member states and event organizers. Such activities as simulation exercises and after-action reviews, the risk communication and community engagement, the emergency medical team project reconfirmed their significance. WHO mass gatherings team was provided technical support to some of the key events, including Tokyo Summer Olympics and Beijing 22 Winter Olympics, as well Qatar World Cup in 2022. And to facilitate WHO work and monitor the global situation on holding mass gatherings during these difficult times, in collaboration with WHO Collaborating Center, Johns Hopkins Center for Health Security, a global database on mass gatherings was maintained to monitor key trends in holding mass gatherings during COVID-19. And additionally, a set of scoping reviews was developed to inform the upcoming development of some of WHO products. And 2024, we expect the release of mass gatherings operational framework, including packages on medical planning, on after-action reviews and simulation exercises, as well a legacy template, which was already mentioned on the plenary session yesterday. So the impact of COVID-19 during mass gatherings remains clear, and to have any kind of conclusions regarding the impact of this pandemic on mass gatherings, the database allowed us to monitor some key indicators. On the top left, you can see the diagram which demonstrates these epidemiological situations starting 2019 till the current time, 2023 year. And to the right, you can see the diagram which demonstrates the current status of mass gathering events through the same absolutely period. So we can see that it was 3 phases, 3 trends throughout all the pandemic. The first year, especially the 2020, during the 2020, predominantly cancellations and postponement of events. The next phase was modifications of events starting 2021 and through mid of 2022. And starting that time, the majority of events were held with no any kind of modifications and of course no cancellations. So how could it be possible during the ongoing pandemic? This trend followed to a large extent the stringency of public health and governmental policies across the same period of time, as well the evolution of pandemic and development and accessibility of public health countermeasures. And as can we see, in the beginning, many movement and gathering restrictions were implemented in the beginning of pandemic, and then it was followed by a gradual move towards easing of restrictions for gatherings. So this successful public health measures made possible events to go ahead and without any even modifications. Even during second phase, such events as Summer Olympics and Hajj pilgrimage in 22 happened. One of the most eminent projects, it was a 3 years project between Qatar government, WHO and FIFA. This project was named, it's still ongoing, so it's named Healthy FIFA World Cup Qatar 2022, Creating Legacy for Sport and Health. One of the pillars is health security. There's a focus on mass gatherings. So this project and ongoing mass gathering, our activities set up a stage for future planning and standardization of medical planning of events. So totally it was 32 different activities with involvement of different WHO technical teams, and one of the final meetings held in June in Doha, with representatives of all 3 parties. During this meeting, it was achieved sort of consensus on the need of standardization of medical planning, and the appropriate model for this planning was identified. For the beginning, it's WHO, AMT standardizations for emergency medical services. So to find any evidence which will help to build a model of medical planning of upcoming mass gatherings, one of the steps, it was a scoping review. It was commissioned by colleagues from a research group from the Brussels University. And the key research question was, what are the standards available for medical planning and response in different types of mass gathering events, sports, religious, festivals, and what are the areas that need standardizations? More than 100 peer-reviewed articles were finally identified, and the result was very clear that there are no studies regarding standards for medical planning and emergency response at mass gatherings identified. And one more practical output was identified that still in any kind of literature there is a deficit of valid predictive models on risk assessment tools from the medical point of view. The majority of products are based on epidemiological analysis. To enhance these results of research, a second step was undertaken, new research which included the analysis of grey literature as well any kind of available regulations, protocols and medical plans from the valid sources regarding key events. And the research questions still remained the same, was around the standardization of medical planning, and what are the other areas which need to be enhanced for medical planning of key events. And again, through this assessment and our colleagues, International Center for Sport Security, was leading this activity. And the topic and the content of the research was not specified only on emergency medical teams' response. It was more wide and covered medical planning and medical response and medical preparedness. So the output of such research again set up a stage for developing a model, and thus it will contribute to the legacy of the FIFA World Cup 2022. So that are the 16 key themes identified in all the analysis, which has some kind of needs to be more deep analyzed, and there are some, definitely some points which they are not oftenly considered. Due to limit of time, we cannot go in detail into each of the topics, but in general, we can say that, of course, content of the event has a huge meaning to all the planning, but despite it, there are specific factors like the profile of participants, the context of the environment where it helps, the access to the medical services, the availability of major incident plans, the availability of 24/7 communications with key partners, and of course the quality of data and the quality of case reporting of each patient. That all will be helpful to improve data quality and medical reporting, and of course to develop, it will help to develop medical planning. As well, a special focus is on research needs. There are some dedicated sessions at this conference to identify the key, the most important areas for research. So again, researchers emphasize on the need on interdisciplinary approach for understanding the health challenges of mass gathering events, and as well the need to have evidence to develop effective policies, plans, frameworks, and guidelines to plan on mass gatherings. Some key aspects on the mental health, on behavioral particulars, and especially particulars on behavior of neurodiverse fans and spectators, again, need to be addressed. Training of staff, it's traditional, very important point, and the legislation, things which include the normative and regulation practices which should be following the key organizations, and not say not following, but be in commitment with the key organizations which develop such a documentation. For example, it's again WHO, International Olympic Committee, FIFA, who has their own guidance on mass gathering event emergency medical services. And one more focus is on including using all hazards approach in planning for mass gathering events, and we can already say that WHO again is working on this project, and on the website you can find their published tool on all hazards risk assessment tool, and the web application would be published in the nearest time. So there is resulting two types of reports, the scoping review and the gray literature review. We can conclude that mass gathering medical planning should be systematized, standardized, and to develop these standard practices. And for a moment, in the context of mass gathering, the model of emergency medical teams was identified because it has very clear standards, very clear tools and resources, and using these available documents, this aim could be achieved. And to discuss these new plans and on developing on model of medical planning, WHO is conducting a next meeting with participants from 15 member states. It will take place in November in France, in Lyon, and the target audience of this meeting is representatives from public health or event organizers who are in charge in medical planning of key events. We meet to share experience, we meet to find the best solutions to develop a model of medical planning of these events, and of course it will again benefit the development of global tools such as operational packages for medical planning as well. Thank you for your attention, colleagues.
Thank you so much, Professor Maria Brodina. We come into the last talk, and I want to, on your behalf and on behalf of the organizing committee, thanks again the speakers, Professor Maria, Ms. Fatima, Dr. Hamoud, Dr. Mubashir, and Dr. Saif. I want to open the floor now for the attendees, if you have questions to the speakers.
Assalamu alaikum. My name is Harun Rashid. I have got a question first for Dr. Al-Gharni. So, Saudi Arabian Ministry of Health used to publish guidelines for travelers coming to Saudi Arabia on Hajj or Umrah and maybe other travelers. I mean, over the last few years, we haven't seen those guidelines. I mean, at least in PubMed. So, do you have any comment? Do you have any plan to restart those publishing guidelines? That's a question for Dr. Gharni. Maybe I have got another question quickly. Can I do it now or later? Maybe.
Yes, please, go ahead.
The second question is for Dr. Mubashir, and maybe also other members may ask. So, as a member of ISTM, International Society of Travel Medicines, in the LISAP, we get a lot of questions, differing opinions about the sources of information. For example, someone coming, traveling on Hajj, the GP often relies on CDC or NATNAC, the UK, or something else, like in Australia we have got Smart Travelers. But according to me, I think the main source should be Ministry of Health's recommendation, and that's the most up-to-date. How can we make those things uniform? That's mainly for Dr. Al-Mubashir. Thank you.
Thank you very much. May I ask you, you are asking, we are not publishing the health requirements? It's not published? PubMed, okay. Actually, during, let's say the last years, we published this requirement through Ministry of Health website, and currently we have, two requirements. It's actually for Hajj special requirement and Umrah special requirement on the same website. However, okay, we'll return back to publish this through WHO, let's say, as a paper or publication in the future-wise, inshallah. Thank you.
Thank you so much, Dr. Harun. You raised a very important questions concerning the unified risk assessment. In fact, in the region, we don't have such kind of tool system or a unit at the Ministry of Public Health to do such kind of risk assessment. CDC, they do, ECDC, they do, Canada, they do, Australia, they do. But when it came to our region, I reflected this in my presentation. We don't have a such department at the Ministry of Health dealing with such risk assessment, and then this risk assessment it's like circulated for travel health physician outside or inside their country. But currently the Gulf CDC, they start to do those kind of risk assessment. They did one for dengue fever, and a lot of them will come. We can rely on this. But as part of the recommendation, it is high time. Ministers of Health, they need to establish a travel health unit or a travel health committee. They do this risk assessment. Then the travel health clinic, the infectious disease specialists outside and inside the country, they can rely on this. With WHO, we'll do a regional assessment. And I put like different questions concerning what are services, what are guidelines, methodologies used to do risk assessment. Is this published, the risk assessment? Because in the end, it's quite obvious, ministers of health, they need to put this guideline. Only country, this is as far as I know, Oman, they are doing this in the website, in the ministry. They have such kind of guidance, how to do with travelers, what are the risk assessment, how to do this, how to notify. It is a system. Travel health right now, it became a system. At the Minister of Health, countries, they need to have a working group with different specialties. The risk assessment itself, it has to be evidence-based, and it has to be well circulated. They need to have a feedback of travel health clinics, and also the travelers at the Minister of Health, they need to have a hotline. The Ministry of Foreign Affairs, they have a hotline, they have also a guidance. This is what we know from literature and from the best practice. It is a system, it is a program. We have most of the foundations, fortunately. Point of entry is part of the component of the program. We have a lot of awareness, vaccines, vaccination guidelines. We have the ingredients, we have the component, but it is high time the Minister of Health, they need to sit and do a situation assessment at their country, and then they can establish what we call a travel health program at national level.
I have one question for Dr. Saif, please. For ports of entry, for IHR implementation, usually there is the minimum requirements by WHO for functioning. What we have noticed during the COVID-19, countries went to the maximum and even beyond the requirements by WHO IHR 2005 core capacities. But after the COVID, after the pandemic, many countries, I would say not all countries, many countries went down to the previous low requirements and even below what is required. And this is, I think, a challenge that we need to elaborate and find solutions for it, please. Thank you.
Thank you very much, Dr. Mohammed. I think this is an important point for discussion, and it's important for countries to take along. Because what we have seen during COVID is that it was whole of government and whole of society approach. And where, for example, it was beyond the Minister of Health. And so there were national committees in most of the countries. And it's like an order, so people will do. And despite that, there were challenges. Most of the challenges at the ports of entry, the way I look at it, I mean, I used to have the ports of entry under my control. Like, you are not playing new ground. It's under you, but these ports of entry are not under you. They are under companies which they want to gain money. Like, yes, it's not for profit, but I mean, I remember in one of the boards, they say, we will lease you the place if you are going to use places, because airports and seaports, or ports in general, are not designed with the mind of ports of entry, or with design of the requirements of IHR. And I think this is one of the major lessons now, that when, and in fact, even IMRO started this, like health in all policies, that whatever policy we have, we need to have health in it. So now we discover that, I remember when, like in 2014, we have the Muscat International Airport, which was just to launch, and we were really thinking more about the clinic and the negative pressure rooms. It was around the Ebola time. But then we didn't recognize that we need other services out of the, we need services at the migration, we need services as the exit. So I think now we need to think about the, what we call flexibility and scalability of ports of entry. So it's very expensive to have all the services all the time functioning, but at least we should have the infrastructure, we should have the flexibility, and we should have the scalability, that in case something happens, we can jump in. And we shouldn't lose what we have gained during the COVID-19. So, thank you.
And maybe a last question, if you allow me, Dr. Waria. The mass gathering emergency medical teams proposal is really interesting, but I understand that it is mostly for planned mass gatherings such as Hajj or sport activities or others. What about the other side, the unplanned one, due to disasters, wars, and other emergencies? Thank you.
Thank you for your question. It's a really very important and very difficult question to answer because, of course, we can be very well prepared for a planned event. And even we are perfectly prepared, any kind of disasters, emergencies still can happen. It would be incredible burden on the health system, and its response could even be insufficient if we are really well prepared. And for spontaneous or unplanned events, of course, it all depends on the capacity of the country. And even one of the findings of the literature, I did not announce, you just asked the same idea of the researchers, that now the mass gathering event, it's not just the matter of the number of participants and the impact which can be caused to the hosts of to the host territory, to the host system of public health and medical care, but it's the matter of the ability of the system to respond if anything happens. So that's again about building sustainable capacities. No matter mass gatherings are planned on this system, it's the strength of the systems in general.
Thank you so much, Prof. Marie. I think you mentioned in your presentation very clearly that it's important to have some standardization in planning and preparedness for mass gatherings, with also some activities that the WHO is doing with CIMICs, simulation exercises in these areas. I think this would help countries to be prepared even for unplanned mass gatherings, as you just mentioned. Thank you so much. I don't know if they have any further questions. Otherwise, yeah, please, Dr. Saif.
Thank you, Dr. Sami. I have a question to Dr. Mubashir, but maybe for all of us. I mean, now he talked about the truffle health, and one of the major challenges in this part of the world is the expat population, like those who are visiting friends and relatives. And yes, for the locals, it's easy to provide truffle health service, but for expats, it's difficult because of the different health systems available, and also most of the, if not all of the health insurances, they don't cover the truffle health as such. I mean, yes, maybe they cover truffle insurance when they truffle, but before they leave. So this keeps me awake at night, like what can we do about this? Where we have, I mean, now in Oman, we have half of the population are expats, and then they come back, and when I practice, we see cases of malaria and other things, and we really feel it's not that useless. I mean, we can't do anything, but I think we need to think about it. How can we address this in the expat populations? It's not only for truffle health, it's all even for the for the global health and for the pandemics and epidemics. Like, for example, nowadays, yellow fever in Africa, even in Sudan. And we don't insist on yellow fever vaccine. So I don't know whether you have thought about it and others have thought about it.
Thank you so much, Dr. Saif. This is, to answer this question, I guess we need a conference like this. So it is a huge problem. It is one of the determinants of the public health in the region, dealing with expat. So first of all, we need to do a situation assessment, what we have in terms of health system, as well as what are the risks coming from outside. It is a huge exercise. We need to see, I mean, like, what is happening outside, what is happening in Nigeria, what is happening in India. So what we call it global surveillance. In addition to this, part of it, the capacity building. I mean, like, I know a very sad story. When from Europe, he came in the transit, he was very high fever, but no one asked about, like, history of malaria. He died because of fast malaria. It took a long time, and there's a lot of people that are coming from outside with diseases. So we need to do a situation assessment, and then based on the situation assessment, we will have what we call the priorities. One of the priorities is like to have a worker health or a travel health unit at the Ministry of Health. In addition to this, we need to adapt the surveillance system at our ministries to take care of those foreigners, our expat people. In addition to this, we need to train our physicians to be ready with those travel-related infectious disease So Dr. Saif, this is a very complicated problem. It needs technical working groups. It needs to learn from best practices of the world, what they are doing. And also, it needs research, because in the end, with the research, you can have the evidence, what kind of risk. This is my answer, and I will be more than happy to discuss this further. And also, we need our institutions. We have right now the Gulf CDC, we have a lot of institutions. It is not the Minister of Health, the responsibility, by the way. This is from my best practice, or from the practice right now is available. The Minister of Interior, they play major part. The Minister of Foreign Affairs, as part of the best practice, they have a department taking care of travels. So they are part of the international surveillance, what is happening outside, and then they can also be part of the risk assessment. So I wish I managed to answer. Thank you.
Thank you, Dr. Mubashir. And I think we came to the end of the session. I want to thank all the speakers, and thanks to the organizers for giving us the chance, all of us, to be part of this. And thank you all for listening and participating. Thanks so much.
Thank you, our valued guest speaker and our esteemed moderators. If you allow us to have a group photo, please. باقي about pandemic preparedness lesson learned, we would like to welcome our distinguished moderator, Dr. Mahmoud Khan. Dr. Mahmoud Khan is the Chief Executive Officer of Evolution Foundation. Dr. Mahmoud Khan's distinguished career has included several senior corporate roles, including Vice Chairman and the Chief Scientific Officer of Global Research Development at PepsiCo and the President of Global Research and Development at Takeda Pharmaceutical. Before moving into the private sector, Dr. Khan was a faculty member in endocrinology at the Mayo Clinic and Mayo Medical School, where he served as director of the Diabetes, Endocrine, and Nutritional Trial Units. He also led the program in diabetes, endocrinology, metabolism, and nutrition in Minneapolis. Dr. Khan, he is a member of the board of director of Reckitt Benckiser and of the Saudi Research Development and Innovation Authority. He is Executive Chairman of the Life Bioscience, a member of the Saudi National Biotechnology Steering Committee, and the Chairman of the Visiting Committee on Advanced Technology of the United States National Institute of Standards and Technology. Dr. Khan earned his medical degree from the University of Liverpool, completed a fellowship in endocrinology and nutrition at the University of Minnesota, Minneapolis. He is a fellow of the Royal College of Physicians in London, a fellow of the American College of Endocrinology, and an elected fellow in the Department of Pharmacology at University of Oxford. Welcome, Dr. Khan, and the floor is yours.
Well, good afternoon. It sounds like, Assalamu alaikum. My goal is to, I think, end the session today, and apologies for things running a little bit late. I know that Professor Maria has a hard stop, so I'm going to be as efficient as possible. I am not an epidemiologist, not an infectious disease expert in any way. My claim to moderating today is I have an interest, academic interest and business interest in geroscience and aging biology. And one thing that COVID taught us is that the world was shut down primarily because of the very high mortality rate amongst people of older age, which made up this largest part. And so we have a big interest in trying to understand pandemics and the impact on aging populations around the world. We have 3 world experts, all of whom have served on the Science Advisory Panel for this meeting. For a variety of reasons, could not travel. So, but technology is working, so I'm delighted. I'm going to first ask our 3 panelists to just briefly introduce themselves, and we'll go right into the questions. So perhaps we start first with Professor Jennifer.
Thank you so much. I am really very pleased to be part of this conversation. Really, thank you so much to the organizers for what has been really fascinating conversation. I'm glad to chime in and hear a bit of the last session. You know, I think COVID has really changed the whole field of pandemic preparedness. You know, many of us who've been working on these topics for decades went into the pandemic with certain assumptions, and many of the assumptions, I think, have been upended by what we have seen played out across the globe. And so I think it's really important that we take a hard look at what we have assumed to be the case in terms of pandemic preparedness, and perhaps really rethink some of our plans. I think there's some things that are abundantly clear, though, is that there is something inherently different about responding to an event when all of the world, or nearly all of the world, or multiple areas of the world is infected at once or affected at once. What that means is that it's unfortunately time and time again, we see every country for itself in many ways, in part because whatever global resources we have are quite limited, and there's going to be a lot of international competition for them. And so while we have to work for a coordinated and a collaborative approach, what is utterly essential is that we have strong national capacities, because that is going to be the foundation on which we have to base our response. And unfortunately, I think what we have learned throughout this pandemic is that national capacities remain insufficient for day-to-day threats, much less possibly once in a century or possibly increasingly occurring events like global pandemics. There had been some kind of dialogue early in the pandemic, looking at what we had previously assumed to be better prepared countries, and seeing them as perhaps not doing as well as we would have expected. And there has been an unfortunate attempt to extrapolate from that, perhaps a observation that maybe preparedness doesn't matter. That's fundamentally untrue. And part of the problem is that we don't have great ways of tracking these pandemics in real time such that we can compare truthfully countries to each other, because national statistics are different, and countries' abilities to collect and tally national statistics are dependent on the level of capacities that they have. And so this is going to be the challenge going forward. But I think if we have any a fundamental lesson from COVID-19 is that national capacities are essential. The corollary to that is that the globe is only as prepared as the weakest level of preparedness. And so that's where the call for kind of global coordination and global collaboration is essential, because you may be prepared as an individual country, but unless we are able to help other parts of the world make sure that they are equally as prepared, we are seeing play out in real time that none of us can truly relax or be considered secure or safe until that happens. So I'll pause there and let others chime in.
So let me, given I know, Dr. Maria, you have a hard stop, and I'm going to ask you to introduce yourself briefly, but then also build on what Professor Jennifer just said, because as we discussed yesterday, the U.S. National Academy of Medicine wrote a global roadmap report on pandemics more than a decade ago. Unfortunately, including the U.S., not much action was taken in relative to the request. The second thing I hear from every dean of School of Public Health that I ever talk to is, in the U.S., for example, the funding for public health academic departments and government public health departments has not only relatively fallen, but has fallen in absolute terms across most developed countries, let alone developing. So where's the gap? What have we missed between what academics and learned organizations have been saying versus it being translated to action? And how do we learn from this moving forward? Now that we sort of come out of COVID, do we just sit on the sideline waiting for the next time and everybody bangs the drums again? Or are we going to be different? I'd love to hear both from yourself and Professor Annelies. I know you've been thinking about this, but this is about action, not just more publications. Dr. Maria.
Yeah, thanks so much. So my name is Maria Van Kerkhove. I'm from the World Health Organization, sitting here in a very rainy Geneva, which you might hear the rain behind me. So sorry for that. And I'm sorry that I'm not there in person. I was happy to listen to the last panel and see so many colleagues that I've worked so closely with over the last 10 plus years on MERS in particular. I currently lead our work on emerging diseases and zoonoses at the headquarters level. And as of Wednesday, I will be the interim director for epidemic and pandemic prevention and preparedness, leading a large group of individuals who are working on high threat pathogens, everything from influenza to plague to COVID to arboviruses to orthopox viruses, and looking at pandemic preparedness. And completely agree. Many of us have been working in this field for decades and have been screaming into the wind, if you will, on the importance of pandemic preparedness, which is still the same. The key message for us is that pandemic preparedness and prevention is a constant. We live in a world of cycles of panic and neglect, which include funding cycles. But for those of us who are in this field, this is something that's a constant. If we do our jobs well, you don't hear about it. You don't hear about those spillover events that become outbreaks, that those outbreaks don't become epidemics and pandemics. So it's a constant. And I think, your comment about the difference between academics or discussion versus action. I work for the World Health Organization, and our mandate is to keep the world safe, protect the vulnerable, and to prevent these events from happening where we can and where we can't, to mitigate them to the best of our ability. COVID taught us so many things. We don't have enough time to go into even a fraction of what it has and continues to teach us. But on the funding side, there needs to be more consistent funding and accountability for that funding. Let's be clear, there's a lot of money that was spent on COVID. There's a lot of money that has been unspent for COVID. And we need to discuss that. One of the things we're trying to do right now is that while the emergency of COVID is over, the threat is not. And the capacities that have been built for COVID over the last 3.5 years are capacities that need to be sustained for all future threats that we face, including variants of SARS-CoV-2. We're not expecting the world to keep up the same level that they did during the peak of the pandemic, but the capacities for surveillance, for risk communication, for community engagement, for scientific collaboration, for vaccine development and platforms, you name it. All of those capacities are important for the current threats that we face, the known ones, and for the next disease X. And COVID-19 was disease X. And the next one is absolutely out there. And so that's what we're trying to do. So the world is moving on. People are moving on. We understand that. Governments cannot. And that's what we're doing as an organization, supporting our member states through our regional offices and country offices, and show that what they have done through blood, sweat, and tears is important, needs to be maintained, but it needs to be financed. So this is beyond health. This is about making political commitments. And remember, these pandemics outlive any political cycle that we see. So the commitments that we have need to be much longer than the promises of elected officials. This is why we have things like these high-level political statements coming from UNGA in September. This is why member states right now are discussing the pandemic accord. So there's a lot of work in this area. I'll stop there because I could keep going on, but financing is absolutely critical, as well as political commitment, in addition to all of the health specificities needed for pandemic prevention and preparedness, readiness, and response.
So excellent. And, you know, clearly, obviously, we don't stay at this crisis level, but coming from a background of drug development and pharmacology, you know, we say in drug safety, when the drug safety team does their job, nobody hears about it. And so it's those silent heroes in the background in my field, the same in public health. When nothing happens, it sort of is assumed that you don't need to take care of it. And yet, crises teach us that when you let your guard down and your systems are depleted, then there are consequences. So how do we balance that awareness without creating, you know, sounding like you're just crying wolf? So Professor Annelies, love to hear you build from your experience, your thoughts on this balancing the need for preparedness and what we learned from this most recent pandemic, and unfortunately probably not the last one.
Well, thank you, and sorry for not being there in person. I would have loved to be there. So I'm the team lead at WHO for vaccine development, and during the entire pandemic, I was the SAGE working group focal point to formulate policy recommendations for all the COVID-19 vaccines for which WHO had an emergency use listing. So we did rigorous reviews of all the evidence for all the EUL vaccines. The question now is, how do we move on from this? And as you know, preparedness needs to be done during peacetime. And this is where we should not slack. And it is a very interdisciplinary, coordinated, cross-cutting approach that includes ensuring that global manufacturing capacity building, and better regional representation continues to occur. That we need to improve on global disease surveillance. We really need to have a global clinical trial network in place, so that when the next pathogen comes out, we are quick, have addressed the regulatory bottlenecks, the ethical issues, have a template, a clinical trial protocol, we can go into the next trial. Also the global, and we always neglect that, global diagnostic reference centers and networks, and also the creation of vaccine prototypes. As you know, CEPI has announced that they want to reduce the time from pathogen isolation to going into vaccine to 100 days. That does not mean cutting corners. It means if you're better prepared, you can go with parallel structures, which have all been proven to work quickly, and practice that with countries. So I think what we now need to do is to ensure that all countries are involved in this process, because, as already said earlier on, it is always the weakest link that will slow down pandemic response.
Thank you. Maybe building on this and changing slight direction in terms of learnings to Dr. Maria. You know, one of the things that deservedly so, leadership and the entire health system in the Kingdom of Saudi Arabia is proud of is their ability to implement testing, vaccination protocols, and digitizing the monitoring and delivery very rapidly, and from firsthand observation, some of the best deployment of technology that I've seen having traveled around the world, actually even during the pandemic. I must have traveled to at least a dozen countries during the pandemic and have that experience. And certainly something we can learn in the US. We did not do a very good job by any criteria in the US in terms of deploying. By the way, Professor Jennifer, I live in Connecticut and was co-leading the Connecticut task force around testing in the state of Connecticut and Rhode Island. So just from that experience, we have a lot to learn. But the kingdom has been thinking about risk of large exposures, given the decades of experience with the Hajj and the pilgrimage, unprecedented numbers of people coming together. I know you've been thinking about this. I'd love your thoughts on what are the lessons learned from the Hajj experience, the kingdom's most recent experience, and how do we share that learning and build on it for the benefit of all?
Yeah, thanks for that question. And I'm happy that I had the opportunity to listen to the panel just before ours, because I know one of my colleagues, Maria, was on the panel there, plus a number of individuals I've been working with for quite a long time. I mean, the kingdom has a lot of experience with infectious diseases and managing them, and particularly with MERS coronavirus over the last 10 years and holding the safe events. So high visibility events like Hajj receive a lot of attention, but we, through our regional office, through our country office there, have been supporting the kingdom in holding safe mass gathering events for many, many years. And I know you talked about a lot of that in the last panel, but it is about it's about planning. The risk-based approach that WHO uses, looking at risk evaluation, risk mitigation, risk communication, takes into consideration all of the different elements of any gathering, whether it's a mass gathering event like Hajj, which is so specific, or it's a backyard barbecue. And during COVID, what we saw was any opportunity where people gather, this virus took advantage of. But what we have seen with successful planning, with successful engagement, and a lot of wide consultation with all of the relevant stakeholders, is that planning, if planning is done well, if there are measures that are put in place, that gatherings can take place as safely as possible. There's no zero risk. We know that with any pathogen. But we do know that with planning for these high visibility events like Hajj, like Tokyo 2020, Beijing 2022, Euro 2020, the World Cup recently in Qatar, that working together on this, these events can take place. So I'm deeply indebted to my colleagues from EMRO and through the country office, who I know are there right now, and I wish I could be with you, supporting the kingdom in the safe planning of this. It takes time, it takes planning, you learn from every single event. I would push the question right back to the kingdom to say, with each successful Hajj that you have, what else have you learned? Because I would imagine that each one is slightly different. Certainly we've seen the different profile of individuals attending Hajj. A lot of the individuals are older age, have underlying conditions, but there was a slight shift during the pandemic itself when Hajj actually did take place. But we saw that it can happen. So I think with successful planning, with engagement, that we can really do quite a lot during these high threat events like COVID and like the next one that we face. But again, it's not just COVID that we were worried about. There's all these other infectious diseases that continue to circulate on the globe. And remember, people have not received the care that they've needed for their underlying conditions over the last 3-4 years. And so a lot of these underlying conditions that people have are exacerbated. And so the risks for other circulating pathogens become even more threatening.
Thank you. Professor Jennifer, one of the, I'll come to you in just 1 minute, Professor Annalise. One of the tenets of the Hajj and Islam is all pilgrims are equal. In fact, that's why they're in a dress and present in the ihram, right? Everybody's equal. But then this raises the question about equity and inclusiveness. I know this is something that all of you have been thinking about, because one thing about pandemics is that unless you think about inclusiveness and equity, not only can you not manage the pandemic, But developed countries learn that you need to support developing countries, the less well-off countries, in order to address it. What are the learnings, and how do we think about this? And perhaps, Professor Annelies, I'll come to you with that question and any other comments. But start with Professor Jennifer.
Yeah, thank you for that. It's a really important question. I mean, I think, first of all, the vision for the future is this, that there will increasingly be these sort of no-notice events that have the potential to upend our lives. And what we need to do is to build resilience for those sorts of events such that we don't allow them to just simply wash over us and put our lives on hold in the way that COVID-19 did. And so we have to prepare for these events by building day-to-day capacities. And I like what Dr. Venkarkov said, described it as sort of a steady state of readiness. I think having mass gathering events offers important opportunities to exercise and develop infrastructure that can be ready to snap into action anytime there's a potential emergency. And so because of the need to plan for these mass gathering events, really important accomplishments in terms of early warning detection systems, surveillance systems, global communication systems, exercising communication plans, et cetera. Lots of great exercises. I make a lot of references to thinking about getting prepared for pandemics and thinking about how we get prepared for fires. And so if you think of events like Hajj and Umrah, that they are important exercises for other future events, and we build in capacity to be ready for these things. But the equity piece that you brought up is, as I said in my opening comments, that the pandemic really underscored, I think, the need to rethink preparedness in a lot of ways. And one of the things that COVID deeply demonstrated is that we can't leave inequities to just simply be an afterthought. Really, we need to center our pandemic preparedness efforts on making sure we are being equitable in our approaches, and also making sure we center them on what our greatest vulnerabilities are. So thinking of the populations that are socially at risk, medically at risk, economically at risk, that should actually be the center of our preparedness activities, rather than what I think it's been for many decades, which is we know it's important, but it goes on a long list of things that we hope to have time to get to. We can't just prepare for the best prepared, which is what we saw happen a lot in the pandemic, where people with the greatest social advantages had much greater opportunities to protect themselves. So making sure we have a response that's equitable is not only the morally right thing to do, but it is the pragmatic thing to do if we are truly to protect ourselves.
So I know, Dr. Maria, you have to jump off. So we understand, we're learning a few minutes. So I'll ask Professor Annelies to comment, and then I'm going to open it up to any questions in the last 5 minutes to our audience. So Professor Annelies.
Well, to prevent importation during the Hajj, amplification at the Hajj, and then dissemination upon return, the best strategy is to increase vaccination coverage against existing diseases using existing vaccines in those countries. And I do believe that Saudi Arabia has an extraordinary role to play, especially in the Muslim world. There are 1.8 billion Muslims worldwide. There are 50 Muslim majority countries. Many of those countries still face meningitis outbreaks and polio outbreaks. And I believe that Saudi Arabia, the kingdom here, would be particularly well suited to address the need for effective resource mobilization, to help those countries implement national plans, to coordinate advocacy, to ensure equitable access, and really give the opportunity and support. And as you are aware, there is major defeating meningitis initiative going from WHO, and I'm very, very pleased to say and to see that Saudi Arabia is one of the member states that promoted the resolution on defeating meningitis by 2030. And they also nominated a member to the strategy support group. And I think that ongoing political and financial and role model that Saudi Arabia could have is important. And for those who may not know, during the last SAGE meeting at WHO, which was just in September, a new multivalent, a pentavalent, in fact, meningococcal conjugate vaccine was recommended to be introduced in the entire African meningitis belt, and a large part of those are Muslim countries. And I think helping these countries to literally introduce this into their routine immunization programs and into their campaigns is of paramount importance.
Thank you. So before I ask my last question, I'm just going to check any questions from our audience. Well, while people are thinking, maybe I'll ask you to put a crystal ball, take a crystal ball in 1 minute each. If you were to look 5 years from now, maybe 10 years from now, and you could have access to what you think are the most exciting technologies other than vaccination of either monitoring, diagnostics, or other technologies to prevent the spread, other than vaccination, to prevent the spread of biological agents that result in pandemics, what would you predict in your crystal ball? Professor Jennifer?
So I am really remiss to ever put my eggs in one basket. Sorry for the idiom there, but to say there is never going to be one single technology that will do it all. And I have to stress that because sometimes we like a shiny object and then sort of pin all of our hopes onto that. The truth is we are always going to need multiple approaches. That said, if I had to pick where I would like to see more investment and research to make sure we have more options, I would be looking more at the diagnostics approach. And so one is that we saw during COVID-19 the rising importance of environmental monitoring, particularly wastewater surveillance. I think that's going to be really important going forward, particularly for thinking about how we conduct surveillance for disease X. So how do we look for things that we don't yet know is going to happen? And increasingly we're being pushed to need to do that, or to monitor to determine if something is already circulating that we might not see yet clinically in the signals that we have. So I think we need to do more work in order to better understand how to maximize the potential of wastewater surveillance. It's not going to fully replace public health surveillance and clinical surveillance by any means, but I think it's an important complement that we need to continue to invest in and conduct research to better understand how to utilize. But I would also like to see improved availability of diagnostic tests, and crucially, I think we saw during COVID the importance of having rapid point of care or point of need diagnostic tests. New technologies will allow us to test for multiple things at once. We need to pair those technologies with a strategy for understanding how we are going to make sure they contribute optimally to surveillance, how we are going to use them and adjudicate sensitivity and specificity issues. We need policies that accompany the use of any of these technologies, but I think those areas are particularly important. And then if I had to pick a third one, obviously we saw increasingly important indoor air quality and making sure we have adequate ventilation and filtration to help clean indoor air so that we don't have super spreading events.
Thank you. Professor Walter-Smith.
AI technology, we failed in very simple shoestring contact tracing, which would have really, if we had done very good contact tracing, we would not have needed to do these very painful lockdowns. I think AI technology needs to be improved as an additional tool in public health. And the second is we really need to get better in immune correlates so that we don't need to have all these clinical phase 3 efficacy trials with clinical endpoints, but can use immune correlate endpoints instead that would accelerate vaccine development. Over.
So let me, thank you very much. Let me summarize a few brief points in terms of the learnings. On the positive side, the pace at which The viral pathogen for COVID was identified, sequenced, open sourced, and allowed the world to collaborate to find, not only develop vaccine, but testing. All of these were just amazing, and allowing a regulatory framework to parallel process and get a vaccine developed based on existing technology. I want to remind that the technology took 10 years to develop and about 12 months to apply and deploy, which then emphasizes the need for ongoing investment, preparedness, collaboration, coordination. Many of those lessons we knew about, but were brought to bear, and we could have done better, and we need to think about how to not become complacent, but keep moving forward. We need to think about equity, access. Pandemics are, by definition, global and don't discriminate between individuals in terms of race, religion, geography, or any other criteria you want to pick up. Having said that, there's going to be an ongoing debate between individual freedoms versus what's in the benefit of the public good. I think this has always been an ongoing challenge, and different countries looked at deploying with different interpretations. And maybe this is a time to really be thinking about those complex issues beforehand. Leveraging experiences from around the world, the Hajj, the Kingdom's experience, as well as many other countries around the world and what they did, which worked better. One thing we learned about COVID, that no one country had all the answers. So a very clear message to get the best ideas at the table, and sometimes systems like the US, the most developed countries and parts of Europe, unfortunately had some of the highest mortality rates and raised some questions around healthcare system preparedness. In many countries, we depleted healthcare systems right down to the bare minimum in light of efficiency, but there was a price to be paid when a crisis happened. Thank you very much, Professor Jennifer, Professor Annalise. We appreciate it. Thank you to our organizers, to our audience. With that, we'll hand over back to our organizers. Thank you very much.
Ladies and gentlemen, with this, we reach the conclusion of the second day. Thank you for attention and see you tomorrow.